EPG quiz. So I'll request our experts to take their chairs on stage. Dr. Shomu, Dr. Vivek, last Dr. Kush also to come forward because he is going to handle this quiz. And he will tell you the terms and conditions of quiz. One request, everybody who wants to participate in the quiz, please come in the first 2 rows. आप चेंज कर लीजिए और जो पहली 2 रोज हैं इसमें शिफ्ट हो जाइए, स्टूडेंट्स इन पर्टिकुलर. You can come ahead. We cannot see if somebody is raising his hand from behind, so I would request students to come ahead. आपका ही जमाना है भाई, आने वाला टाइम इज योर्स. आगे आ जाओ, नहीं आना चाह रहे थे. Anyway, okay, so I'll request Kush to come here and start the quiz before losing more time.
Thank you so much, sir. A very warm good afternoon to all of you. So before starting the ECG quiz, so there are a few instructions. I think all of you have that ARS with you, and there are 4 options, 1, 2, 3, 4 for every ECG quiz. So I have options A, B, C, D, which corresponds to 1, 2, 3, 4 on your ARS. Please press the button only after the music stops and press OK. Sorry, music starts. When the music starts, press the option and press OK with it. And one more thing that, it's not that we, I mean, the timing is also very important. The one who will answer the question fast, he will be given priority. So you will have 30 seconds for each ECG. So all the ECGs are very easy, not very difficult. And our experts are there, Dr. Makkar, Dr. Vivek, Dr. Shomu is there. So it will be definitely a very interactive session. And there are interesting prizes as well. So there are 20 students who are just waiting outside. I'll just wait for 1 or 2 minutes before they come. So,
okay, one important thing is that this quiz we have kept for MD physicians and MD students. I could see some cardiologists smiling. So I'm announcing this, that this quiz is not for you. Okay. So anyway, if you want to participate, you can. But once the results are declared, we'll find out who is cardiologist and who is physician. And cheating is not allowed. Use your own mind. So hide your, just like you do in the ATM booth, hide your number pad when you are dialing it.
So you will have 30 seconds for each question and you have to answer only when the music starts. So let's start the quiz, sir. I think students are there if I'm not wrong. Can I start the quiz? Okay, okay. So all of you have ARS with you? Is there anyone who don't have ARS? Please give him. Please answer only when the music starts and press OK with your answer. Done? So let's start. Let's start. So this is the first case. So he's a 50 years old patient with sudden onset tachycardia. So these are the options. I'll show you the ECG first. This is the ECG. 50 years old patient with sudden onset palpitation. And this is the ECG. These are the options. And your time starts now. Just a moment. Yeah. So you can start voting now. Where is the timer? Can we see the results? So, sir, most of the people have answered it as D, AVNRT with LBBB. So this is 1, 2, 3, 4, and most of the students have answered that as D, AVNRT with LBBB.
Anybody who is voted for AVNRT, LBBB wants to defend, just we can have quick comment. If somebody wants to comment on it.
Anyone want to explain what is going on in this ECG?
Okay, we can refer to our experts.
I just
who agrees
the
it to be
correct answer.
ventricular tachycardia? That's what. So first of all, is it ventricular tachycardia? Is there? So you apply those Brugada criteria and you say that there is no ventricular tachycardia based on the Brugada criteria, no AV dissociation. So once ventricular tachycardia is out, you have the T differential. Now you have to see where is the P wave. P wave is present or not, and which is the best lead where to see the P wave. Which is the best lead to see the P wave? Lead 2 and V1, right? So here see the lead 2, the rhythm strip. What do you see? Is the P wave present or absent? And I think Kush is marking it also. You have 2 P waves seen, but is there a P wave in between or not? That is also you have to see. And with a rate of 150 rate, what do you think? Why should a rate be 150? It is either atrial flutter, sinus tachycardia, or it is classical SVT with aberrancy, like AVNRT with aberrancy. But now you see P waves, so AVNRT is less likely. See the P wave morphology, and if you find a P wave which is double that of the QRS, it is likely to be flutter or atrial tachycardia with 2 to 1. You can never be sure, however, because this is LBBB. So therefore, what you want to do is, the next step, what do you want to do is, to bring out, give carotid sinus massage or give adenosine, right? If the patient is otherwise stable, you can give adenosine or do carotid sinus massage. And if it causes the P waves to come out, stops the ventricular rate for some time, you'll be able to see flutter or atrial tachycardia, but it will terminate an SVT with aberrancy like AVRT or AVR, right? So that is how you approach this.
Perfect.
I think Dr. Shomu has beautifully pointed out a couple of things I wanted you to see. First of all, it's a wide QRS tachycardia, but why not PT? Why not PT? Can somebody explain? Okay, so the basic rule of looking at this kind of regular tachycardia is that if it conforms to the character of a typical bundle branch block, then you must start thinking in terms of HPT. So in a typical left bundle branch block, because the initial conduction is still through the fascicles and not through myocardium, so the initial conduction is always faster. You look at lead V1 or V2, V3, you can see that the initial depolarization of the ECG QRS is quite rapid. And that suggests that this may not be myocardial. The other thing about flutter is that because if it comes at the rate of 150 or 2:1 block, the hallmark is that you see some kind of a P-wave summation right in the middle of the thing. Can you show that, please? Yeah, just in the middle, always in the middle, which should always make you suspect that this is a flutter. And additionally, what you will see is, if you look carefully at the end of QRS, look at the last 4-5 complexes. You see there is some slurring, then it goes, then it comes back again. So there is some P wave or a flutter activity which is hiding in this QRS, which is distorting. So whenever you see the QRS initial part or later part getting distorted, one must always think of AV dissociation.
So the answer is B, atrial flutter with left middle branch block. And take home message is whenever the rate is 150 beats per minute, then you should always think of flutter. Should look for flutter waves. This is the crux. So coming to the next question. So again, he's a 50 years old patient with sudden onset tachycardia. This is the ECG, and these are the options. 50 years old male with tachycardia. So you can see there. Okay. So let's start. So the time starts now. Okay. Most of the students have answered SVT with aberrant conduction. Anyone would like to explain? So this is an interactive session. Anyone would like to explain? So do we have mic? Where's the mic? So can you give the mic to Dr. Gunjan? So please, you would like to explain? Please give the mic.
Good afternoon. First, the rate is not regular. There is irregularity in the rhythm. If we see the intermittent complexes, then here in lead 2, there is increased RR interval. So might be there is maybe a fusion beat may be there. It's not clear from here, but
you mean to say there are fusion beats in this ECG?
Yeah.
So the rhythm is irregular. That is perfectly fine. Definitely the rhythm is irregular. We can see the distance between these two QRS and these two QRS is different. No doubt the rhythm is irregular. And you mean to say you can see fusion beats?
Yeah.
So which beat seems to be fusion beat? Please see lead.
Here, that if we come in this second complex of V1, V2, V3, right there in long lead.
Anyone else? So back to you. So, sir rightly said it's irregular. The QRS, definitely the RR interval is irregular. and the morphology is left bundle branch morphology. But
Can you see P waves? The question is simple. Even if it is irregular, that doesn't mean that it is AF. If you can see P waves, then it cannot be AF, right? Can you see P waves is the question now. Can you point out if there are P waves?
no.
So if there are no P waves, then it becomes atrial fibrillation. What is there in lead 2? Can you see lead 2 long rhythm strip? Something is changing, means the initial complex part, you can see there is a changing morphology of the initial part of the QRS complex. So it is within the QRS or not, that you have to see. It looks within the initial QRS. So if there is a change in the QRS, initial QRS, and it is not the same, then either it is SVT with aberrancy or WPW if there is no PVC. So what do you feel?
With AF, atrial fibrillation, no P waves, irregular RR interval.
Yeah, AF with SVT with aberrancy or WPW. So that is what I was asking.
The only option, we have given this AF, VT, WPW.
No, but this is a discussion. So
okay, fine. So, definitely, so I think it's, I would go for AF with aberrancy.
Okay, so can someone point out what is against aberrancy?
Actually, one more thing is there. So patient had extremely wide QRS with left bundle branch morphology, and actually he was under drug effect of hyperkalemia as well. So that's why it's not typical left bundle branch block.
Yes, so it is not typical. You don't see that typical R wave in V6, but that can happen actually in a disease heart.
Exactly.
Somebody who is a technician will just 1, 2, 3, 4, 5, 6. The LV is actually lying here. So this is very common, but look again at the initial part in V1, V2, V3.
Rapid.
Okay. So, and why isn't it WPW with aberrant conduction? The reason is that it should correspond to some known location of a WPW. If you look at from V1 to V6, there is hardly any progression. It doesn't correspond to any, typically with 2, 3 AVF being negative, you would think that somewhere near posterior wall it should be there, but then there should be some transition happening, which is not happening. This is AF, and in all likelihood, this is not rate-related aberrancy. With such wide QRS, this must be an underlying. Already, the person has a bundle branch block.
The notched QRS complex, you have possible features of scar also.
Scarred myocardium can also
If it was AF with pre-excitation, you had seen a lot of QRS complexes of different morphology, and narrow QRS is also intermittent and looks like more ventricular flutter or fibrillation kind or polymorphic VT kind of thing.
So coming to the third question. So it's a relatively easier one. So 36 years old male presents to the emergency room with chest pain. And so this was the ECG which was recorded in the emergency. So 36 years old male presented in emergency with severe chest pain and with 1 hour duration of chest pain. And these are the 4 options. So I already told that it's a relatively easier one. Yeah. So anyone would like to explain? Anyone? Yeah, why? Please give mic to Dr. Yatandar.
The PR depression.
Very
and
true.
In the AVR, it is opposite.
Exactly. Very true. So I think, sir, let's move to the next ECG, more interesting one. Please make sure we have the options first, not the answer. So she's a 42 years old male or female patient with sudden onset dyspnea. So what is going on in this ECG? Yeah. So these are the options. A female with sudden onset dyspnea. Pulmonary embolism. So I think most of them got it right. Anyone would like to explain? Anyone would like to explain? Please give mic to Gunjan.
Firstly, there is the history of sudden onset dyspnea in a female, and the ECG showing sinus tachycardia, RBBB morphology, and a specific S1Q3T3 pattern in the ECG, which is highly suggestive of pulmonary embolism. So two things, sinus tachycardia, RBBB, and S1Q3T3.
Any comments, sir? These were relatively easier ECG. Coming to the next ECG.
Sir, it is not that common. Sinus tachycardia is the most common arrhythmia in pulmonary embolism, but it is a quite specific finding in the ECG.
I think you beautifully analyzed this whole scenario.
Thank you.
Coming to the next. So he's a 40 years old male with history of giddiness since last 3 years. 40 years old patient with history of giddiness since last 3 years. So this is the ECG of that patient. And these are the options. Patient with history of giddiness. Time starts now. So I think we are going to have a lot of people who maybe with common with maybe a lot of winners will be there because this is right Osarts. Again, anybody like to explain? Anyone? Most of them have got right answer.
Anybody who has answered rightly can stand and try to explain. This is just an interactive session. Don't worry too much about
Says everybody knows, I suppose.
Can it be an artifact? Rather, we can ask that.
So what are the additional features you are looking in the QRS complex to say it is torsade? That is very important, right? So what do you find in a QRS complex in sinus rhythm to say that this is likely torsade? Is there a long QT? Is there T-wave alternance? Is there STT changes before? Do you find them? In fact, in the upper lead, you can see T-wave alternance. You can see T-wave is alternatingly changing. So when you have T-wave alternance like this, and you have a torsade, you have to think that this is likely to be more long QT related or something like that, causing this tachycardia.
Perfect, sir. There was a history of sudden cardiac arrest also in the family member and treated with beta blockers and endowment ICD implantation.
It's very important that long QT may not be there, right? Even if you measure long QT, it may not be there in the routine ECG. Just before the torsades, you may have a short, long, short, or you may have this T-wave alternance with even a normal QT. So don't always look on the QT only. And if it is not there, don't say it is not long QT. You have to also see the other things like the history.
And also it is important in these kind of cases to differentiate from an artifact. So if you can go back to that. So how would you differentiate an artifact? One thing is that sometimes there are 3 channels. If you see some activity in 2 channels and 1 channel is absolutely spared sinus rhythm, that is definitely an artifact. If it is present in all 3, then if you follow the RR interval, you will see a correlating QRS complex in the middle of that artifact. So if you keep on following that RR interval, on the same interval, you will find a spike of normal QRS, which is merged with the artifact. So that is the way how you differentiate.
Coming to the next question. So 60 years old gentleman with history of pre-syncope. And this was the ECG which was recorded. So there are 3 ECGs in there in this question. So probably you have to have a look at this ECG and then I'll move to the other ECG. 60 years old male with pre-syncope, and this was the ECG which was recorded. Now, patient was advised Holter monitoring, but he again had pre-syncope, and this was the ECG which was recorded the second time. Now I'm moving to the third. So he came to emergency and he was waiting, and while waiting he had seizure-like activity, and this ECG was recorded at that time when he had the seizure-like activity. Now, what the patient was having. These are the 4 options. So what will you do, this patient? Implantation. So anyone would like to explain what was happening to the patient? So this was the first ECG. This was the second. This was the first ECG, the second one, and the third one. So what was actually happening to the patient? Anyone would like to explain? Please give mic to Arif.
First, the patient has the RBB in the first ECG. Okay. And as it follows, it becomes the LBB, and then it becomes a trifascicular block. It's a CHB.
CHB. Yes. Trifascicular block, exactly, with CHB. Perfect.
If a patient has syncope without the last history, and if a patient has RBBB and another ECG which has LBBB, what would you do? If there was no CHB also, would you put in a pacemaker or not? So alternate bundle branch block with a history of syncope or even without history of syncope in such a patient should warrant a pacemaker implantation, because alternatingly the bundle branch is getting blocked. Sometimes it may be together also. So the patient may go into a CHB.
Yes. So we just go to the first slide. What typically is this? If you look at lead V1, and if you look at the axis in the frontal leads, the axis is a little bit rightward, and there is some right bundle branch block. It is not exactly right axis deviation, but it is a little bit rightward. Then we go to the next. Yeah. See, now the axis has changed and it has gone left, and there is a left bundle. So as Dr. Shomu was saying, there is alternating. This is enough to put a pacemaker. This is a recommendation. And then if you go to the last slide, now there is a complete heart block, but by rate, you may not suppose so. And the reason is simply because there is sinus tachycardia. And the escape rhythm is also a little bit, but if you look at lead 3 here, you see very nice T waves coming in and out, and so the diagnosis of complete heart block is established.
So can anyone tell how you identify trifascicular block in an ECG? Any student should answer this question. So one is this, if you see alternating, yeah.
Please get back to that. Wants to answer, I think. You want to answer the question? Yeah, please get mic.
Right bundle branch block plus either left anterior hemivesicular block or right posterior, and hemivesicular block plus prolonged PR interval, that is first degree AV block.
Exactly. So this is one manifestation. And I think the most unique, most diagnostic manifestation is alternating left bundle and right bundle, because the scenario which you explained, still the delay may be within the AV node, not down in the his bundle or bundle branches. Similar way, if there is LBBB with first degree AV block, it can be a trifascicular block, but still the delay may be in the AV node. PR interval is prolonged because of AV nodal delay. So this is the most pathognomonic manifestation of trifascicular block. With this kind of ECG, if somebody has syncope, as Dr. Shomu and Vivek said, no need to wait for a syncope to happen, or no need to wait for documentation of CHP, and straight away we should put a temporary pacemaker and then.
Important concept to remember is that per se, right bundle branch block does not cause any change in the axis. This is important to understand because you may get a right bundle branch block with the right posterior hemiblock, which will then cause the change. And the reason for that is because the total mass of RV is so less as compared to LV, that the right bundle branch block per se does not cause any change in the axis. So if you see a right axis deviation along with the right bundle branch block, you have to think of either a coexisting RPHP or then the congenital heart diseases, etc., which can cause RVH.
So coming to the next question. So he's a 37 years old male with sudden onset palpitation with normal hemodynamics, and there's no past medical history. Echo is normal. This is the ECG. So can we have the options? Yeah. This is the ECG. The time starts now. What is actually happening in the ECG? So I think most of students think that it's SVT with aberrancy and or antidromic AVRT.
Okay, just anybody, we just not talked about aberrancy. So can you please tell what should an aberrancy, what is the basic tenet of to call something an aberrancy? It has to follow the principles of aberrancy. So just now I said RBBP does not cause any deviation in the axis. What is the axis here? Can someone tell me the axis here in this patient? So all 2, 3 AVF are all predominantly negative. So the axis is top. So it's somewhere near the top. It is probably between, in probably the left quadrant topmost axis. Is this axis physiologically possible with the right bundle branch block? It's not possible, no? So then what does it leave us? Okay, now again, our old friend rhythm lead 2 comes to the rescue. So look at lead 2. And as I told you, you look at the starting, if you can't see figures clearly, look at the starting and the end of QRS, successive QRSs. And you can see that there is some distortion happening just before or after QRS. Can you appreciate that? So for example, look at after the fourth complex, look at the T wave, then look at the complex after that. So there is something happening in and out. And if you count this in and out, you would be able to actually say that this is a regular activity, which is happening at a less fast rate than the ventricular activity. That makes it a VA dissociation. And once you have VA dissociation, then what does it become?
So still it can be RVOT with VT. So we have made a diagnosis of VT. So how will you differentiate between a RVOT VT and a fascicular VT? Anyone? Sir has already told it's a VT. Anyone who could differentiate between RVOT VT and fascicular VT?
Outflow means what? Outflow means coming from superior, right? So the axis should be what? Outflow tract VT. Superior to inferior. So inferior axis 2-3 AVF should be positive in outflow tract VT. While this is left axis RBVP, classical of fascicular VT. Fascicular VT also there are 3 types. So this becomes a posterior fascicular kind of VT. There can be other kinds also.
The answer is fascicular VT.
No, many a times what happens is people will give Dilzem. Most of you have answered SVT with aberrancy. Yeah. Most of you would give IV, Diltiazem or Verapamil and it responds. The tachycardia terminates. And then you still label it as SVT with aberrancy and send the patient for ablation, and then the diagnosis suddenly is different as a VT. So that is a common scenario that we see. So if you have a RBBB, left axis deviation, tachycardia in a young patient with structurally normal heart, differential of fascicular VT should be high on the list.
The basic thing. The other thing is that the reason why all of you said SVT was because this looks quite narrow, right? And that is the hallmark of fascicular VT because it engages the fascicle. So most of the myocardium is depolarized to the normal conduction route, and that is quick depolarization, and that is why it looks quite narrow. Actually, they are not that narrow. If you go to calculate, it's something like 110, 120, but they look quite narrow as compared to a VT, and that is why this confusion arises. So what comes to our rescue is always looking at P waves and then looking at the axis and whether it is congruent with your bundle branch block pattern.
Next question. So he's a 86 years old male patient who had no heart disease, and ECG was recorded after a fall. So patient has a history of syncope or rather a fall, and this was the ECG which was recorded. 86 years old male patient with history of fall. These are the options. Typical atrial flutter, sinus AF, atypical atrial flutter. In an 86 years old male with history of fall. I think 0% voted for A. And most
all leads, can you see V6 maybe and V1? Just before the QRS, what do you see? Is there a P wave which is separate from those flutter wave. You cannot have a separate P wave and a flutter wave ongoing two rhythms together, right? Yeah, so lead 3 is very clear. It is only in certain leads that you have flutter. So can there be flutter in some leads and sinus rhythm in some leads? Is it possible? The heart is same. Na? So what you are finding is some leads have artifacts and some leads are showing the true picture, especially lead 3, V1 and V6, where you can see distinct P waves prior to the QRS complex. Very distinct P waves.
See, mostly
Signs.
artifacts present as either atrial flutter or polymorphic VT. So in both these situations, you should apply your mind and rule out artifact. Here again, the same principle, look at the corresponding leads, and if you see a sinus rhythm in one lead, trust that sinus rhythm, because that cannot be artifact. Flutter can be artifact. And probably this old man had Parkinsonism.
Yeah, actually. The patient had Parkinson's disease, and these are all
common in
artifacts.
Parkinson disease.
The answer is basically,
And maybe the reason of fall may be sick sinus, because he's having sinus bradycardia.
the answer is basically sinus rhythm.
So nobody
all
could
artifacts.
identify an artifact. Anyway.
Coming to the second last question. So again, an interesting question. 53 years old female patient who was implanted dual chamber pacemaker for stick sinus syndrome, and she presented with sudden onset palpitation. This was the ECG at time of palpitation. 50 years old female patient with sudden onset palpitation. Time starts now. Implanted a dual chamber pacemaker. So most of them have answered D. It's pacemaker mediated tachycardia. Who has answered D? Because then they have to explain. Anyone would like to explain?
Paced first. You have to answer that question. Na? When it is a pacemaker mediated tachycardia, it should be paced.
So now for their,
Yeah.
you
So
can show
this was the ECG of the patient.
after pacing
Yeah.
in sinus rhythm. So now you go back to that. Yeah. So the hint here is that QRS morphology is same as sinus rhythm. So KVF also same. So, okay, anybody would like to try to answer that how pacemaker mediated tachycardia is identified? Or anybody would like to elaborate the mechanism? Forget mechanism, what are the clinical findings for pacemaker mediated tachycardia?
Why isn't it RVOTVT? Like, you know, I mean, you didn't know the sinus rhythm ECG earlier. No, he hadn't shown it to you. Why not? Because PMT follows certain characteristics. No? So what are those characteristics which are seen very classically in this ECG? What is the rate? Can someone tell me the rate approximately? Okay, so it is more than 2 squares and less than 3 squares, somewhere around 120, 130. That is a usual upper, tracking rate which is kept in pacemakers. Then look at the retrograde P wave seen very clearly. So obviously, in the setting of a pacemaker with this particular thing, you would always think of a pacemaker mediated tachycardia.
It's difficult if you don't know that pacemaker has been implanted. So then it comes in mind RVOT, VT, but then you have to look for the VA dissociation. So such a beautiful retrograde VA association would be very rare, I would say, in RVOT VT, but it is still possible. It is possible.
Have to be from the free wall because the transition is happening so late. It would have to be more wider than this.
Yes.
Seems to be relatively
Not
narrow
that
from the
narrow,
septum because
right.
space to them is
And then ectopic atrial tachycardia, in that you generally see a Venki backing, not such a regular thing, but that is also a possibility in, again that, but yes, it could be atrial tachycardia with left bundle aberrancy. That can be one differential diagnosis if you don't know that pacemaker is implanted. But here you know pacemaker is implanted, morphology of tachycardia and sinus rhythm, paced rhythm is same. And then most important, as Dr. Vivek said, it would be 120 or 130 because these are the upper track rates programmed in dual chamber pacemaker conventionally. So rate is limited to 120 or 130. It cannot go beyond.
coming to the last question. So a 50 years old patient was implanted a pacemaker for complete heart block, and he presents to you in the outpatient clinic with the following ECG. So this is the ECG. 50 years old male patient implanted a pacemaker. And what is happening in the ECG? Who has answered D? Definitely a lot of people have answered. Anyone would like to explain what is happening in the ECG?
This is one answer which is making us happy that you know
Exactly.
at least 30% people know that what is conduction system pacing and how does it look like. I would definitely would like somebody to volunteer and tell more about his answer, if someone can. Who all voted for, can you raise your hands, who all voted for conduction system pacing? Are you ragging thodi ho rahi hai? It's just a question. Come on, this is not
Okay.
your examination.
So the last,
No negative
last
marking.
question should be removed. Nobody has answered 30%.
Yes.
Nikal
Who
dijiye.
all have answered conduction system pacing? Yes. So
Okay,
would
sir.
you like to explain anything? This is not any examination. There is no negative marking for a wrong answer. If you are answered right, it is already registered as right. But we want you to, this will help you in your career also, in your exam also. You should have courage. You know, I know 70-80% of you know the right answer, but you don't just are gathering the courage to stand up and speak. So we are not examiners. We are just your colleagues, just few years senior to you. I think you must stand and speak.
Anyone would
At
like to
least
speak
we
anything about
expect from ladies here. आजकल ladies ही lead कर रही हैं, so maybe some lady can stand up and speak. Okay. So what is fusion and pseudo fusion beat? Anybody who knows? Would you like to?
So the pacing spike, where is it paced? So where is the pacing? The pacing spike is before the QRS complex, right? So if you have a pacing which is before the QRS pacing, you are pacing the ventricles. That is what we generally would say. What is a fusion beat and what is a pseudo fusion beat? Means you have a own conduction happening through the conduction system. Along with that, a pacemaker is giving a spike. So generally you will have a QRS which has certain part which is preceding the paced beat also, right? Like a own rhythm beat, that is initial part is own and the later half becomes a fusion between the conducted and the pacing beat, right? So here, do you find anything before the pacing spike, any QRS part which is before? Unlikely, right? Now, if it is pacing the ventricle, where it is pacing, why the QRS? What is the morphology of the QRS?
You saw the last pacemaker rhythm. It was a wide left bundle kind of QRS. But here it is right bundle and narrow. So that gives that is the, where is the hint?
It's very narrow. If it is narrow, it has to be in the septum and preferably on the bundle branches. That is the conduction system. So that is where you pace nowadays. In fact, sir does it very regularly.
So nowadays, if you see paced QRS spike before paced QRS, and it is narrow QRS, it is possible because we do conduction system pacing more and more. Okay, next.
Yeah, okay.
Pseudo fusion is the other thing which was given. So if the QRS, I mean, if the ventricle is depolarized, but by that time the lead hasn't sensed it, it would give a spike, but that spike would probably be a little bit later than the QRS. So what you would see would be a spike coming and a QRS2, which is narrow. And so that is called a pseudo fusion.
Right bundle branch, because the right bundle, most of the pacemaker leads are on the right side. If you have a right bundle branch block, then the impulse doesn't go directly there. It goes to the left side first. There is a deactivation there. And therefore the pacemaker will not know, and therefore the pseudo fusion is more common with right bundle branch baseline patients.
So you see spike and QRS complexes both, but they don't have any relation. No fusion and no relation with that. Results are ready?
Yeah, results are ready, so.
Any tie?
Yeah, there's a tie between two doctors.
Okay, only two. Okay. Dr. Rajanya Patel. Dr. Rajanya Patel and Dr. Aishwarya. Cardiologist. Cardiologist. Okay. So find out. Okay, then the Dr. Aishwarya kaun hai? Dr. Aishwarya. Okay, she is the
winner.
She's second, but she's first now. Congratulations. But then if with this any ties, okay. That definitely. Sure. Thank you so much. So so we clearly have winner here.
So we have a winner. So if we want, we can go for so definitely she's the winner.
Okay.
Is anyone who is third?
Who is the second one?
Three.
Second one में तीन है. कौन है?
बहुत सारे हैं तो फिर काम नहीं. बहुत सारे तो नहीं
कर सकते.
So she's a cardiologist. You are a cardiologist.
No, you are an MD student. Okay, great round of applause for her. We had some tiebreakers ECG, but short of time.
We can go for a tiebreaker in. I mean, among the top two who came third actually.
Okay, along with the
time one, yeah. Okay, so because I already told
announced those two names.
Let's call these.
But we have to be quick because we are already late. 15 minutes behind.
Should we start the session? But I think it will take how much time? Later on. Fine.
Okay, so we'll again.
So we will have a tiebreaker. So maybe after the next session.
Yeah,
we all have to wait for the next session.
Just before tea break.
Yeah, we will have that.
We'll have a tie break session and we'll announce the runners up. And definitely you are the first. You will also get the prize at the same time. So we can start with the session and
perfect.
Thank you so much. Thank you, Vivek and Somu. You've been great.
So all of you, please deposit the ARS. And so you have to wait because still you can be a winner. Let's start the next session. Thank you so much, sir. And it was a great discussion. The ECG session was very good. So let's start with the next session. So next session is overview of AF. And I would like to invite Dr. B.M. Goyal. So Dr. Dipendra Bhatnagar, Dr. J.L. Sharma, Dr. Nikhil, Dr. Pushpendra Garg, Dr. R.D. Pandey, Dr. Rohit Chopra, Dr. Sanjeev Sharma. Now, Dr. Chitresh, Dr. Dipendra Bhatnagar, sir. Avinash. I would like to invite Dr. Makka for his presentation.
Thank you, Pushpender and Dipender Bose, for sparing time in your busy schedule. Thank you everyone to stay back for this session. So I think AF is the arrhythmia where we need to focus now. As an electrophysiologist, we have been treating all kind of arrhythmias for last 15 to 20 years. But my interest in AF is also very recent. So we are doing first conference which is dedicated on AF because this is the arrhythmia of future India. In 10 to 15 years, you will see so many AF patients that we need to be ready to treat this arrhythmia. So that's the whole idea of conference here. And I'm very happy that we have been joined with by some distinguished faculties here. No, this is not the one. So before we start further discussion on atrial fibrillation, I thought I'll keep this brief introductory kind of talk on various definitions and classification of atrial fibrillation. So what is definition of atrial fibrillation as such? It is a supraventricular tachyarrhythmia with uncoordinated atrial electrical activation and consequently ineffective atrial contraction. And electrocardiographic characteristics of AF include irregular RR interval, absence of distinct repeating T wave, and irregular atrial activation. So what is the crux of this definition? Two things. One, uncoordinated atrial electrical activation with consequently ineffective atrial contraction. So why these two things have been kept in definition? Because it is the ineffective atrial contraction which causes the problem. It induces heart failure, it causes stroke. So ineffective atrial contraction is more of a pathological problem than ineffective mechanical contraction rather than ineffective atrial depolarization. What is now this clinical and subclinical AF and symptomatic and silent AF and asymptomatic is a very confusing terminology, now made very clear by European Society as well as American Heart Association. What is clinical AF and what is subclinical AF? So what is clinical AF? Clinical AF, now mind, in the beginning of definition, you just pay attention that symptomatic or asymptomatic atrial fibrillation that is documented by surface ECG. So if surface ECG is documented, then only you say clinical atrial fibrillation. Minimum duration of an ECG tracing of atrial fibrillation required to establish the diagnosis of clinical AF is 30 seconds. Either you should have a 30-second of rhythm strip or you should have an entire 12-lead ECG to document a clinical AF. Now, why this clinical AF terminology was defined? Because nowadays we implant a lot of pacemaker and ICDs. We do a lot of implantable recorder use and lot of external loop recorders, lot of pocket ECG, lot of monitoring systems which detect subclinical atrial fibrillation. So whatever is detected by these devices is called subclinical atrial fibrillation. Once it is documented by ECG, then it turns into clinical atrial fibrillation. And what is AHRE or atrial high rate events. So AHRE is the terminology used for the AF episodes detected by the implantable devices like ICDs and pacemaker. So they also, whenever we open a pacemaker interrogation screen, it shows that this was the burden of AF. This is this how much the AF episode have happened. Then we have to verify that looking at the intracardiac electrograms and if possible document by ECG to say that this is clinical AF. So subclinical AF is any AF detected by either an implantable or external loop recorder or by any monitoring system like Holter or by a paced implantable devices. And AHRE is the specific terminology used for AF episode detected by the ICD and pacemaker. Now we come to classification. There's a lot of confusion here also, chronic AF and what is paroxysmal and what is persistent. So first diagnosed AF is now defined separately, that AF that has never been diagnosed before, irrespective of duration, whether it lasts for 2 days or 3 days, but if it is first time detected, it is first diagnosed AF. Paroxysmal AF is self-terminating in most cases within 48 hours, but up to 7 days. Up to 7 days you call it paroxysmal AF. So even if one episode lasts for 7 days, and but then it should be second episode to say that it is paroxysmal AF, but it should last 7 days. And importantly, AF episodes that are cardioverted within 7 days should also be considered a paroxysmal AF. So any paroxysmal AF which reverts spontaneously or cardioverted within 7 days is called paroxysmal AF. What is persistent AF? More than 7 days. So including episodes that are terminated by cardioversion either with drug after 7 days. So lasting more than 7 days, and that is called persistent AF. Now this new term has been added recently, long-standing persistent AF. Now this is a continuous AF lasting for more than 1 year, but still we don't call it permanent AF. When we call permanent AF, when we have decided that AF is always to be there and we are not attempting any cardioversion, we are not giving any antiarrhythmic drug to control the rhythm, that is the permanent AF. When patient and physician both have accepted the atrial fibrillation, that is permanent AF. But at any point of time, if I think that I should cardiovert the patient and get back to sinus rhythm, it will be classified as long-standing persistent AF. So why these definitions have been changed? Because once we call it permanent AF, that means we have left the rhythm control strategy behind and we have come to the rate control strategy and rate stroke prevention. But long-standing persistent AF, we have hopes of maintaining the sinus rhythm. That is long-standing persistent. So there are many definitions like lone AF, that is only a historical definition. It was used for an idiopathic atrial fibrillation, but we see commonly some reasons, so this lone AF should not be used. Valvular AF and non-valvular AF, not very defined categories, but important from the NOAC's point of view, that the valvular AF means when there is moderate or severe mitral stenosis. Mind it, moderate or severe mitral stenosis, not even mild mitral stenosis or mitral regurgitation. Aortic stenosis, aortic regurgitation with AF are non-valvular AF, and prosthetic heart valves. So if somebody has prosthetic heart valves and severe or moderate stenosis, this is the category where NOACs have not been studied. So it is more important from that point of view. Otherwise, this classification doesn't mean anything other than the NOACs point of view. Chronic AF is a very variable definition and should not be used. I think long-standing persistent AF or permanent AF are the more accepted terminology. And what is atrial cardiomyopathy? Atrial structural, architectural, or contractile or electrophysiological changes with potentially relevant clinical manifestations. So atrial tachycardiomyopathy is AF is there, persistent or permanent AF is there, and then LA is getting dilated, LA is getting fibrosed, looking to causing a relevant clinical manifestation in forms of heart failure. So that is the atrial cardiomyopathy. Now, what is the AF burden and burden of AF? Burden of AF is comorbidities like stroke and everything, and the economical, financial consequences. That is burden of AF. But AF burden means that how much time a patient spends with atrial fibrillation. That is AF burden. Now, how to calculate it is mostly related to the patient who have implantable pacemaker and ICDs and other heart failure devices. They calculate AF, and whenever we do interrogation, then it defines that patient is in AF for last so many days. So basically, AF burden is hours of AF, and then in 24 hours or 7 days like this. So what is rate control? Just I'm going for definition because Dr. Clare has a full talk on rate control and rhythm control. So rate control, strict rate control would mean that target resting heart rate less than 80 and target exercise heart rate less than 110. That is strict control. And lenient control is target heart rate less than 110. Lenient control is preferred because the affirm and some more trials showed that the strict rate control and lenient rate control didn't have any difference in the outcome. So there's new definition, new field, integrated management of AF, which we'll discuss later on. But this means that it is a coordinated and patient agreed approach with multiple disciplines, particularly in AF clinic. That is the integrated management for atrial fibrillation. And then this terminology is also given by the European Society of Cardiology. AF, better care, the ABC pathway. A stands for anticoagulation or avoid stroke. B for better symptomatic management, and C for cardiovascular and comorbidity. So in AF, 3 pillars of management: anticoagulation, then symptom control, and third is the comorbidity management. So primary prevention of atrial fibrillation, we never thought of this before, but now the risk modifications like losing weight, quitting smoking and alcohol can prevent atrial fibrillation. So in summary, I would say that AF is a new epidemic of India, and we need to be knowledge ready to conquer it. It is important to differentiate between paroxysmal, persistent, and permanent AF, as their pathophysiology, prognosis, and line of treatment are totally different. The better care lies in the ABC pathway. An integrated approach in form of AF clinic is the way to go. Thank you. So any quick question we can take?
You have covered almost all the points. I think we will cover all the questions at the after the next talk. So,
sir, one quick question: how comfortable you are regarding diagnosing AF based on wearables ECG, which are very common right now, like Apple Watch? Somebody sends you on WhatsApp. Do you feel comfortable in diagnosing such patients with AF, or do you call them for a surface 12-lead ECG?
For subclinical AF documentation, Apple Watch is a good thing actually. It gives you 30-second rhythm strip, and it is very sensitive. I think it is Apple Watch is specialist of atrial fibrillation, not for any other thing. So I would trust on that. But yes, you have to document by ECG if you want to label it as clinical AF. But for subclinical AF, I relied more than the pacemaker and ICD, because there the heart rate is 175 or 150 or 200, which is not very reliable for AF. And EGMs are also, and duration is kept as 5 minutes in pacemaker and ICDs. So that also rules out many atrial fibrillation. But Apple Watch is very sensitive for atrial fibrillation at least. There is some study also, I'm not very much aware of that, but Apple Watch is good for AF.
So much so for such a wonderful talk. And I have seen around 4 to 5 patients of Dr. Makkar who was given an Apple Watch, and they came in emergency with either CHP or syncope or episode of AF. But when they came to emergency, patient was absolutely, uncomfortable, but they had the documentation of either AF or sinus pause or something. That thing really works. So thank you so much, sir, for such a wonderful talk. And I would like to invite Dr. Vivek Chaturvedi, sir, for giving his talk, Diagnosis and Screening of AF. is silent AF, really silent?
So point is that these watches, I think we'll discuss this as time goes by. They do detect AF quite well. Just that we are still not sure what to do with these patients. That because studies with opportunistic like this, they are quite ambiguous as to how they are helping outcomes of. My topic is silent AF really silent? And this thing goes on because a majority, I mean not a majority, but a sizable amount of people who have atrial fibrillation actually deny these symptoms. And so this then AF is called asymptomatic AF or silent AF. So is this truly an entity, silent AF or no? There is a lot of ambiguity in the symptomatic presentation of AF because the AF typically happens in people who have a lot of non-specific as well as some specific symptoms which can be ascribed to coexistent conditions. A lot of these people will have hypertension, AD, heart failure, etc. Not only this, to confuse things further, people who have symptomatic episodes of AF can actually have asymptomatic episodes also. And a lot of research has gone on to prove that, especially after ablation, many such episodes happen and they are not detected by the patient at all, but because of routine screening, they have been detected. So the question which begs is that is silent AF a true entity or no? Or is it some kind of downplaying of symptoms or desensitization of the patient towards his own symptoms over long term? Overall, according to the different clinical settings, about 10 to 40% patients do not report any symptoms when asked directly when they have AF. So then the question arises as to what is causing the symptoms in AF. Is it the high ventricular rate or is it the irregular heart rate itself? And here there is definitely a mind-heart connect because a lot of people, even the irregular heartbeat, but a lot of them don't. The commonest symptoms of AF are palpitations, dyspnea, some chest discomfort, fatigue, very rarely syncope, but a lot of effort and tolerance. It's worth mentioning that the symptoms which are also present in almost all other cardiovascular disorders. On top of that, when studies have directly looked specifically at psychosocial problems in these people, then it is found that they have anxiety and depression as well. Complicate things further, the same patient may have different kind of symptoms at different points of time. And then, the symptoms may differ from one patient to another also. But why asymptomatic AF becomes very important to know is because it has the same thromboembolic and acute decompensation of heart failure risk. And that is why the treatment of AF does not discriminate between symptoms per se, because these two are the most important problems happen when a person gets AF. That is systemic embolism and progressive deterioration of heart function. Now, several studies have actually looked into the correlation of symptoms and arrhythmia. And this has been a very sobering exercise because it has been proven that sometimes when the patient thinks he has AF, actually he's got sinus rhythm. And when he is not even aware, he's actually having AF. So this again puts a lot of difficulty in trying to do a proper research study for this implications of symptoms in patients with AF. So what kind of patients actually do not have symptoms? So silent AF actually increases with age and with duration of AF, and it also happens to be more in women. It is less in paroxysmal AF, much more in long-standing, persistent, or permanent AF, where with time the symptoms of AF go down. And this also happens once they have had some ablation or they've gone some pharmacological therapy, despite them still being in arrhythmia. And as I mentioned, that lack of symptoms does not mean less serious AF. In fact, almost 15 to 25% patients AF, the first presenting clinical scenario is stroke, irreversible. Now, when we say that somebody has symptoms or no, and we are kind of doubting the patient's own account of that, one way which has been used is to cardiovert these patients sinus rhythm, and then ask them again whether they're feeling better, because then that would mean that they had some symptoms. Typically, those symptoms have been of fatigue or of exercise intolerance, and then that symptoms become better. So this whole controversy started because of this small study which cardioverted these patients. And then when these patients, almost all of them actually reverted back into AF because they were not on any pharmacological therapy after cardioversion. But when they were in sinus, and these were all monitored by loop recorders, so when they were in sinus, they did improve, they did report improved energy and increased exercise tolerance. And they could accurately localize when they've gone back or slipped back into AF again. Subsequent studies, though, have shown that this really is not, consistent with bigger studies. Some studies have, like this one from 2006, they have seen these cases, and they found that patients who did not have symptoms to begin with report some improvement after cardioversion, but within a span of a year or so, they're back same. And in terms of hard data like exercise performance, it doesn't change at all, whether they are in AF or if they are in sinus. And then some people have actually ablated these people also. And the biggest problem with this kind of studies has been that, as is usual with ablation of AF, many of them go into a kind of recurrence of AF or atrial tachycardia, which is regular and fast. So you've turned some of these people from asymptomatic into symptomatic atrial arrhythmia, which is definitely not a good idea. So this is another paper which shows that, depending on the symptom burden in AF with heart failure, because again, that is another concern that we have. It was found that patients with heart failure have a little bit more symptoms, but more of atypical symptoms when there is reduced ejection fraction. And then if we were to study from Japan shows that if somebody has paroxysmal AF, which is asymptomatic, it's a small subset only, but if you do ignore it and if you don't address it, then majority of them over a period of a decade or so will progress into persistent AF, which has its own deleterious consequence. So this study, again, as I mentioned before, was a large survey, and they found that people who were men at older age, previous MI, and limited physical activity tended to have asymptomatic AF. The connotation being that patients with asymptomatic AF also tend to get less oral anticoagulation. And seriously, this study actually found that patients with asymptomatic AF actually end up having higher mortality than symptomatic AF. That makes sense because they are less under the radar. They are not given anticoagulation. They may not be cardioverted. They may not be pursued for a rhythm control therapy. So this particular conclusion that asymptomatic AF has higher mortality is debated by a few people, but what emerges is that definitely the morbidity and mortality of asymptomatic AF is at least, if not more than that of symptomatic AF. And in this study, it has clearly shown that irrespective of this is a meta-analysis of over 80,000 patients, about 1/4 were asymptomatic. It's clearly shown that whether it's all-cause death, cardiovascular death, or stroke, it does not matter whether you have asymptomatic or cardiac AF. Putting it all together, silent AF is a dynamic concept. You may have had symptoms in the past, but they are gone now, asymptomatic, or symptoms may be coming in the future. The complex interplay of physical and psychological domains, the correlation of symptoms with severity and burden is questionable, quite common in symptomatic patients also. And but on the other hand, it is true that some patients are truly asymptomatic, especially who are old and who have long-standing AF. But then this should actually lead to even more enhanced care for these patients rather than a neglect. And this is why opportunistic screening has increasingly found its way into recommendations of several guidelines, including APHRS1. And I think the easiest way of opportunistic screening for these people is, just feeling of the pulse when somebody of the suitable age comes, who are, as well as, for cardiologists, if you are putting pacemakers, then it definitely merits attention to the high rate episodes. Thank you so much for your time.
Thank you very much, sir. You are very well highlighted, and after Maktar and your talk, we have really highlighted this point that now time has come where AF should be treated aggressively and it should be diagnosed even in asymptomatic patients also. And meanwhile, we'll address you for the question and answer session later on. Can we move to next one?
I request Dr. Bagratta sir to come over the dais.
Please come, sir. Yeah, pleasure, sir. Thank you so much, sir, for such a wonderful talk. So the next talk, actually, Varita ma'am was supposed to deliver, but somehow, because of some family problems, she couldn't come. So I'll be discussing very brief about the various screening tools for arrhythmias. So before starting this presentation, so I would like to ask a question that suppose a patient comes, patient gives a history of syncope, recurrent syncope, but that happens every 7 days or 8 days. Then what will you do? So a patient coming with history of syncope every 7 days, what will you do? Anyone would like to answer? Dr. Gunjan, please. Please give a mic.
As the frequency of symptom is on a weekly interval, so we can go for an extended loop recorder.
Exactly. So that is the crux. That most of the times we go for Holter monitoring and we say that the Holter is normal. So patient doesn't require anything. So this is wrong because the symptoms it's actually occurring every 7 days. So there is no role of Holter monitoring. So let me start with my presentation. So we all know the current techniques for arrhythmia monitoring. So most common is ECG, and which gives us the diagnostic yield of around 2 to 11%. Then we have Holter. Then we have external loop recorder, which can give us recording for around 7 to 30 days. And we all know about the implantable loop recorders. So implantable loop recorders can give recording up to 12 to 14 months. So we have 4 things which can tell us about what is happening to the patient. Holter, which can be implanted for 24 to 48 hours. External loop recorder up to 14 days. Again, it can be extended to 1 month as well. And implantable loop recorders, which is implanted inside the patient, can give a diagnostic yield, very high diagnostic yield, and which is implanted when patient is having recurrent symptoms, but infrequent. So all depends on the symptoms. If daily, we can go for Holter. Weekly or monthly, we can go for external loop recorders. If the frequency is very less, then we have to go for actually the ILRs or insertable loop recorders. So what are the tools? What are the tools which are used for detection? So Holter, now coming to the external loop recorders. So earlier, the external loop recorder was very, very, uncomfortable for the patient. It had a lot of wires, a lot of patches. Patient can't take shower, and for 7 to 14 days, it was very difficult for the patient. But nowadays, it has become very simple. Patient has to just apply a patch, and again nowadays we have 6 lead, 7 lead external loop recorders. Just a patch. Patient has to just get a patch. Patient can take shower, and more importantly, there is a live monitoring. Suppose I get this ELR, then there are a lot of people sitting, company people sitting, they can see the live ECG of my in their monitor. And if anything happens, they can immediately call or send signal to the patient or the doctor that you are having something and reach emergency immediately. So this is again a beautiful aspect of external loop recorders and implantable loop recorders. I'll come back to that shortly. So now, again, we have instant recording as well, that we can also see what is happening on the smartphones. And just I think Dr. Vivek discussed about Dr. Markar discussed about the Apple Watch, in which we can see what is happening to the patient on an instant basis. Patient can send a PDF. Suppose a patient feels some palpitation or giddiness, he can immediately record his ECG, single lead ECG in the iPhone, in the iWatch rather, and he can immediately send that ECG PDF to the doctor, who can see and suggest what is happening to the patient. So this is how the external loop recorders, it works. So this is a patch. This is a very, very simple patch which patient has to wear. 7 lead ECG can be seen. Live monitoring is there. Remote patient monitoring is there. And this is the implantable loop recorder. So again, it's a very, very small device, approximately 7 into 45 millimeters. And the insertion technique is also very easy. It has to be implanted in the chest wall. And it's an OPD basis procedure, not a very difficult procedure, implanted at the OPD. And this is implanted, and it can be implanted up to 1 year, 2 years, depending on the model. So if patient is having anything is happening to the patient, then a doctor can know immediately what is happening to the patient, and he can be admitted, or the diagnosis can be made. So a lot of times it is helpful. Suppose a patient is having symptoms every 4 months, 5 months. A lot of young patients are there who complain of syncope. We get Holter, we get ECG, neurological evaluation is done, MRI, EEG, everything is normal. And we think that patient is functional, or nothing is happening to the patient. But actually patient might have some cardiac problem. Patient might have VT, VF, long QT syndrome, or CHB, Sixanus syndrome, which can be captured by these kind of loop recorders, and we can make an exact diagnosis what is happening to the patient. So definitely the diagnostic yield of external loop recorders is much, much higher than Holter if patient symptoms are infrequent. And all the guidelines, be it EAC guidelines or be it ACC-HA guidelines, all of them have a very good recommendation for these, either Holter or external loop recorders or ILR, depending on the patient symptoms and the duration of the symptoms, the frequency of the symptoms. ACC-HA guidelines, again, the same thing. So I just present 1 or 2 cases how actually this helps. So, so she was a 70 years old female patient who had history of recurrent palpitations, and the Holter was done, which was normal, and echo was done, baseline ECG was normal. So usually, most of the times we leave it like this only, that if Holter is normal, we consider that patient basically doesn't have anything. But then patient was advised external loop recorder, and then this runs of tachycardia or atrial fibrillation was seen in external loop recorder. So this is very, very important to diagnose the symptoms what patient is having. Again, a lot of cases are there. A patient was having actually non-sustained VT, giddiness, which was diagnosed by implantable and external loop recorders. Patient had sinus pause, a long sinus pause. Patient was having symptoms of syncope, infrequent syncope, diagnosed with the help of these loop recorders. And this is with a 2:1 AV block, patient was diagnosed. So I won't discuss, I have a lot of cases. So just this case. So she was a 50 years old female with history of TIA. So I don't think there is any neurologist sitting here, but they always advise a Holter monitoring or an external loop recorder if patient has a history of CVA or TIA, which is unexplained. So Holter was done, which was normal LV function. Everything was normal. She was on antiplatelets, but then she was advised ELR, and an episode was seen on 20th day. So the treatment option now is different. If patient is having AF with stroke, we have to anticoagulate her. And if patient is having maybe only CVA without any history of AF, then we have to give antiplatelets. So this is very important to make a diagnosis whether the cause of stroke is basically AF or not AF. So all these loop recorders are indicated in patient with recurrent palpitations, pre-syncope or syncope, and ELRs are recommended who have symptom interval of around 4 weeks, and they are very diagnostic for therapeutical decision only when a correlation between symptoms and arrhythmia is detected. So this is also very important, that there should be a correlation between what is happening to the patient and the ECG which is happening at that time. Because a lot of patients are there who actually have sinus pause in their Holter monitoring or in the ELR, but they are not a candidate for pacemaker. So patient has to be symptomatic for getting the treatment. And the yield of loop recorders are much, much higher than the Holter monitoring. So I kept my presentation very short and tried to be informative. So much.
Just a small thing, like we get so many cases of TIA and stroke. Do you have any some guidelines to suggest, because every patient cannot go for ELR, and in most of the cases like Holter and all those things is normal. So do you have some like age or some other factors that these people should be investigated further? Because
yeah, very nice question actually. But as far as I know, what neurologists do, apart from all these carotid Doppler and all the other investigations, if they feel that everything is normal, they definitely advise for Holter monitoring. If everything is normal, all the neurologists in my hospital, they advise Holter monitoring. Initially, I used to feel why they are advising Holter monitoring, but then I mean the reason was that they just wanted to see whether AF is there or not. But definitely, if patient is at high risk, old age patient with diabetes, hypertension, then and if there is no definite cause of stroke, TIA rather, then we should go for external loop recorder just to make sure whether patient is having AF or not, AF as a cause of TIA or not.
I think there are some telltale signs of cardioembolic strokes. So a radiologist or a neurologist can easily tell you that, yes, I think it to be a cardioembolic stroke. So that in that cases, you can definitely should go for the rhythm monitor.
There's one more point which I want to impress upon is that though you mentioned that the ELR is obviously has got more yield, but we have conducted a study, we published a study from our hospital itself, where as Dr. Jawahar said, that there were indications of patients who might be having AF. The neurological, the MRI or the CT picture of a cardiomyopathic stroke. In those cases, we did find a reasonable, I don't remember exactly what was the percentage like, but we had these patients got their Holter done in our hospital, and I think around 5 to 10%, they had AF, especially in those patients who had documented cardioembolic stroke, as far as the imaging was concerned. Yeah. ELR is good, of course, but as you said rightly, that ELR may be difficult for some patients.
If the symptoms are very infrequent, so I'm not talking about AF, but any patient with syncope
CVA or TIA, the patient is present with CVA or TIA.
It might.
Have AF.
Yeah.
But there is no temporal relationship between AF and stroke. So this is a very important concept, and that is why now for patients who are suspected cardioembolic, till now we were thinking how to do a monitoring in them. Whether you do extend it for 15 days or you do it for. So the recommendation nowadays is that you should do like 3-4 days, multiple times at intervals. That probably will give the best heat rather than one continuous long monitoring.
Sir, the understanding we had during our MD days was that it was the conversion from paroxysmal AF to sinus which led to, so it was naive.
It's proven now.
Okay.
And as he said, there is no temporal relationship. So it's not like sick sinus that syncope and bradycardia both have to happen. If stroke has happened and if we identify any time at any point of time of any duration atrial fibrillation, it becomes significant.
In fact, after radiofrequency or cryo ablation also, it is recommended. that even if you have normal sinus rhythm in your ECG in the follow-up visits, you should get these monitoring just to make sure that patient is not having subclinical AF, because maybe patient is asymptomatic, but you have subclinical AF in the ELR or this recording system. So this is also recommended for every patient who have been, given the therapy of radio frequency.
Sir, in my view, it is more important to detect the AF, whatever the modality, because among the all arrhythmias, this is the most morbidity causing arrhythmia. So the person who has the stroke, you should try your best, whatever the modality you choose. And all AF patients must be treated with the anticoagulation. And that is the most important thing to detect the AF.
Right. Very true, sir.
I think the newer Apple watches, which we have discussed earlier, they are very important.
Very important, sir. But then the only problem is that they are very good when patient has palpitation and patient is symptomatic, then immediately patient can diagnose. But what if patient is asymptomatic, subclinical AF? For that, Apple watches, are not very effective because patient will not have symptoms. But definitely, sir, Apple Watch is very, very good thing because it will not only detect the AF, but the bradycardias also. Very, very nice. So,
sir, one last comment. Dr. Vivek, you showed us that study of Ganapti, which was the first study to show that regarding the symptoms. So when they cardioverted those patients, they felt better. So I think the Orbita trial has classically taught us when you do something which has not compared to placebo, when the patient has belief in you that the doctor has corrected abnormality in my body. So that must have been a cause that those patients felt better after cardioversion. So unless we have a comparative with placebo, unless we cardiovert the sinus rhythm patients, we cannot tell whether those symptoms must have been correlated with. Although very great topic, a great concise talk by you and Dr. Kush, sir. Thank you very much.
So now I would like to invite renowned cardiologist Dr. T.S. Clade, sir, for his talk on rate versus rhythm control. Is it still a controversy? And sir, after this, we can have that ECG tiebreaker.
Thank you very much. Thank you, Jitendra and Kush, for organizing this meeting. Obviously, atrial fibrillation is a big problem in the world, and atrial fibrillation incidence goes on increasing as the age increases. By the time you are 80 years, almost 8% of the people have atrial. And still, it is a very inadequately understood and inadequately treated arrhythmia. So now we come to atrial fibrillation. My topic is rhythm control versus rate control. My concept is that we are comparing two modalities. Both the modalities are not proven to be used. Either we have technology to keep patient in normal rhythm, nor we have effective medication to control the rhythm. So I think discussion to my mind is superfluous because we don't have the methodology to keep patient in normal rhythm. Neither we have methodology, proper methodology to keep them under control. Now, if I heard Jatinder correctly, said rhythm control means the average heart rate below 80 and lenient is below 110. How do you know in any patient that the heart rate is controlled? You maximum do 24-hour Holter. You don't know what is happening in the rest of the month or 2 months or 3 months. Maximum you can do a ELR. So you really don't know whether you are controlling heart rate or wrong. In my experience, when I see Holters, same patient will have heart rate of 140 at time and 30 at another time. What do? Rate control or not rate control? So in my own opinion, in my experience, neither we are able to control the rhythm to bring them back to normal rhythm, nor we are able to control. So what these comparing two entities is superfluous. Anyhow, I have to show some slide. Atrial fibrillation, it's a chaotic atrial contraction. It could be paroxysmal, and I think Jatinder has told you all this. It's a most common sustained arrhythmia in the world. Patients may be asymptomatic. It may be symptomatic. And the irony is, same patient may be symptomatic in one episode. In the second episode, he doesn't feel it. So it's also a very difficult challenge. And as I said before, it increases with age. So there are a lot of disadvantages of atrial fibrillation. First of all, I think we should understand one thing. If God made atria and he made a system that first the atria will contract, then the ventricle will contract, there is synchronization between the upper and lower chambers, then it is very clear that sinus rhythm will be better. Anyway, there is no, I think, controversy regarding that. When a patient is in AF, there is a loss of his AV synchrony, there is irregular ventricular rate, inoperability increase in rate with exercise, rate-related cardiomyopathy due to rapid ventricular rate called tachycardiomyopathy. And obviously, they have reduced cardiac output. And there is a decreased LV function, exercise tolerance is less, and quality of life suffers. Tachycardiomyopathy, fold increase in cardiac mortality, 5-fold increase in stroke, significant burden of healthcare system in the world. So AF is not desired. It's not a benign arrhythmia, but I think one should understand very clearly. Okay. Now, percentage of atrial patient, what the symptoms are? Normally, 60% will say breathless. Palpitation, 53%. This is one study. Fatigue, 41%. Chest pain, 25%. Dizziness, 23%. And syncope, 3%. Why syncope happens in patient with atrial fibrillation? Syncope happens in those patients who get paroxysmal AF. What happens? You have an AF, and when the AF terminates, there may be a pause because the sinus node is suppressed for some time. So that is one time when you can have a syncope because of atrial fibrillation. Atrial fibrillation in chronic AF, syncope is not a feature unless the heart rate is going very, very slow. So coming to the management, so far we are totally inadequate to treat atrial fibrillation. So what we try to do is we do rate control, we try to do rhythm control. We are very clear in one thing at least, that any atrial fibrillation, paroxysmal or permanent, every patient needs anticoagulation. Aspirin, clopidogrel alone is not enough. That I think is very well established. There's no doubt about it. So most common question answered is whether to restore the normal rhythm or control the ventricular rate. So, but if a patient is unstable and he comes with AF, I think there's no doubt cardiovert him. We have to bring him back to normal rhythm. Don't think anything else. But if a patient is stable, then the controversy arises. If you maintain the normal rhythm, there are advantages. Avoid electrical and anatomical remodeling, improve the hemodynamics, improve the quality of life, reduces the mortality, thromboembolism. What are the disadvantages? If you use drugs, there are side effects. You must have seen a lot of patients having bradycardia with amiodarone, heart problems, pulmonary fibrosis, and whatnot. And even other drugs, they have their own side effects. So if you control the ventricular rate, what are the advantages? Lessen symptoms, but there are symptoms that never absent. You may control the rate, but palpitation to hoti rahegi. You know, they will continue to complain palpitation because it's irregular heartbeat. So it's like this. They will complain always these symptoms. And there is absence of ventricular proarrhythmia because the drugs to control the ventricular rate are relatively less toxic, like beta blockers or calcium channel blockers, or even amiodarone, for that matter, is less proarrhythmic as compared to many other drugs. What are the disadvantages? Requires long-term anticoagulation, hemodynamics are never normalized, does not prevent electrical and anatomical remodeling, side effects are there, inadequate rate control during exercise, persistence. I say actually that hardly ever patients have proper heart rate control because we cannot monitor these. Okay. So ultimately, there have been so many trials done in the past. I don't want to go in the trials, but all these trials showed that rhythm control and heart versus the rate control, there was no difference in the patients. So despite substantial difference in the drug trial, 36 studies done with selected almost like more than 6,000 patients of rate versus pharmacological control of strategies, uniformly concluded that the rate control was not inferior to rhythm control for the primary endpoint of the trial. But this is 2006 data. And what are the criticism of these trials? Young people were not represented, symptoms not considered as a primary endpoint in these trials. And some of the trials, patients did not show improvement in exercise tolerance. There are a lot of criticism of all those trials if you consider. Now, rhythm control with antiarrhythmics. Antiarrhythmics used for maintaining rhythm are low efficacy. Only 10 to 35% in rate arm, they maintain rhythm. What are you talking about rhythm control? 26 to 63% in rhythm arm maintained, they could only maintain rhythm over a period of 2 or 3 years. We don't know the long-term effect. So more effective maintenance on rhythm may have yielded different results. Also, antiarrhythmic drugs carry their own risk, proarrhythmia, which will take away some of the gains of normal rhythm. Amiodarone is the most effective drug, but also most toxic drug. And as far as possible, I would like to avoid using amiodarone in any patient. So this is a trial, this is a chart to show that if you don't give any drug in AF, 30% still remain in rhythm. If you give the most toxic drug, amiodarone, you achieve 60% normal rhythm. And that also for a couple of years, ultimately they also fail. So implications. The guidelines statement is again old statement that says actually you can either do whatever you want to do in a particular patient. There is no difference in maintaining rhythm versus rate control. So is there an evidence of favor in rhythm control? Yes. Observational studies higher morbidity and mortality in patients with AF, especially if they are associated with heart failure. Symptoms worsen during AF than in normal rhythm. We have seen these patients, heart failure well controlled, they develop AF, they go to heart failure again. This, I am sure you must have seen, all of you. A farm database, patients in normal rhythm had lower morbidity, mortality, and less symptoms of congestive heart failure in both groups. PABA trial showed compared maintaining normal rhythm by RF and AV nodal ablation with the biventricular pacing showed less heart failure symptoms, improved 6-minute walk test, and ejection fraction in patients where we maintain the regularity of the heart. So pace and ablate and pace, because at least they produce the regularity of these patients, that was still better than continued atrial fibrillation. Now, one of the recent trials was Castle trial. This trial was that showed clearly the first trial to show there was a mortality reduction in heart failure patient by AF ablation. The recent data that if your patient has heart failure, as far as possible, bring back to normal rhythm either by medication or by ablation. This is a trial with ablation. And if you go to the Cubana trial, which was published in 2018, this trial was also the first trial to show mortality reduction in new onset and undertreated patients by AF ablation. So this is all what I have said from the literature. What is my own view? My own view is what I want for myself, what I want for my father, what I want for my wife. I want normal rhythm. I don't want atrial fibrillation. So it is always preferred over atrial fibrillation. So, my dear friends, my own opinion is Jatinder and Vivek Chaturvedi, that my view is that we should have a new trial. And this trial should be divided into symptomatic and asymptomatic patients. Symptomatic patients should have 3 arms. Rhythm control by RFA plus minus drugs. Number 2 thing should be rate control by AV nodal ablation and conduction system pacing, not by routine pacing. The third limb should be rate control by drugs alone. Similarly, asymptomatic patients, all the 3 limbs, and then it should be a randomized trial. It can be done in India because we have a lot of patients, and if I think the electrophysiology community comes together, we can do such kind of trial, and it can be a wonderful new information in the world as far as the disability. I think with these remarks, I will thank you, and I will be ready for any answer.
Thank you, sir. Nice presentation. And I think your presentation completed all the and answered all the questions which were there.
But still, I would like some criticism, if you have.
Sir,
there's no criticism as such, but
no, I think your views. I want some other views. We have talked. This topic I'm doing first time in my life because I never liked this topic.
Yeah, when I told you to take this topic, he said, no, this is no more a controversy and I don't want to talk about it. But I said, no, we need your views because so much experience in treating AF. But sir, you said for all that I need sinus rhythm for all, for my father, for my grandfather. But for grandfather, I may differ. For wife and for brother, it's okay. But old asymptomatic patients may not benefit that much with sinus rhythm control with the effort, because we generally defer ablation in them, and we don't want to use amiodarone, flecainide anyway in these population, and these drugs have a lot of side effects. So rate control for at least debilitated, old, elderly, frail patients with atrial fibrillation is a good idea.
No, I agree. See, the thing is, my dear, that I would like to maintain normal rhythm in every patient, provided I can do that with acceptable side effects. Acceptable. You know, I don't want to do damage by giving them RF ablation to a 90 years man or a amiodarone. If I can maintain with acceptable side effects, then it is okay. But if I cannot do, then I think I'll go to rhythm control. But my own view is that rhythm control best will be AV nodal ablation and connection system. I think
yes, I was coming to that because you have.
I know there's no data, but I think.
But that's a good idea.
Yeah, I
Any
think.
Comment about this doing AV node ablation upfront?
Rhythm control by drugs is perhaps inappropriate, inadequate.
If you do AV node ablation and do a CS pacing, would you accept AF in that case and do only ventricular pacing? Still, you will like to control the sinus rhythm.
No, I will accept the AF. Then I'm controlling rate. I'm not control. I'm so not. They are not in the sinus rhythm arm. They are in the AF arm.
So these are the patients who are already in permanent AF and they are already in the rate control thing, and you are not able to control the rate.
Right.
So it is a rate control strategy.
Absolutely.
Not a rhythm control.
Because my concept is that rate control is effectively done only by AV nodal ablation, not by drug. But I may like to do this philosophy in symptomatic state. I don't want to do this in asymptomatic as far as possible.
Yeah, but then here's just my suggestion that if we do CS spacing and we don't have any backup and we are creating an AV node ablation, so are we in a stage to believe in his bundle and left bundle pacing so much that we don't leave a backup? Or would you like to give a backup?
The experience so far we have, many of us know you do, and your department does the conduction system pacing. Believe me, left bundle pacing is very, very reliable. I may not depend on his bundle pacing.
To begin with, maybe we can implant a dual chamber and put a backup.
Left bundle is very reliable. Very reliable. Patient with the paroxysmal AF, I may still put an atrial lead, but patient with permanent AF, I think single chamber conduction.
That's a very revolutionary statement that you're giving, that all patients would like to go for rhythm control. Would you like to still strategize your or classify your patient? Okay, there are some patients who would again revert back to AF.
Right. So, see, the thing is, what I'm saying today, nobody recommends that in the. Let me tell you, this is off the literature.
Agreed.
But this is my thought basically. But I will risk stratify these things. For example, symptomatic patients, heart failure patients, where I cannot bring them back to normal. I want to ablate the AV, give them conduction. But again, there is no data to prove or disprove. I think. So I think this trial is needed.
So that will be more pragmatic and more personalized approach.
Clear, sir. We have a lot of electrophysiologists here, but our lot of MD physician or colleagues are also there. So can you overview some rate control strategies also, or can you describe them? It is very useful for them.
There is a separate talk, but
I think by the mouth of clear, sir.
No, but in any way, thanks very much for this question. The only thing I want to emphasize is that please don't neglect AF. AF should be respected. Anticoagulation in every patient unless there are great contraindications. And if there are great contraindications, I have another talk. Then you have to do the left atrial occlusion tabla. But anticoagulation is must. Number one. Number two, as far as possible, try to maintain them in normal rhythm with drugs, but with acceptable side effects. Don't produce too many side effects. try to bring them normal rhythm. Please never hesitate from cardioversion. I don't know why physicians never cardiovert me, but there's no scary at all. Cardioversion is a very, very simple thing. If a patient comes with AF without anticoagulation, you have to do a transesophageal echo for before cardioversion. But if your patient is on anticoagulation for 6 weeks, then there is no need to do transesophageal echo. But the rider here is that if a patient has been on appropriate dose of NOAX, then I don't care at all about the echo. But a patient who's on vitamin K antagonist, then I should have reasonable evidence that the INR has been acceptable in last weeks, because sometimes the INRs are haywire, and then you can't depend on the reliability of that 6 weeks of anticoagulation. Thank you very much.
Thank you, sir.
Thank you so much, sir, for such a wonderful presentation and great discussion. We have actually a tiebreaker in the ECG quiz. So if you give 5 minutes, you can just. Yeah, so Vivek sir, Shumu sir, please come. Makka sir, please come. So, I would like to call Dr. Gunjan and Dr. Vishal. Dr. Gunjan, Dr. Vishal. Dr. Vishal. So, we will actually, both of them are second. We can have a tiebreaker for them.
This is not a response system, so you have to describe the ECG. Diagnosis may be correct, incorrect, but we'll see the presentation of that ECG mainly, and along with the expert panel, we'll decide who is the winner as second, because we have decided the winner. So as first runner-up, we decide between two of you, and we'll show two ECGs, one to each, and we'll just like to see the presentation and your approach to the ECG, not necessarily diagnosis.
So, Dr. Gunjan, you can come. So the ECG. Please describe the ECG.
In rhythm strip, the rate is okay. It is between 60 and 100, so it's normal rate. There is RBBB morphology, and the axis is changing. Axis is changing. And in V5 rhythm strip, there are alternate morphology of QRS complexes, and each QRS complex is preceded by a P wave. The morphology of P wave is, it is upright in inferior lead, so it seems to be sinus. PR interval is prolonged. So
this is a tough ECG, no doubt. You have been really wonderful coming to this level, that you have shown your very good approach to this ECG. The only thing is that just I want to give you a hint whether you see one P for each QRS or maybe more. Yeah, that's what. You look at lead 2, long lead 2. You have been very good in observing that there is alternate QRS is changing. What about the P waves?
the P waves are at regular interval, but there is no relation between atrial and ventricular activity. I think every dissociation is there.
Okay.
PR interval is not big.
Are you sure there is total AV dissociation, or you can find out some association?
Is it electrical alternance?
They should just let him come to. Okay, so if it is like, okay, you think there is the first degree AV block, you say it is first degree AV block?
The PR interval.
Oh, you said complete AV dissociation. Okay, so if we say it is complete AV dissociation, what is happening to the QRS here and axis?
QRS, the morphology and amplitude of QRS complex is changing on an alternate complexes, and axis is also changing. Sir.
Any comment, Dr. Vivek? Dr. Shoma?
Electrical alternance is there.
The axis is changing, and if you are finding that there is a right axis, the PR is longer as compared to when there is a left axis, the PR is shorter. So you have alternating LPHB and a LAHB with conduction a little bit faster. That is what I would keep. And the RBBB, so the width of the RBBB is also changing based on the activation pattern along the different things. So whenever you have this, you have a baseline RBBB, you have alternating bundle branches which are with the PR prolongation. It's always a conduction system disease that you think of.
I think, sir, this axis is changing. And
Yeah, so he's beautifully explained that with RBBB, there's alternating posterior and anterior hemi blocks, and QRS duration is changing because there is change in aberrancy with the P related to PR interval. So, but only thing which you have not picked is probably this 2:1 AV block going on here.
Yeah, the 2:1 AV block is
Not
also there.
exactly complete heart block because the PR interval for a conducted B is almost fixed. You think it is CHB?
Sir, it's
2:1.
not CHB, but PR interval is not fixed. In B1, if we see that in first, second complex, in second complex, PR is short in first complex.
That's just Dr. Shumu said that because it's alternating bundle branch block. I mean, rather, it's conducting through. It is conducting whenever there is, a right axis deviation, the PR is prolonged. But when there's a left axis, the PR. That is why
PR means if it is alternating conduction system block, then still the.
You are right. You are right with RBBB. You are right with alternate. That QRS morphology is changing.
PR
Except for the 2:1 AV block.
You differ, Dr. Vivek?
At 2:1, I am also not very clear because
Next slide.
the P wave, I'm not
Next slide.
sure
Yeah,
where is the
please.
second P wave.
I think this, and this is the change in the morphology in the QRS. So
when there is sinus rhythm, if you are saying 2:1 block, the sinus rate is very fast.
yeah, it can be atrial tachycardia also.
So the P wave morphology looks like sinus because it should not be there. So if the P wave is going within the QRS, it's very difficult to say. Now that is because of the repolarization changes. It's not seen in the alternate. It's not seen in the alternate beats. So I don't know whether it is seen in the alternate beat.
You think it's part of QRS complex? Of
Yes,
the previous beat?
that is what. So terminal part of the QRS complex. It may be 2:1. We may not be able to say on this. You may need a longer rhythm or when the heart rate slows down.
This was published in JAMA.
So in B1, what we mark with arrow, so in between this first and second QRS complex, there is the 2P. Then in between this second and third QRS complex, so if in fixed 2:1 block, there should be 2P, then a QRS complex. But this pattern is not being followed here. In this strip between third and fourth QRS complex, single P is there. And this PR interval is also it's varying. So it's not a fixed 2:1 block, a sort of AV dissociation.
So is the PP interval also regular? I suppose that's some irregular in the PP interval also. So is it not so that one of the P which comes earlier, that gives rise to a different QRS? The one which is conducted in the lead 2 has got a definite PR interval, but the next P wave is come earlier, and that gives you a different type of QRS. So I think the PP interval is also not regular. If I mean, you can see that. Yeah, that's what. So this one, these two PP, I mean, this one PP interval, and this one is not same. The PP interval is also not regular. I mean, not the same. So the one which is coming earlier is an ectopic P wave. That's what I feel, and that is giving rise to a different type of QRS.
That means I tell Bigemini, but I am convinced that this may be part of QRS complex rather than T wave, and agree more with Shomu and Vivek. Claire sir, is it a 2:1? A very interesting discussion. Is it a 2:1 or first degree?
I think it's a good ECG, very good ECG. I will go in more favor of some kind of atrial tachycardia with two strong blocks.
Yeah.
Of course, there is a connection system. This is no doubt about
wonderful,
that.
Wonderful explanation.
Very nice.
Yeah, very
see,
nice.
If you want to study further, of course, you should be ready, not to be scared of transient AV block. Give adenosine, you can the atrial rhythm will come out. Then you can study better. If you got adenosine, at least produce a AV block template, any atrial arrhythmia for that matter. If you want to study further, clarify further, just give adenosine, and it's a transient AV block, so we'll understand the atrial.
That's a
okay. So we can call the next person.
Dr. Vishal.
So I'll take advice of experts only. So just keep a watch how the second person explains the ECG. Your diagnosis here, we presenters also were not sure about the diagnosis. So I think rest of the work has been done wonderfully by Kunjan.
The answer which was mentioned, so it was published in JAMA. So the answer which was mentioned is sinus tachycardia with alternating left anterior left posterior fascicular. The answer which was mentioned in JAMA. Clear debate of session. So please come forward. Yeah, very difficult, sir. Very difficult. Exactly, I agree. Very difficult. In fact, we also thought that it's atrial tachycardia. Axis, exactly, sir. Yes, sir. Next. One more slide next. This is the ECG of a 50-year-old male who presented to emergency with chest pain, severe chest pain. Property was negative. What's happening in the ECG?
Okay, take your time, take 30 seconds, 1 minute, no problem.
Don't come to the diagnosis. Try to explain whatever you can see.
The rate is normal in these two, and there is a T wave inversion in V1 to V2, V3.
Okay.
And poor progression of R wave in testis.
Okay. So you have said T wave inversion, poor progression of R wave, lead V1 to V6. Next, the normal rate. These three things you have mentioned.
After rate and rhythm, what do you comment on generally in exam?
That is giving a lot of hint.
The rate is irregular because there is RR interval.
It is irregular, but we don't have a rhythm strip. Strip is not there. Still, you feel rate is irregular? True. Sinus arrhythmia.
Which ECG lead is always negative, whatever is the axis? फिर कहाँ अभी तक कहाँ थे? Come to that.
What is happening in lead AVR? Please keep the mic. The mouth.
Positive complex in AVR.
Positive. Positive.
In AVR, sir.
What positive?
Complex, sir.
Okay.
Sir, reversal.
Reversal of? Reversal of? You are right, actually. Reversal of?
Lead, sir.
Reversal of lead. Okay. Just reversal of lead or anything else is also there?
Dextrocardia, sir.
Why you say dextrocardia?
Sir, inverted P wave and in V1 and AVR positive complex. Positive AVR.
So that will differentiate between dextrocardia and limb lead reversal, because that will be present in both the scenarios. That is not a criteria to differentiate between these two things. You have to explain. Negative P in lead 1, positive P in lead AVR will happen in both limb lead reversal and in dextrocardia. What is the other thing which goes in favor of dextrocardia? So basically, you already answered. There's a poor provision of R wave in lead V1 to base.
All negative complexes in precordial lead. इसका मतलब क्या है? हार्ट दूसरी तरफ है. तभी तो सब नेगेटिव आ रहा है ना.
Next slide, Deacon. Next slide. Next. Next slide. Next. This is basically just limb lead reversal. We can see negative P wave in lead 1, positive in AVR, and a normal pattern, concordance pattern, normal transition pattern in lead V1 to base 6. Next slide. And after correction of the limb placement, we can see this remains same, and now this has become normal. Up to dextrocardia, the first one, second ECG. Back, yeah.
Scar in the anti wall. What is your reaction to that?
Can definitely.
That's also a possibility.
Yeah, that's a possible.
Because that also should be kept.
Yeah, that
because pain तो हुई है बंदे को पता नहीं पहले भी हार्ट अटैक हुआ हो क्या पता.
Yeah.
Situs inverses, it has to be situs inverses because P wave is negative. If it was situs solitus dextrocardia, then the P wave would have been positive in one AVL as compared to AVRs, because dextroversion can also be there, right? So how do you differentiate that? Is by P wave morphology. P wave negative in one and AVL, it is situs inverses. So it is situs inverses dextrocardia. The atrium is also changed. That is why the P wave morphology.
Now it's up to you. So who is the winner?
So we are ready with the results. So first is first, Dr. Aishwarya, you can come ahead. And second is Dr. Gunjan. According to all the experts here. Very nice. What is your name? Dr. Vishal. What is your name? Vishal. Very well done. You are an MD student at SMS? Great. So both of you can come ahead, and if we are ready with the prize, I'll request Dr. Claire sir to come and give them the prizes. This is to inform you all that Dr. Claire has been my kind teacher, and whatever I learned in my early career is from him only. And thank you, sir, for everything you did for us. And congratulations to Dr. Aishwarya. So here is an iPad for you. So next time iPad किसने लेना है वो तैयारी कर लो अभी से. Congratulations, Dr. Gunjani. His second inning. Last year also he won.
I think this was a great thought from Jatinder and Ankush to have this competition and quiz. I just want to tell you one thing, that ECG is something which has a lot of improvement. And you don't have to be cardiologist even. You don't have to be electrophysiologist. You can still diagnose 90 to 95% of the concentrated on it. So please strengthen your ECG. जितनी बार ज़्यादा पढ़ोगे, ज़्यादा ECG देखोगे, उतना अच्छा है. We have a ECG Academy. We do webinar once a month, first Wednesday of every month, 7 p.m. So I think I will encourage you to join this. It's a webinar. You don't have to go anywhere. So learn ECG, a gateway to medicine, cardiology.
Thank you very much, Bhagrata sir, to join us. He has been also one of my kindest teachers. Thank you very much for coming. Thank you, Pushpender. Thank you, Nitesh. So we have a small 10 minutes tea break here, and then we'll continue the session. We are a little behind the schedule, so exactly by 10 minutes, we should be back on our chair. Thank you. I'll request all students to stay back for rest of the session, please. Thank you.
check, check. Hello, hello.
Check one. Hey, hey. Check one. Hello, hello. Check, check one. Hello, hello, hello. Check, check one. Check. Hello, 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 hello. Yeah. हेलो हेलो चेक इनको थोड़ा कम कर हाँ इनमें ज्यादा आ रहा है हेलो 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 हाँ ये कर रहे हैं इनको थोड़ा कम कर हेलो 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 अभी भी हाँ अभी भी थोड़ा ज्यादा है हाँ अभी भी ज्यादा है हेलो आ
as a chairperson for our next session, Management of AF, Dr. Amit Gupta from Shalby Hospital, Dr. Anil Gupta, Dr. Dinesh Gautam, Dr. Manoj Sarova, Dr. Milind Shrivastava, Dr. Pawan Mehta, Dr. Sanjeev Sidana, Dr. Sunil Garsa, and Dr. Shashank. Dr. Amit, Dr. Pawan, Dr. Milind, Dr. Shashank. I would like to invite Dr. Makkar sir to present his first talk on integrated approach to AF, the ABC care pathway.
Thank you, Milind, Sanjeev, Dr. Pawan, to spare your time. So we are starting the next session, Management of AF. So first, I thought this is important. Welcome, Dr. Amit. So I thought I should put few words about integrated approach to AF management as we are planning an AF clinic at our center. And you can understand why we are aggressive about atrial fibrillation is because we have bought cryoablation therapy. So we are starting, but we believe in the wholesome care. So we start with integrated approach to AF management. So what is an integrated approach? I'll request all the colleagues who are on the T side, they can carry their cups and come back to their tables. So carry your snacks and cups. It is absolutely allowed, and please be seated. So integrated management of AF patient requires a coordinated, efficient, and agreed patient individualized care to deliver optimized treatment by an interdisciplinary team. So what are the keywords? One is that it should be coordinated. Second, patient agreed. And third, it should be through, it should be an individualized care pathway because every patient is different. As Dr. Claire was discussing, rhythm control, rate control. So whatever strategy we have to see, it depends on the type of that patient, and it should be an interdisciplinary team approach. So we'll discuss how. So what is a medical model and what is an integrated model, care model? So medical model is, suppose I'm the clinician and patient comes to me, I examine him, I write some investigation, he comes back with report, and then I write some treatment and I ask him to come after 2 months, 3 months, which he may come, he may not come. So that is a medical approach, medical model, which is existing for different kind of diseases. But this is not absolutely okay with the atrial fibrillation treatment because there should be some kind of periodic follow-up, some kind of mechanism to look at the adherence to anticoagulation or other rate control or rhythm control regime, and whether rate is actually controlled or not. If you are seeing the patient after 3 months and he is coming back to your clinic with again increased heart rate, you don't know that whether in 3 months the heart rate was controlled or not. So to start with, AF better care, that is ABC pathway. So as I described earlier also, A means avoid stroke or anticoagulation. B for better symptomatic control, symptomatic management of atrial fibrillation. And C is cardiovascular or comorbidity management. So these three things we'll discuss. And why integrated care for atrial fibrillation? Because AF is a chronic illness with multi-system involvement and comorbidities. And there are gaps in existing AF related care. So what are the gaps? What are the shortcomings in AF care? Underutilized anticoagulation is definitely the most important gap in the treatment. 18% strokes are related to atrial fibrillation, but 34% patients do not receive appropriate anticoagulation even in absence of contraindication. Physician-related factors for gaps in anticoagulation is fear of bleeding, therapeutic inertia, and herding. Herding is a decent name, but हिंदी में इसको भेड़चाल कहते हैं. अगर 10 डॉक्टर लिखने लगेंगे तो बाकी डॉक्टर भी लिखेंगे, अगर 10 नहीं लिखेंगे तो बाकी नहीं लिखेंगे. So believe in herding rather than in the evidence. So patient-related factors, lack of disease-related knowledge, and individual perception and attitude. So patient also has to be educated. As we discussed in detail with Dr. Vivek Chaturvedi, that unpredictable and variable symptoms and asymptomatic AF is the reason for gaps in AF-related care, because patient will present only if he has symptoms or by opportunistic screening, as we say, but otherwise it's very difficult to diagnose silent AF. Special population is to be taken care of: chronic end-stage renal disease, cancers, cognitive impairment, and extreme elderly and frail population. So risk factor and lifestyle modification, we talk a lot about coronary artery disease, we talk a lot about heart failure, but we don't talk when we talk about AF. So we have to take care of risk factors and lifestyle modification when we talk about AF. And recent guidelines by AHA, including lifestyle modification as class 1 indication for AF related care. Comorbidity optimization, hypertension, obstructive sleep apnea, heart failure, diabetes, these are very common comorbidities and they have to be taken care. In Indian context, some of the gaps are overuse of amiodarone. Everybody will agree that it's a toxic drug, and sometime only for rate control is being used. And underutilization of class 1C drug. For our knowledge, I would like to state that we have 2 class 1C drugs, flecainide and propafenone, available in Jaipur market, but we use them lesser. And we use amiodarone more because we are more familiarized with that drug. Underutilization of AF ablation. Now that is also a long story why AF ablation is underutilized. It is physician related factor also. A lot of time is needed. Like in a busy cath lab like ours, we never intended to do a lot of AF radiofrequency ablation because every procedure will take at least 1.5 to 2 hours. So that's why we got cryo, because it takes less time and we can do PVI in less time. So in integrated AF management, patient is in the center, and then we have to optimize stroke prevention, symptom control, then risk factors modification, then patient education, healthcare professional education, lifestyle modification, psychosocial management, strategies to promote medical adherence, and multidisciplinary team approach like neurologists, diabetologists, and geriatric specialists, and so on. So this is how integrated care works: patient and the center, and then AF nurse, a general practitioner, pharmacist, cardiologist, family, and at least one of the family member should be told in detail about the atrial fibrillation in that with the AF patient. So as I told, patient himself, then AF clinic, AF nurse, a relative caretaker, primary physician, multidisciplinary team, and then screening tools. I think Kush has elaborated few of them, even BP monitors, pulse oximeter, smartphones, smart watches, Holter, patches, loop recorders, implantable devices. Those who have pacemakers, we can easily follow the AF burden in the implanted pacemakers, but even as cardiologists, we ignore that. So we should stick to that and give importance to AF burden shown by the devices. So these, I think, have been covered earlier. Patient-reported outcomes are very important, and then there are clear-cut guidelines for integrated AF care, class 1 now. So conclusion, AF incidence is rising with underestimated complexity and burden of the disease. There are gaps in knowledge, implementation, and delivery of AF care pathways. Routine AF care is a medical model centered to patient and treating doctor with ignorance to adherence to the treatment, optimization of risk factor, and comorbidities. Just like heart failure, AF is not the disease where you see the patient and send back home and ask him to come after 3 months. It is a continuum of care which an AF patient needs. if we really want to avoid stroke and improve the mortality. The future of AF care lies in integrated care pathways for delivering an organized and effective care to improve the outcomes. And there is conflicting evidences in favor of various components of integrated care needing further studies. Thank you very much. And with this, I'd like to announce that we are soon inaugurating our atrial fibrillation clinic at our center. So that will be a kind of pilot clinic. Let's see how it works and how it goes ahead.
That is a wonderful presentation, I would say. There are associated comorbid conditions with atrial fibrillation, which makes the treatment of AF is more difficult, like associated CKD, COPD, or you can say chronic AF with a valvular heart disease. So how important is the management of these kind of subsets?
Yeah, so very important, and we have it. I gave similar importance to this discussion, so I gave a separate talk on this.
Then it's
That
fine.
AF in special populations, which it exactly includes CKD, exactly will include heart failure. So I think that will be more elaborating, and we can have some discussion at the end of this session. So thank you so much.
Thank you so for such a wonderful talk. So I would like to invite Dr. Shomuso for his next talk, risk stratification of AF for stroke prevention, balancing the thin and thick. Back all to you.
A very good evening, respected chairpersons, and thanks Dr. Makkar and Kush for having me here. So, integral part of AF management is stroke prevention, and that is thromboembolism to prevent. The only problem is you have, when you give anticoagulation, you become make the blood thin, and if you don't, you have obviously the risk of thromboembolism. So how to balance that? And this is a very important topic that comes down over a period of time, because it's a long-term therapy. It's not a short-term therapy. If you initiate, it is for lifetime. It cannot be stopped in between. So how do you know when to start and what to start? So it is basically that you have increased thrombogenesis, and that is because of endothelial or endocardial damage, abnormal stasis, especially in the left atrial appendage, and an imbalance between hemostasis, that is coagulation, and fibrinolysis. And that is where the risk factors are. So balancing the thick would be to know whether which type of AF is there. Now, only here is valvular and non-valvular, that is lone AF. Otherwise, the type of AF like persistent or paroxysmal doesn't have any say. What you need to know is the scoring system in lone AF and what are the options available to make the blood thin. While if you make the blood thin, how do you know that the patient will bleed? So what is the dose and which are the high risk patients? And that is with Hasbled score and the associated risk factors. So balancing the benefit of anticoagulation and the risk of anticoagulation is very important. And that is what we'll see in the topic. So how to prevent strokes in atrial fibrillation? There may be large strokes. So what we do is to anticoagulant by either vitamin K antagonists or NOACs or by LA appendage closures. The risk of thromboembolism in a non-valvular AF is 5-fold, and it is based on the risk factors alone. The type of AF, the atrial size doesn't matter here. Whereas in valvular AF, especially in mitral valve disease, 17-fold risk, and therefore anticoagulation is mandatory. You don't have risk factors assessment in that. So it is always to be given. The most common studied risk factors for atrial fibrillation would be what you see is the stroke, hypertension, aging, that is the age more than 65, structural heart disease present absent, diabetes, hypertension, vascular disease, LV dysfunction, and females if it is there. But what are the other important special situations or the risk factors that are there? CKD is there, obstructive sleep apnea is there, HCM, amyloid, smoking, hyperlipidemia, metabolic syndrome, malignancy, etc. are also risk factors for atrial fibrillation, which are not included in the score.
the LA size per se. If you do a imaging, echocardiography, LA dilatation is there, spontaneous echo contrast. So these are not included in the risk factor scoring. And that is very important to see individually in these patients. Now people have started to see for blood markers like NT-proBNP especially, what is the risk, and also D-dimer 1 Willebrand factor, CRPs. If CRP is elevated, especially in metabolic syndrome patients, they are at a higher risk. So in 2003, the CHAD score came, where it was given a score of 6, and based on which anticoagulation was started. And then came the CHAD-VAS score, which we generally now use. And of this scoring system, the total score is 9, and it is based on congestive heart failure, if it is there, with or without LV dysfunction, left ventricular dysfunction, if it is there, or HCM, it is there, it's given 1, hypertension 1, age more than 75, 2 points, diabetes mellitus, and a patient with vascular disease, and age in between 65 and 74, 1 point, and if female is there, it's 1 point. A prior stroke, transient ischemic attack, or thromboembolism elsewhere itself is given 2 points. That means the patient has had higher risk. Why all these risk factors? So if you have a total score of 2+, the risk of having a thromboembolism per year is 2.2% per year. That means over a period of 10 years, it will be 20%. And that is what you want to target. So if it is a 0 score, the chances are less. However, if you see the data, the number of patients is very less. So it's overall, they have said that if lesser the score, the chances of thromboembolism is less. If higher the score, the chances of thromboembolism is more. So you give various anticoagulation, and we have demonstrated that by maintaining INR between 2 and 3.5, the stroke risk is decreased and the hemorrhagic risk is also decreased. While in NOACs, which will be discussed separately, which to be used, the chances that the stroke risk decreases per year is this much. So if the initial score was with no therapy was 4.5, if you use antiplatelets like only aspirin, it decreases to 3.7. If you use dual antiplatelets, it decreases to 2.8. While if you use warfarin derivatives, it decreases to 1.7. That is nearly half. And dabigatran, it comes to around 1.1 and a therapeutic dose. But on the other hand, when you are using these drugs, you are giving the risk of bleeding, right? 1% to 1.5% per year. So if you see overall, the difference between the risk factor of anticoagulation and the benefit of decreasing the stroke should be good enough. So that is when the CHAD-VAS score says that if the CHAD-VAS score is 2 or more, then only we anticoagulate, otherwise we don't. What are the problems of anticoagulation? And this is the major problem. The risk is around 1%. These patients don't come to us. They directly go to a neurologist, and we fail to see such patients. And that is why we don't prescribe anticoagulation, because of fear of bleeding and monitoring. So only 38% patients on required atrial fibrillation are on anticoagulation. And that is one major. One is monitoring, and second is the fear of bleeding. So how do we optimize that? So there have been bleeding criteria score. Many criteria have been there. And if you see the Aubry score, hemorrhage score, and what we commonly use is the Hasbled score. What is the Hasbled score? It is similar. So if you have on one hand a CHAD-VAS score, Hasbled score gives you a total of 9. What are the inclusion? If you have hypertension, which is uncontrolled, more than 160, if you have abnormal renal function, a creat of 2.25 or more, or the SGPT, SGOT is more than 2 or 3 times, bilirubin 2 times, and SGPT, SGOT more than 3 times, a prior stroke, bleeding history, or predisposition. Even patients with anemia are included in this. If the patient's INR, if the patient is on warfarin, is not maintained well, if the patient is elderly, more than 65 years of age, and if the patient is taking antiplatelet, NSAIDs, or the patient is taking more than 14 units of alcohol per week, these are included in the risk factors. So you calculate both, because the major bleeding with the increased score goes up to around 12% per year. So if you are giving an anticoagulation in a high Hasbled score, then the chances of bleeding is very high. So it is important to have a consistent anticoagulation. It is not that कि एक महीने के लिए देंगे और उसके बाद भूल जाएंगे. ऐसा नहीं है. Anticoagulation is a must. So you should have it daily. The risk of hemorrhagic events are maximum in the first 90 days. So if the patient is taking regularly and in first 3 months, the bleeding has not occurred, chances that the patient will bleed later on with the same anticoagulation is less likely. Actually, we try not to anticoagulate the elderly, saying that they are more at high risk, but they also benefit the most because the chances of the stroke is at the highest in the elderly. Risk changes over time because the patient's age increases and the risk as well as benefit changes. And there are modifiable and non-modifiable factors. So what are the non-modifiable factors? Age, the change, prior bleeding, renal function, hepatic dysfunction, malignancy. But potentially modifiable factors are, you can control the blood pressure, you can increase the hemoglobin per se, decrease the alcohol intake, change the antiplatelets as such. So that is very important to focus on decreasing the modifiable risk factors of patient having a bleed. So how to balance that? So you should only start if you are having a Hasbled score which is less than the Chadwick score. So that is very important. And the first approach would be that if the patient has a mechanical heart valve or moderate to severe mitral stenosis, you give vitamin K antagonist. If you have low risk factors, that is the Chadwick score is 0 in male or 1 in female, then no antithrombotic therapy should be given. And then the steps 2 comes. So if the score is 1 in male or 2 in female, then you calculate the Hasbled score. If the Hasbled score is more, try to modify that before starting. That is very important. If the score is more, Chadwick score is more, then you have to start anticoagulation, and in which you have to see that it remains in the therapeutic range. That's very important. So you cannot start and not monitor. You have to monitor it well. That's very important. So if you have a Chadwick score 9 and you have a Hasbled score 9, if a Hasbled score is more than Chadwick score, try to modify, bring it down, and then only start anticoagulation, especially in high-risk patients, right? So guidelines also mention that. I will not go into detail. And those patients who are at high risk of bleeding, then you try to do a LA appendage occlusion. So this is how you should approach. Just 1 or 2 cases for discussion. So if you have a patient with a reversible, like an alcohol binge causing atrial fibrillation, you don't need anticoagulation, right? You don't want to give them. A patient who is diabetic and at 63 years old, the patient has only a Chadwick score of 1, but after 2 years, at 65, the Chadwick score will become 2. So every yearly assessment should be done for a Chadwick score in follow-up if a patient has had atrial fibrillation. The problem is patients with CAD, how to monitor these patients with antiplatelet therapy. So if you have an elective PCI done, this is very important. So I'll just take 1 minute in that. With stent, you'll have to give 3 months of 1 month of triple drug so you have 2 antiplatelets and 1 month of NOACs to be given, and then you have to withdraw 1 antiplatelet, that is aspirin may be withdrawn, and you can continue on clopidogrel with a NOAC. And after 1 year, it is recommended that only 1, that is a vitamin K antagonist or NOAC has to be given. While if urgent PCI, like a primary PCI is done, then 6 months of triple antiplatelet therapy, and then 6 months of dual therapy, and then 1 year of monotherapy should be given. So that is very important to understand. In rheumatic, you have to give vitamin K antagonist if it is moderate to severe mitral stenosis and above. Rest all, you can still give NOACs. Now, very important, if you have a bleed on warfarin. So what to do? If you have a bleed and they present with hemiparesis, so if you present with a thromboembolic stroke on warfarin, then what do? You see if the TI is there and it is very small, just 1 day you go back to anticoagulation and shift over to NOACs. Maybe not continue with warfarin itself. If there is a small disabling infarct, 3 days you have to restart it because the risk of intracranial hemorrhage is there. But if it's a very large infarct, you'll have to wait for 2 weeks. You have to change over to apixaban because it's superior. So consider left. So concluding, Atrial fibrillation as a cause of stroke is well documented. Anticoagulation is has proven to decrease the risk. CHA2DS2-VASc score is very important. Score 0 to 1, none. Don't use anything. Don't give aspirin just for the sake of giving it. Score 2 or more, you have to give anticoagulation. Hasbled score is modifiable, and therefore you have to decrease the Hasbled score to less than the CHA2DS2-VASc score before you start anticoagulation. Consider LA occlusion if there is a high risk of bleeding. And long-term anticoagulation is the most integral part of AF management. You have to individualize therapy according to the patient. Thank you.
Thank you, Dr. Shumu, for your wonderful presentation in a very simplified way. We'll be running short of time, much behind the schedule. So we'll continue with the other sessions and we'll take the question and answer at the last session. Thank you.
Thank you so much, sir. Really very informative talk. So I would like to invite Dr. Vivek so for his talk on Are All NOACs the Same, since Dr. Vanita is not here.
Thank you, Dr. Kush. So one word answer that is no, they are not all the same. But each yes or no has more nuances to it. So we'll just cover that in a brief span of time. So NOACs have been a game changer as far as non-valvular AF is concerned. Their non-inferiority for preventing ischemic stroke or embolic events is clearly comparable to those of VKAs by 4 large pivotal trials. Now, there is a lot of statistical jargon which comes into play in these things, and that is why it's important to understand what kind of trials have they all been. So a non-inferiority trial essentially just sets out to prove that a new treatment is not significantly inferior to an established treatment. For example, dabigatran compared to warfarin. While a superiority trial actually tries to show that the new treatment is actually superior to an old treatment. The practical difference is in terms of sample size and expectations. So for a new drug, it's much easier and much simpler, less costly to establish a non-inferiority as compared to superiority. So it's a mixed bag of picture nowadays. Most of the trial designs tend to have a non-inferiority followed by sequential superiority analysis with the same sample size. Now, so for doing the purpose for which the anticoagulants are given, they are clearly non-inferior to VKAs. Possibly superior, we'll just have a look for that. But clearly for preventing anticoagulant-induced bleed, they are far superior as compared to vitamin K antagonists. However, there is no RCT which has been done till now comparing these NOACs head-to-head to each other. And that also is unlikely to happen even in future. The simple reason is that the differences between them are so small that you would need a trial running into 30 to 50,000 number of patients, which in today's world is going to be really, really expensive. However, there are important differences in their biological effects and real-world effectiveness, which can be utilized. However, these also do remember a lot of publications are biased, and these are exaggerated by different manufacturers. So the 4 pivotal trials that we know already are the RELY for dabigatran, ROCKET AF for rivaroxaban, then Aristotle for apixaban, and finally the ENGAGE AF for edoxaban, which is not, edoxaban is not available in India. This is a summary characteristics of the pharmacokinetics of these drugs. Important to remember is that rivaroxaban is just once a day, while the other 2 are twice a day. And in terms of renal clearance, dabigatran is the one which is heavily affected. So in any kind of substantial renal failure, this is the drug which needs to be avoided. Now, if you look at the combined analysis of NOACs versus warfarin, there is some data to show that the strokes may be reduced a little bit with dabigatran 150 BD. Apixaban, well, this publication seems to think, but overall the consensus is that it may be slightly superior to VKs, while dabigatran 150 is likely to be more superior. I mean, most effective as far as all the agents combined, including warfarin, is concerned for preventing stroke or systemic embolism. Now, if you look at intracranial hemorrhage, which is, I think, what most of us are scared of when we try to start any anticoagulant, specifically vitamin K antagonists, then all the NOACs in all the dosages used are clearly very, very superior to vitamin K antagonists. So intracranial hemorrhage, there is a clear signal for superiority. And if you look at all-cause death, then virtually none of them is superior to vitamin K antagonists, and that might be also because of the low event rates. It's difficult to prove something as hard endpoint as all-cause death for comparison. Now, if you look at major bleeding, then again, except for rivaroxaban, which in Rocket AF also had equivalent but not better outcomes as compared to warfarin, well, both dabigatran and apixaban do far better for major bleeding as well. So if you just put this all together, then apixaban seems to check all the boxes here. But there are nuances within this, and this is what we are going to tease out. So if we look at the thromboembolic risk at baseline in all these studies, as Dr. Shomu was telling you about the CHATS-VAS score. Now look at the CHATS-VAS score, the difference between these 4 trials. Clearly, the patients who were there in Rocket AF were at much higher risk for embolism. Also, do remember that in most of the patients, the CHATS-VAS score and the HESPLET score tend to go hand in hand. So people who have higher CHATS-VAS score also tend to have higher HESPLET score. So implication being that this is a sicker population, which will benefit more with anticoagulation, but is going to bleed more also. What about different dosages? So this is another very interesting thing, and that is why a lot of people are of the view that because the baseline characteristics and the trial design was so different for these 3 pivotal trials, that it's like comparing apples to oranges. So for dabigatran, both 150 and 110 were used. So it was a 3-arm trial, 150, 110 placebo. In apixaban was used in 5, except in certain criteria with patients. So age more than 80, creatinine more than 1.5, or weight less than 60. If any of the two of the 3 were there, then a 2.5 dose was used. And then in Rocket AF, depending on the creatinine clearance, either 20 or 15 was used. But if you look at, suppose you're giving somebody 2.5, well, only 5% patients in Aristotle actually got 2.5 BD. So there is hardly any evidence for 2.5 milligrams of dose. Now, this is a huge retrospective claims database. So this is now I'm presenting because we don't have head-to-head trials. So a lot of publications have been done based on the electronic records and insurance claims from different countries. So this is from Europe, and more than 60,000 patients with patients on apixaban being significantly sicker. And apixaban and dabigatran performed almost similar, while rivaroxaban had 35% more chances of bleed. This is another large Korean database of more than 40,000 patients with quite sick because they had CHATS-VAS score of 4.6 and HESPLET of 3.6. No difference in stroke or systemic embolism amongst the 3 different NOACs. But if you look at major bleeding, again, there is a gradation with rivaroxaban having higher bleeding than dabigatran, and the safest being apixaban. And if you look further into the details here, then it is clear that as far as intracranial hemorrhages is concerned, all of them perform very well. But gastrointestinal bleeds actually tend to be higher with the higher dose of dabigatran and with rivaroxaban, while it's uniformly low with apixaban. So this was also found in this propensity score matching analysis. So this is another study which was just published recently, and it concluded that that apixaban might be a better choice. But I wanted to, so I went into the data of this study, and they have covered a lot of different studies. But what I want you to see is how heterogeneous are the studies in themselves. And that is why you can't ever really compare these three agents, because the type of people, the type of country, the type of circumstances in which they have been used are all very, very different. So these are, the absolute rates of events with the three agents when compared to the other agents. So rivaroxaban versus apixaban, rivaroxaban versus dabigatran, then dabigatran. So these are the rates with rivaroxaban, these are the rates with dabigatran, and these are the rates with apixaban. So if you look at stroke rates, pretty much all have similar. So that's fine, and we know that they're all working very well. If you look at IC bleeds, again, the rates are almost similar, except that rivaroxaban may be a little bit higher, but not much. If you look at GI bleed, suddenly we know that, okay, it makes sense that the interpretation that apixaban has the least amount of GI bleeds. But if you look at major bleeds, in one population, rivaroxaban is showing 5.1, another is showing 2. So this is a huge difference. And that is why these comparisons, which are indirect, are actually meaningless. Now, coming to specific subsets, I won't go into the details here, but again, rivaroxaban and apixaban can be used for even advanced renal failure. For end-stage disease, trials are going on. The ones which have gone on have been, can I just take 1 minute of time? So the trials which have gone on have not shown clearly, but we know that reduced dose apixaban and rivaroxaban are used in patients who are ESRD. In chronic liver disease, again, both apixaban is quite good, and rivaroxaban cannot be used with moderate to severe liver disease. And then, with people who are at lower spectrum of weight, because frailty is very important when we are treating elderly, again, apixaban tends to score because it has a definite dose which has been tested for patients who are frail. So this was another large study of more than 4 lakh people, again, based on claims databases. And this showed apixaban to have better efficacy, besides being better in bleeds also. But there are studies which have shown dabigatran 150 to be the best for prevention of ischemic events. And this is why this publication recently is of importance, because it says that there are so many methodological errors in these comparisons that they provide no meaningful benefit. And it is very unlikely that we'll ever get real hard data which will compare one NOAC to another. So fitting the right one to the right patient, for IC, if you want to prevent IC bleeds, almost all of them are equally good. If person is elderly, then I think dabigatran and apixaban both have very good efficacy. In CKD, again, apixaban is probably the safest and the best drug to use, and so on and so forth. I won't go into the details here, but again, in Asian patients, and Asian here by and large means Far East, not Indians. But we do have data from RELY and other trials for India as well. But almost all of them are quite safe and very effective as compared to VKs in Indians. So to conclude, it's difficult to compare the different NOACs, but in uncomplicated AF, probably all are equally safe and efficacious. But the difference in kinetics, metabolism, and interactions can be exploited to target specific NOAC for particular clinical scenarios. Apixaban, I think it is pretty well settled, has the best bleeding profile. So the most safe drug, wherever you're concerned about safety, then I think apixaban is clearly a good choice. If somebody is having recurrent events and you're bothered about preventing thromboembolic events, then dabigatran full dose is probably the best choice. Do remember, however, that any drug is as good, only good when it is taken regularly. So rivaroxaban is the only one which is once daily, which definitely has far better compliance as compared to the other two. And apixaban is still under patent in India, so it is still the costliest one. So if somebody just takes it for a month and leaves it, there is no point. Although it will probably become off patent in about 6-7 months or so. Thank you so much for your time.
Thank you, Dr. Vivek, for a nice elaboration on a comparison of various NOVAX and letting the people know that which NOVAX to be chosen in which population. And discussion will be taken in the last of this session. So I think this was the last lecture in this session. So can we can have question answers for this session? Are there any questions from the audience?
So the dais is open for discussion.
So,
yeah, please, any discussions? We can, I mean, we are open for question and answers.
Any of the panelists can ask.
One important point that although apixaban is said to be very safe, but only thing is that most of the time whenever we consider a safe NOVAC, we tend to use a lower dose. So 2.5 milligram twice daily of apixaban has got very, very little data. It was used on only, I think, 40-50 patients. So I think the 2.5 milligram BD dose should be avoided as far as possible, except in the ESRD patient who was on dialysis. Otherwise, as far as reduced dose is concerned, dabigatran has got better data with the 110 milligram twice daily.
Yeah, no, I differ because all the comparisons I have shown you are with the standard dose of apixaban, that is 5. 2.5 is very extensively used in India. Maybe cost reasons, maybe skepticism, but it is very clear that 2.5 has hardly got any efficacy data. That's missing. And it should only be used if 2 of the 3 criteria are satisfied. Now, that's another point, whether the equivalent biological for the creatinine, age, and weight are equivalent in Indian as compared to Caucasians, in which most of this data is there, we don't know. But till the time the data is not there, I think unless the 2 of 3 are not present, it should not go down to the lower dose.
Actually, patient with higher age means between 80 to 90 years with atrial fibrillation. So there is a common concept is that you start with a 2.5 apixaban because it will cause less bleeding. But how effective it is, nobody knows. Similarly, with 75 milligram of dabigatran, that drug is also available in our country. How efficacious it is, I would like to know the comment from Dr. Vivek.
75 was actually never used in any trial. I don't think it's even available in the US. It's probably only marketed in other countries. Regarding the elderly patient, you're absolutely right, sir, that unless somebody elderly is 90 kilos, I think he should definitely get 5 mg BD. What is interesting here is that this creatinine cutoff they have used, whether it should have been a GFR or creatinine based is something, because again in elderly the GFR changes, and do remember that the GFR for NOACs is usually taken by the Cockcroft formula. The CKD IPA, the other one should not, MRC one should not be used because all the trials have used the Cockcroft formula for this. So the only NOAC which has been safely shown to actually have even mortality benefit has been in very elderly, has been the edoxaban with only 15 mg, which is 1/4 of the usual dose used in Japanese patients. Again, extrapolation is not known for other populations.
I have a comment here, sorry. three small doses like dabigatran 110 and rivaroxaban 15 and apixaban 2.5. They were used differently in these three trials. Like 110 and 150 were randomized without any CKD, without any creatine clearance, age or creatine, whatever. Now, in this case, this was not a clear randomization in case of Aristotle. A very small population had age mode, two of these three criteria which were discussed. And in this other Rocket AF trial, there were proper randomization of 15 and 20 according to GFR. So I would say that on CKD, if some dose is studied, well, that is 15 milligram of rivaroxaban. 2.5 only we are giving because there was a small population in Aristotle, which was very effective in old days and equally effective with less hemorrhages in old days and more creatinine. Creatinine, I think, is a very rough criteria. So 110 proved to be less efficacious than 150, but then there were less hemorrhages than 150. So I think all three doses have their own good effects, but I think most overused low dose is 2.5 milligram and followed by 10 milligram rivaroxaban. I don't know from where it comes. So either it is 15 or 20. There is no 10 in cardiology. It may be post TKR, DVT. I don't remember.
Absolutely right. 10 milligram was used and published in New England for prevention of recurrent venous thromboembolism. So that is how it started getting used in COVID also for the same reason.
Yeah, but this 15 milligram dose of rivaroxaban was studied only in patients with moderate renal dysfunction. It was not studied in severe renal dysfunction.
I'll just comment one. So if NOACs are to be used, what is, Dr. Vivek, if you have an antidote for dabigatran, does it change your practice? Because now the company says that if you have a bleeding, we'll give an antidote for free. So does it change your practice in clinical scenario?
To be so with the original inventor molecule. After that, now nobody is giving it for free. But either way, the overall incidence is so low that I don't think it changes my practice at all.
What I personally do is if you have a high Has-Bled score and then I have to give NOAC, possibly I'll give dabigatran so that in case there is a bleeding, I would want to reverse it by giving an anticoagulant. I'll give Predexa only then because then they'll give it for free. And then if it tolerates for 3 months, I tell them 3 months, 3 months of tolerated Predexa, you shift over to any other because the cost difference is there. It's a very simple practical solution. And then definitely it helps to decrease our headache.
But the first NOAC dabigatran was launched in 2012, and for good 5-6 years we used only dabigatran. We hardly used any antidote, and now it's available for rivaroxaban as well as apixaban, which is same for both. So I don't think that is a criteria.
I think with the antidote available, that has changed Dr. Shomu's practice. You started using dabigatran, but how often or...
And Dexanet is also available for factor 10A, but it's not available in India, I think. It's not available. Mostly PCC is used for, but that's also not widely, I think, available. One indication I forgot to mention for rivaroxaban is bioprosthetic valves. The RIVER trial has clearly shown that it is even better than warfarin for bioprosthetic mitral valve.
I think this is definitely a puzzle to what to use in out of all these NOACs. But as far as I can understand, with all the presentations of Dr. Vivek sir and Dr. Shomu sir, I think with the high ischemic risk and the low bleeding risk, we can use rivaroxaban because as far as Dr. Vivek sir told that Aristotle trial, they had higher mean CHADS score in comparison to other trials. But bleeding risk is not that much good as in comparison to apixaban and the dabigatran. And if a patient is having higher ischemic risk, but high bleeding risk also. So as Dr. Somu sir already said, dabigatran should be a preferred option because it has better bleeding profile as well as it is carrying a free of cost antidote itself. So I think this would be the better summary of the whole presentation.
Now I have a caveat here. If you have high ischemic risk and low bleeding risk, dabigatran 150 is most efficacious anticoagulant.
Yeah, true.
In comparison to placebo. There is no head-to-head comparison, but in comparison to placebo and slightly superior to warfarin in all these three trials. So if somebody has highest ischemic risk and low bleeding risk, not because of antidote available, we can use dabigatran. It is getting out of our practice because of twice daily dosing or whatever, I don't know. But we can still use dabigatran 150 because that is the most efficacious anticoagulant in amongst the all doses and all. But because of GI hemorrhage, high GI hemorrhages and non-cranial hemorrhages, it was more in 150.
And one more thing, it is BD dose in comparison to rivaroxaban.
One more point, if the patient is having AF and you are giving calcium channel blockers or amiodarone, dabigatran has a lot of interaction with that. So you should always remember if the patient is CCPs or amiodarone, dabigatran should be less preferred because the efficacy, so it can the chances of bleeding can increase, right? So that is also important.
I think
finally, I think all the residents here probably should read the EHRA NOAC guidance. It came out in 2021. It is in Europe-based or in European heart failure both. So it's a beautiful, I think it's about 25 pages, and it gives every possible scenario and its solution.
Sir, what I want to ask one question. What is the antidote cost?
The company gives it for free.
Actually, the company is giving it for free of charge
because it's
if
not
you are using
available.
it.
It's not available very routinely, and 1.5 is the approximate lakh rupees.
But cost is nobody can afford. So I think this discussion is will never end. There are a lot of questions. So, but we are running short of time. So we conclude the session. And if there are any further queries, you can contact with Dr. Vivek and Dr. Shomu is available here. So with that note, I'll end this session. Thank you.
Thank you so much, sir. Thank you so much, everyone. So we will not have tea break. We will directly go to the next session, management of AF. And I would like to invite Dr. Ankit, Dr. Atul Kasli also, Dr. Gaurav Singhal, Dr. Mayank, Dr. Nikhil Parikh, sir, Dr. Prem Ratan, Dr. Ramanand Sinha, and Dr. Suresh Gupta, sir. Please, sir, please come on the dais. So Dr. Gautam Sharma do we have a video recording of Dr. Gautam Sharma? Fine. So his presentation will be via Zoom. And his talk is management of AF in heart failure.
Good evening, everyone. I'd like to thank Dr. Jitendra Makkar for inviting me to this AF Summit. I'm really sorry not to be there in person, but there were circumstances that I couldn't avoid. The topic that I've been given to discuss is management of atrial fibrillation in heart failure. So let's have a look at the prevalence of atrial fibrillation in heart failure. This slide is depicting the major CHF trials, and they've been listed from left to right in terms of a worsening of heart failure. And the black bars are depicting the prevalence of atrial fibrillation. You can see that with worsening of NYHA class, worsening of heart failure, the prevalence of atrial fibrillation increases from around 10% to almost around 50% in patients who are in NYHA class 4. So let's understand a little bit about the pathophysiology of heart failure in AF. We know that both these entities share the common risk factors such as age, hypertension, smoking, obesity, diabetes, obstructive sleep apnea. So once heart failure sets in, there is an activation of the neurohormones. There is an activation of the renin-angiotensin-aldosterone system that results in increased filling pressures and afterload, which in turn causes increased pressure in the left atrium. That leads to atrial hypertrophy and stretch. Eventually, atrial fibrosis sets in, and that leads to heterogeneity of conduction. In heart failure, simultaneously, there is an enhanced sympathetic tone. And because of that, there is a predisposition to ectopic activity. Once there are frequent ectopics in the left atrium, where the substrate is conducive, atrial fibrillation can frequently result. So once atrial fibrillation sets in, there is a loss of the atrial contraction. And because of the irregular and rapid rates, you have poor diastolic fillings, and that leads to and worsens heart failure. So heart failure leads to atrial fibrillation, and atrial fibrillation leads to heart failure, giving us the adage that atrial fibrillation begets heart failure and heart failure begets atrial fibrillation. Now, what happens if, how does it matter if both of them coexist? So this study, the Framingham Heart Study Group, looked at 1,470 participants who developed atrial fibrillation or CHF and followed these patients up for the development of the other condition. So what they found was that, as you can make out from the hazard ratio here, that there is an increased mortality when both the conditions coexist. So the authors concluded that individuals with atrial fibrillation or congestive heart failure who subsequently develop the other condition have a poor prognosis. So that leads us to the question, does sinus rhythm influence prognosis in patients with heart failure? Let's have a look at the on-treatment analysis of the AFFIRM study. This was published by the AFFIRM investigators themselves in Circulation in 2004. What they found was that there were only two variables that were associated with improved survival, and they were sinus rhythm and warfarin use. The use of antiarrhythmic drugs actually was associated with poorer survival. So there were a lot of rate versus rhythm heart failure trials before the ablation era. So the landmark ones have been listed here. And what essentially they showed was that even though there was an improvement in quality of life, even though there was a hint towards an improvement in ejection fraction, there was no effect on mortality. Let's take a closer look at one of the elegant trials, the AF-CHF investigators. And what the hypothesis they had was that since AF is a predictor of death in congestive heart failure, suppression of atrial fibrillation may favorably affect outcomes. And with this, they divided the 1,400 patients into two groups, the rhythm control, which was essentially amiodarone and cardioversion, and the other was a rate controlled group. And the primary outcome was a time to death from cardiovascular causes. And what they found was that there was no difference in the two modalities, rate control or rhythm control. Now, why is it that this antiarrhythmic drug rhythm-based drug-based rhythm control and rate control trials did not show any definite conclusion? Let's have a look at the limitations. So in the AF-CHF trial that I just showed you, around 1/3 of the patients in sinus control were, in the rhythm control, were actually in atrial fibrillation. On the other hand, 40% of the patients in the rate control group were free of AFib during follow-up. So, you know, there is a lot of overlap, and this overlap likely affects the outcomes. Secondly, the harmful effects of the currently available antiarrhythmic drugs may have neutralized the benefit of sinus rhythm. Similarly, in the AFFIRM trial, 2/3 of the patients were prescribed amiodarone, but less than 60% of the patients were in sinus rhythm at 5 years. Also important to note was that almost 600 patients crossed over from the rhythm to the rate control group because of drug intolerance or inability to achieve sinus rhythm. So we have seen that antiarrhythmic drugs cause higher mortality, whereas sinus rhythm leads to lower mortality. Now, mortality with antiarrhythmic drugs have listed here in this ELECANT trial, and you can see that the highest mortality is with sotalol, followed by amiodarone, and then dronedarone. But as you know that the efficacy of dronedarone in maintaining and sustaining sinus rhythm is much inferior to that of amiodarone. So then to summarize, why was rhythm control not associated with fewer cardiovascular events than rate control? Number one, antiarrhythmic drugs are ineffective in controlling atrial fibrillation. Number two, antiarrhythmic drugs have significant toxicity. So let's have a look at catheter ablation for AF in congestive heart failure. This was one of the earliest studies by Li Fen Su from Michel Hezeguier's group from Bordeaux, France. And they ablated atrial fibrillation in patients with congestive heart failure. And they concluded that if you restore and maintain sinus rhythm by catheter ablation, you can significantly improve cardiac functions, the symptoms, exercise capacity, and quality of life. This was followed by a spate of trials. And all of these trials actually looked at the same thing, atrial fibrillation ablation versus the medical rate control group or rhythm control with antiarrhythmic drugs. And what they found was that there was an improvement in ejection fraction. There was an improvement in exercise tolerance, an improvement in quality of life. But the big question remained unanswered. And that was, does catheter ablation improve mortality and affect MACE? So to answer that question, we had to wait till around 4 years back for this very elegant landmark CASTLE-AF study. And here, there were patients with atrial fibrillation and heart failure. All of these patients had an ICD, and they were randomized to ablation or medical therapy, plus guideline-based therapy for heart failure. And the primary endpoint was a composite of death from any cause or hospitalization for heart failure. And these are the results. As you can see from the cartoon on the left, that there was an improvement in ejection fraction. The ablation arm is in red, and the conventional arm is in green. And you can see that over 1 year, 36 months, and 60 months, there was an improvement in ejection fraction. That led to corresponding decreased hospitalization for worsening heart failure. You can see from the graph, on the right side, the ablation arm is in blue, the medical therapy arm is in red, and you can see that the ablation arm is higher. So similarly, there was a decrease in death from any cause in the ablation arm. And this was a big result. This was the landmark result that this study threw up. And it's important to note that though there was an improvement in hospitalization almost from the very beginning, in the trial, but for the survival benefit to manifest, it took almost around 3 years. Also, it is again important to note that remember, these patients, all of them had an ICD, so you could calculate the burden of atrial fibrillation. So here, the recurrence of atrial fibrillation was not a yes or no answer. They actually looked at the burden of atrial fibrillation. So you can see that the red bars are denoting the ablation arm, and the green is the conventional treatment arm. And you can see that the red arm are throughout the period of 60 months is much lesser than the green conventional arm, but it was not zero. What it implied was that you needn't have a freedom from atrial fibrillation to show a benefit. Even if you decrease the burden of atrial fibrillation in these patients with heart failure, you can have a significant improvement in terms of MACE and mortality. So the trial showed that irrespective whether it was a paroxysmal or persistent atrial fibrillation, there was a benefit. When they looked at the NYHA functional class and ejection fraction, it was evident that patients with better functional class and better ejection fraction did better. There wasn't any benefit in patients who had a very poor LV function, less than 25%. This was the recent RAFT AF study that was presented at the ACC by Anthony Tang. The primary hypothesis of the investigators was that catheter ablation for AF will reduce all-cause mortality and heart failure events in patients with AF and ejection fraction of less than 45% or more than 45%, which is in heart failure patients with preserved or reduced ejection fraction. So the outcomes revealed that the primary outcome narrowly missed the magic p-value of 0.05. But the secondary outcomes were all substantially better, whether it was quality of life, whether it was exercise tolerance, BNP levels, or ejection fraction, all showed improvement. Now, it's unfortunate and a bit controversial that this trial was prematurely terminated, apparently because of slow enrollment and because of low event rates. If they had enrolled the numbers that they had set out to, probably the primary outcome would also have achieved the statistical significance. However, if you dichotomize patients in this RAFT AF study into those with reduced ejection fraction, the graph on the left, and preserved ejection fraction, the graph on the right, you can see that the patients with preserved ejection fraction did not show improvement, and in fact, the patients with reduced ejection fraction showed survival benefit. And this survival benefit in patients with ejection fraction of less than 45% was mirroring what we saw in Castle AF. And remember, Castle AF patients were those with reduced ejection fraction. So the guidelines have now suggested that for paroxysmal or persistent atrial fibrillation and heart failure with reduced ejection fraction, it's a class 1 indication for catheter ablation. Of course, you have to consider the patient's choice. The AHA scientific statement for management of heart failure summarizes this very nicely. And so these patients, after the guideline-directed heart failure therapy, risk factor modification, oral anticoagulation based on the Charles-Vass score, you evaluate these patients for rhythm control by catheter ablation. Now, so they listed patients who are likely to benefit from catheter ablation and those less likely to benefit. So I just want to show you the ones who are less likely to benefit from catheter ablation. So these are patients with advanced heart failure, NYHA class 3, 4, significant scar on MR, advanced heart failure, severe atrial myopathy, advanced age, or significant comorbidities. So, ladies and gentlemen, I would like to conclude here by highlighting that AF and heart failure commonly occur together. Atrial fibrillation adversely affects the prognosis of patients with heart failure. Antiarrhythmic drugs are associated with significant adverse effects. Atrial fibrillation, on top of guideline-directed medical therapy, improves clinical outcomes and mortality in heart failure patients. And it's a preferred management option for most heart failure patients with atrial fibrillation. I'd like to thank you for your kind attention. Thank you.
So without wasting much time, I would like to invite Dr. Sanjeev Sidana for his presentation on drug therapy for AF, rate as well as rhythm control.
Good evening and warm welcome in AF Summit. So the topic given to me is pharmacological management of atrial fibrillation. So the Novex part I will not take care, I'll because that has already been spoken by Dr. Vivek. So I'll just discuss with the rate control drugs and rhythm control drugs. So first coming to rate control is an integral part of AF management. It is often sufficient to control symptoms of AF. And drugs mainly used for rate control are beta blocker, calcium channel blocker, and digoxin. Beta blocker are definitely the most effective and first-line agents. In a PALM trial, 70% of the beta blockers, patients who were on beta blockers, they achieved good rate control as compared to 54% in the calcium channel blockers. Calcium channel blockers may be preferred for the patient who has got normal LV function and severe COPD, and they should not be used in patient with the reduced ejection fraction. Verapamil and diltiazem, they are equally effective. Digoxin is less effective than beta blockers or calcium channel blockers, and it is not effective in the high adrenergic states, and amiodarone should be used as a last resort only. Now coming to strict versus the lenient heart control. So this concept was studied in the RACE trial, and which compared the lenient control, that is resting heart rate of less than 110, with the strict control, that is resting heart rate of less than 80. And no significant difference was found as far as the primary outcome was concerned. And so we can say that lenient control is the non-inferior to strict control, and lenient control should be acceptable initial approach with the exception of tachycardia-induced cardiomyopathy or patient who remains symptomatic despite the lenient control. But in this trial, all the patients who were included were the young, relatively young male patient who did not have much of symptoms, and they were ambulatory. And mostly these patients are not encountered in our clinical practice. And a long-term effect of rapid heart rate in response to AF on ventricular function were not studied because this trial was only for 3 years. And if we continue to on lenient control, then we should monitor the LV functions regularly. And the similar results were found in a PALM trial also. These are the drugs which are used for the rate control, that is metoprolol, available in both IV and basal oral. The metoprolol succinate is used as an oral formulation. Bisoprolol, atenolol, and esmolol, they are in oral form. Esmolol and lindalol are IV preparation, and nebivolol, cardiolol, again they are in oral formulation. The calcium channel blocker, non-dihydropyridine calcium channel blockers, they are verapamil and diltiazem. They are available in both IV form as well as the oral form. And the oral form for maintenance are doses are 40 mg BID to 480 mg in extended release, and 60 mg TID to 360 mg for the diltiazem.
Digitalis can also be used both as IV as well as oral formulation. And the other drug is amiodarone, and which should not, generally it should not be used for rate control only. So this is the outline of rate control therapy. It should be background therapy in all the AF patients. It should be the first choice for a patient who has got no symptom or minor symptoms. And it should be therapy whenever the rhythm control therapy fails. And it should be therapy when the risk restoring sinus rhythm outweighs the benefits. Initially, we should aim at a linear control, that is heart rate of less than 110 beats per minute. And then if patient remains symptomatic or patient is on has got a deterioration in LV function, or patient is on CRT, then we should aim for the strict control, that is heart rate of less than 80. And we should assess the heart rate during exercise also, and there should be a gradual increase in the heart rate, that is less than 110 beats per minute at the 25% duration of maximal exercise time. And we should perform the 24-hour Holter monitoring for safety. And in CRT patient, we should assess continuously for biventricular pacing. And we should consider rhythm control or active ventricular or near ablation if symptoms persist, or there is deterioration in LV function or tachycardiomyopathy persist, or when continuous biventricular pacing with CRT cannot be achieved. And this is how we should proceed for the drugs. First line treatment for patient who has got hypertension and normal LV is beta blocker or calcium channel blocker. For patient with reduced ejection fraction, the first line therapy is beta blockers. And if patient has got pre-excitation, then definitely the first line therapy is ablation. And if patient does not have adequate control with the single drug, we can add the second drug. For patient with normal LV, the second drug should be a calcium channel blocker if patient is on beta blocker. For patient with heart failure, the second therapy should be a digoxin. And for patient who has got a COPD or severe asthma, then a patient should be given either calcium channel blocker and digoxin. And if patient still remain symptomatic or patient doesn't get adequate control, then we can proceed for the third drug, or we can go for the antiarrhythmic therapy for sinus rhythm restoration. These are the guidelines. The beta blocker, calcium channel blocker, they have been given class 1 recommendation. If patient has got ejection fraction of more than 40%, beta blockers and digoxin are recommended as a class 1 agent if ejection fraction is less than 40%. And the combination therapy has been given class 2A recommendation. A linear control has been given class 2A recommendation. And if patient is not a candidate for antiarrhythmic therapy and patient is not eligible for the ablation, then antiventricular AV node ablation with pacemaker has been given a class 2A recommendation. And patient who has got hemodynamic instability and severely depressed ejection fraction, then amiodarone can be used, and it has been given class 2B recommendation. So now coming to rhythm control, it is a primary indication of rhythm control is to reduce the symptoms and improve quality of life. AF progression is associated with decrease in quality of life, and if patient remains in AF for longer time, they may become the AF become irreversible. Therefore, decision for rhythm control should be taken early in the course, and rate of AF progression is significantly lower with the rhythm control. And active informed patient should be involved in the decision making, and choice of specific agent is based on type and severity of associated structural heart disease. So this rhythm control is a class 1 recommendation for to improve the quality of life and symptomatic control. These are the drugs which are used for the acute conversion of AF into the sinus rhythm, that is plaquenil and propafenone. They are class 1C drugs, and they should not be used in ischemic heart disease with the significant structural heart disease, that is significant LVH. They may induce hypotension and atrial flutter with the 1:1 conduction, so they should be given in the background of AV node conduction blockers. And the flecainide may induce mild QRS complex widening, and we should not use it in the patient with atrial flutter. Then Varnacalant, it is used for the acute cardioversion in the IV formulation, and it is given 3 mg per kg over 10 minutes. And it should not be used in patient who has got hypotension, that is systolic blood pressure of less than 100, recent ACS within 1 month, and NYHA class 3 and 4 heart failure, and prolonged QT or severe aortic stenosis. It also may cause hypotension, QT prolongation, QRS widening, and non-sustained ventricular tachycardia. It may cause phlebitis also. Then amiodarone may cause hypertension, bradyarrhythmia, and AV atrioventricular blocks and QT prolongation. It is an option only if no other option is available and patient cannot be given any other drug, and it should not be used in a patient who has got thyrotoxicosis or hypothyroidism. Then ibutylide, it is very commonly used, and for the pharmacological cardioversion, it is given in the dose of 1 milligram over 10 minutes, and dose can be repeated after 10 minutes, and it should not be used in the setting of without any cardiac care unit setting, because it will also cause the QT prolongation and may cause the TDP, and continuous ECG monitoring should be done at least for 4 to 6 hours. This is a class of recommendation for the drugs for acute pharmacological cardioversion. Varnacalant and the flecainide or propafenone should be used in absence of structural heart disease. It is a class 1 recommendation. Amiodarone can be given in the patient who has got structural heart disease and heart failure. It is a class 1 recommendation. Patient who are on either electrical or pharmacological cardioversion is recommended in symptomatic patients with the persistent AF as part of rhythm control, because if we are aiming for rhythm control, then we have to cardiovert the patient, and pre-treatment with amiodarone, flecainide, and ibutylide can be done to improve the efficacy of electrical cardioversion. It is a class 2 recommendation. And in patient who has got very infrequent episodes who are not symptomatic and not eligible for then they can be given pill in the pocket, that is flecainide and propafenone can be given with the patient who has got very infrequent episodes, and this is a class 2 recommendation. And for patient with the sick sinus syndrome, the active ventricular conduction disturbances or prolonged QTC of more than 500, the pharmacological cardioversion should not be attempted unless risk of proarrhythmia and bradycardia has been considered. Now coming to the drugs which are available and how to use them. If we decide to proceed for the rhythm control strategy, we should take care of the stroke prevention, the rate control, as well as we should take care of the cardiovascular risk reduction, and AV nodal blocking agent should be started to control the rate. If patient becomes asymptomatic, then we can continue with the rate control. And if patient remain symptomatic, then we should consider whether patient has got favorable rhythm control factors or not. That is, patient is young, it is a first episode, then patient is developing a tachycardia-mediated cardiomyopathy, normal or mildly increased left atrial volume index, and no few comorbidities, then rate control is difficult to achieve, and AF precipitated as a temporary event. And if it is patient choice, then we can proceed for the rhythm control, that is with the antiarrhythmic drugs. So the principle of antiarrhythmic drugs is that it is to reduce the symptoms, and the efficacy is modest. It leads to almost 50 to 60% of the reduction in the episodes, and clinical successful antiarrhythmic therapy may reduce rather than eliminate the recurrence. And if antiarrhythmic drugs fails, then a clinically acceptable response may be achieved by other drug, and it may cause proarrhythmia and a lot of extra cardiac side effects. And safety rather than the efficacy should be considered first to guide the choice of antiarrhythmic drugs. So I'll not go into details of various drugs, and just this is the guideline how to choose the various agents. And if there is none or minimal structural heart disease, then we can give them the dronedarone, flecainide, and propafenone. It is a class 1 recommendation, and sotalol is a class 2B recommendation. If patient has got recurrent AF with these drugs, then we can proceed for the catheter ablation. And if patient has got CAD, heart failure with preserved ejection fraction or significant valvular heart disease, and if it is a patient choice, then we can go for amiodarone, dronedarone, or sotalol. Amiodarone and dronedarone are class 1A, and sotalol is class 2B. And if patient remains symptomatic or recurrent AF, then we can go for the catheter ablation. And if the patient has got heart failure with reduced ejection fraction, then the amiodarone is class 1 recommendation. So these drugs should also be considered to reduce the recurrence of AF because of their positive impact on the ventricular remodeling. Thank you. Thank you. I think the question answer will be taken last.
Thank you, sir. So The next talk will be given by Dr. Shomu, Management of AF in special situation. It's a very important actually talk because a lot of time we have hyperthyroidism, COPD, CKD, stroke patients, what to do in these kind of patients. Dr. Shomu will brief you.
Thank you once again, respected chairperson. In the last talk we have discussed regarding the CAD patients and also how to manage ischemic stroke. So I would go further. Lone AF is what people have guidelines on, and that is the most important study topic. And these guidelines now have come up with special situations. So what is important is they have addressed these special situations, but except in India, rheumatic heart disease is prevalent, though it is decreasing. It's very important that local cultural medication availability and everything should be kept in mind. So that's very important because people would say catheter ablation kar do, but then what, where, how? That is very important before you tell a patient. So these special situations should be addressed to in view of cultural as well as availability of procedures. These require individual. Many a times they give us a restricted medical or invasive management, and here anticoagulation is the backbone even if the CHADVAS score is low. NOACs sometimes may be inappropriate, and some medications cannot be given in patients like flecainide with structural heart disease cannot be given. So I would keep these special situations in these groups: valvular heart disease, WPWAF, HCM, inherited arrhythmias, which we now commonly see. And these are the most important thing would be secondary causes of AF. Heart failure and LV dysfunction has been already been discussed, but others like pregnancy, renal dysfunction, they are a topic in its own. And it's just that you have to modify the drugs rather than the approach itself. So valvular heart disease and atrial fibrillation is very important that we see. So when do you say valvular heart disease? What is the definition of valvular heart disease? It currently refers to patients with mitral stenosis, moderate or severe, or patients with artificial heart valves, not with even bioprosthetic heart valves. So artificial heart valves or moderate to severe MS are valvular heart disease. AF is more common with mitral heart disease as compared to atrial aortic, and up to 40% may have atrial fibrillation. And all such patients with a valvular heart disease, you should give a systemic anticoagulation, and that should be a vitamin K antagonist in these patients. So that's very important. The important point is disease process also contributes. So if you go on treating atrial fibrillation, it will not help. Valvular heart disease also has to be treated either by surgery or by a transcatheter route. Rheumatic heart disease patient, even if you treat, the disease is progressive. So in those patients, even if you give a bioprosthetic valve, anticoagulation continues in terms of oral vitamin K antagonist. Obstructive lesion, especially patients with ventricular hypertrophy, are very vulnerable. The moment they have atrial fibrillation, they'll decompensate. And development of atrial arrhythmia, it's an independent risk factor. So if you see the guidelines, mitral valve disease, if you have like mitral regurgitation, if the patient develops atrial fibrillation, even if asymptomatic, surgery is recommended. So if the patient is asymptomatic, severe MR is there, you have to advise surgery or correction of mitral regurgitation. And in mitral stenosis, it's a class 2B indication. So if you have MS asymptomatic severe, you have to recommend surgery because it says that the disease is progressing to such an extent that now you are getting atrial fibrillation. Medical therapy, rate control is important. Achieve sinus rhythm is important, but unless you correct the valvular heart disease, you are going back to atrial fibrillation. So it's very important to maintain sinus rhythm by drugs. Cardioversion, if the patient decompensates immediately, and especially in the patient, even if unstable, if the patient is unstable, you immediately give anticoagulation to the patient. Doing a TE and then seeing may not be the correct choice. You just anticoagulate, give heparin, and then cardiovert the patient if unstable, and then continue it for long term. Ablation in such valvular patient is less effective. Non-pulmonary vein sites are there. Therefore, just doing a pulmonary vein isolation is not very feasible. and generally reserved in refractory cases, and you may end up in doing AV nodal ablation plus pacemaker. Now, importantly in valvular, when you are sending for surgery, you can actually do a ablation during surgery, which many of us would not advise also, but the surgeons can do a MACE procedure, or they can actually do with the cautery itself, isthmus line, as well as a correction on the left atrium also. So surgical MACE during valvular surgery should be advised in patients who have atrial fibrillation. Even LA appendage ligation can be done surgically. So that's very important. And many surgeons do a LA reduction surgery in patients who have a large left atrium. So if you have a patient valvular heart disease going in for surgery, advise the patient for surgery. For atrial fibrillation also, because the patient symptoms later on post-surgery will be due to atrial fibrillation. So this is a case history of a 75-year-old lady who presented with sudden onset breathlessness and had pulmonary edema, and a systolic murmur was used, and you can see LVH with strain pattern, atrial fibrillation, and immediate heparin and cardioversion was done. Get back to sinus rhythm and then evaluate. Echo showed severe AS. So now what do? You give beta blockers, you give amiodarone for rhythm control, anticoagulate at least for this, because the patient is having a CHAD-VASc score of 273, female as well as age more than 65. But because the patient CHAD-VASc is not for valvular heart disease, you have to give for any patient who has valvular heart disease anticoagulation, and then you plan a AVR or a TAVI in this patient to reverse the problem. What about rheumatic heart disease in patients who have chronic atrial fibrillation? Like this patient has atrial fibrillation and the LA size is very large. You can go initially for rate control, reassess. The LA size is more than 60 millimeters. So just rate control is important in these patients. Once heart failure is resolved by amiodarone and digoxin and diuretics, you can then change to achieving a target heart rate, but long-term anticoagulation is a must. Now, when this patient goes for MVR, you have to do a MACE procedure, a LA reduction surgery, as well as a tricuspid valve repair, because the patient had severe TR also. Ablation will only be reserved for post-surgical arrhythmias, if any. What about WPWAF? Now, up to 5% of WPW patients have they present with AF WPW, and they can degenerate into ventricular fibrillation, and it's common with posterior multiple pathways with congenital heart disease, especially HCM. Immediate treatment is cardioversion. You can give procainamide and amiodarone if the patient is hemodynamically stable, but long-term treatment of choice is ablation, no doubt on that. So this patient presented with a fast, broad, irregular tachycardia. Irregular fast, broad is generally WPWAF. Immediate cardioversion or IV procainamide, which is not available, but you can give amiodarone with DC cardioversion backup. But never give beta blockers alone, never give digoxin alone, never give adenosine alone, as it may degenerate into ventricular fibrillation. Now, anticoagulation for this is not warranted, except you can give heparin during the thing. You do an ablation, the WPW is gone, you don't need to treat atrial fibrillation per se. So there is no pulmonary vein isolation required otherwise. What about congenital heart disease? You are going to see more often. Generally, it is a flutter. The incidence may be as high as 30%, with an increase in adverse event, mortality, morbidity, and heart failure in these patients as they grow up. Epstein's anomaly is commonly associated. You can give medications, beta blockers, and flecainide has been used by pediatricians very well. Amiodarone and sotalol has also been used. Ablation is the preferred form of therapy, especially for atrial flutter ablation. Surgically, it may not be very convincing to do just an ablation for that. But when it is associated with repair surgeries, you can actually make lines, complete lines, so as to prevent a flutter from occurring later on. So this child, severe Epstein's with post-Fontan, and the patient had atrial flutter, and Fontan patients, that will decompensate immediately as the atrial arrhythmia occurs. We added flecainide after amiodarone plus beta blocker, maintain sinus rhythm, but then you don't want to give such patients amiodarone long term. So an ablation was carried out through a Fontan, and then the patient maintained well. Importantly, hypertrophic cardiomyopathy, if they have atrial flutter or fibrillation, anticoagulate them. They are high risk. and they respond poorly to any form of drug therapy as well as ablation. So most of them will require rate control, and secondly, they may end up in having a AV nodal ablation. Along with that, you have to give a dual chamber AICD or a pacemaker. Inherited cardiac arrhythmias are not uncommon, but the problem is these patients are at higher risk of having thromboembolism, as well as drug therapy is limited. You cannot give amiodarone in such patients. You cannot give flecainide in all these patients. So you need to know whether it's long QT, short QT, and Brugada, and quinidine can be given in patients with Brugada. So such patients can be seen. This is very important. I would take 2 minutes in this. Secondary atrial fibrillation. Up to 31% of patients have secondary atrial fibrillation, which people fail to recognize. They can be the first manifestation of an infection, pericarditis, and this is shown in Framingham study. Even we have done a study where 30% had secondary atrial fibrillation. Patient can present atrial fibrillation as the first in coronary artery disease. You have to just cardiovert these patients and then revascularize, and that's it. Post-alcohol, many patients have, if you ask a history post-alcohol, they present, you don't need to do anything else. This is a resident who had atrial fibrillation as a first, and actually the cause was tuberculosis. Treated tuberculosis, is not on any drugs, no anticoagulation, nothing is required. This patient had an atrial tachycardia with an external mass, just pericardial large mass, and then you treat that and that's done. This patient presented with atrial fibrillation, you evaluate, and then the patient had CA breast with multiple metastases. So if you give anticoagulation, you will have bleeds. You have to find out what is the cause of atrial fibrillation before going in for these therapies. This patient had an angiosarcoma, atrial fibrillation as the first. In fact, patient who present with menstrual related atrial tachycardias, you just give hormonal therapy and that's it. So these are special situations where ablation won't work. You have to give them specific therapy. This had a AV fistula. You close the AV fistula, you cannot do pulmonary vein isolation for this. So that's very important to have secondary. And the last was sarcoidosis. These were chemotherapy ports. The line is there in the atrium and then causes atrial fibrillation. What do you want to do with this? You remove the port, that's it. So secondary causes are very important. Look for them. So when you should suspect for secondary causes, young patients, acute history, systemic symptoms like cough, patient has pericardial effusion, low EF, patients who have STT changes, you should see whether this is an associated pericarditis or myocarditis. So concluding, look for secondary causes. Special situations should be identified and treated according to the local available therapies. Patient symptoms are very important. You relieve either by maintaining sinus rhythm or rate control, either of them. Tailored therapies for anticoagulation, and you use special drugs. Ablation and surgery should be offered if they are going in for a specialized procedure, and long-term follow-up is required because they may develop later on cardiac problems. Thank you.
Thank you, Dr. Shomu, for a nice talk. Now we have a talk by Kush, guidelines for management of atrial fibrillation.
Thank you so much, sir. So I think most of the things have already been discussed by Dr. Sedana and Dr. Vivek on Novax and the drug therapy.
Kush, let me ask one question from Shomu for the benefit of physicians. You said in WPW on atrial fibrillation, never give beta blocker, never give digoxin, never give adrenaline. Why? What happens?
Yeah, so only if you give that the AV, so these beta blockers, digoxin, they will act on the AV node. They'll decrease the conduction via the AV node. However, it doesn't affect the pathway. So the pathway conduction is actually increased. And once that is increased, the irregularity to the ventricular stimulation is increased and it may degenerate into ventricular fibrillation. So if you have AFWPW, you give beta blocker, actually you may degenerate into ventricular fibrillation. The conduction, see, when there are two things going together, one, there is a competition between AV node and this. So yes, so once the AV node stops that, you stop that conduction, everything goes via the pathway. So amiodarone, as they said amiodarone alone is actually contraindicated in guidelines, but actually we had done a study and it's published in IPJ. Amiodarone, around 10% of patients may cause hemodynamic instability immediately. And as a backup, if you have a DC fibrillator, then you can still give because you don't have procainamide here. What is the other option? Cardiovert? Yeah. So most of the physicians would agree they will not want to do that. They will not want to do that.
So we have IV ibutolide as well. So IV ibutolide has shown good results.
Yeah. So again, for WPW atrial fibrillation, ibutolide can be given, but it has to be combined with the IV beta blocker again to be safe enough. Now, how many? Again, the problem is availability. Getting that ibutolide is not generally available on shelf. You have to half an hour goes in that. Do you want to wait for that?
So best is cardioversion.
Best is cardioversion.
So I'll be talking in brief about the catheter ablation. Excuse me, slides. So as far as guidelines are concerned, the NOACs and the drug therapy has already been discussed. So in short, I'll be discussing about the guidelines for management of AF from a catheter ablation point of view. So I think Dr. Makka has already discussed about paroxysmal, persistent, long-lasting persistent, and permanent AF. So we won't be discussing that. Just to tell that treatment of AF is very, very important because it can not only it can lead to stroke, but it can lead to LV dysfunction, heart failure, cognitive decline, depression, impaired quality of life, repeated hospitalization with heart failure, and it can also lead to death. So coming to the guidelines, so any patient who presents with symptomatic AF and who is refractory to or intolerant to at least one class 1 or class 3 antiarrhythmic. Just a moment. Yeah. So any patient who is refractory to either class 1 or class 3 antiarrhythmic medication and who is symptomatic, then if he is having paroxysmal AF, then it's a class 1 with level of evidence A recommendation. So any paroxysmal AF patients who have been given amiodarone or any other drugs, and despite that he is having AF episode, then it becomes a class 1 recommendation with level of evidence A for catheter ablation. Similarly, if patient having persistent AF, it becomes a class 2A recommendation. Now, even if patient is symptomatic and if we don't initiate an antiarrhythmic therapy, then also in paroxysmal AF, catheter ablation is a class 2A recommendation. So basically, in short, any patients with AF who is symptomatic, paroxysmal AF at least, who is symptomatic, it becomes a candidate for catheter ablation. So this is very important because we have a lot of patients who are having symptomatic AF despite medications. So the treatment option for those patients are definitely catheter ablation. Now, there are a lot of patients who have not been well represented in clinical trials. Like if we talk about heart failure, I think Dr. Gautam has already discussed. If patient is having heart failure, then it is becomes a class 2A recommendation for catheter ablation. And again, if patient is having hypertrophic cardiomyopathy, then also it's a very, very important to go for radiofrequency or catheter ablation for AF. And in tachybrady syndrome, so a lot of patients are there who is having, tachybrady syndrome. So it is reasonable to offer AF ablation as an alternative to pacemaker implantation in patients with tachybrady syndrome with a class 2A recommendation. And if patient is asymptomatic, so all these are recommended when patient is symptomatic. So if patient is asymptomatic, then even if it is paroxysmal, then it's a class 2B recommendation. So patient has to be symptomatic for catheter ablation. Now, as Dr. Shomu rightly mentioned, that any patient who goes for surgical, any surgery for MVR or AVR, any open heart surgery, and if patient is having atrial fibrillation, then AF treatment should be taken care of either by May surgery or by catheter ablation, and all mostly it is class 1 recommendation if patient is having atrial fibrillation and patient is undergoing bypass surgery. So a very small question. So he was a patient who was having recurrent paroxysmal AF with fast ventricular rate, and he was treated with beta blockers. And now patient presented with frequent dizziness. So this was the episode of AF, and then AF terminated and patient was having a normal sinus rhythm. So basically the diagnosis was thick sinus syndrome. So the question is whether we should go for pacemaker implantation or whether we should just reassure the patient or we can go for AF ablation. Obviously a matter of discussion, but just to emphasize that as far as guidelines are concerned, it becomes a class 2A recommendation, both in ACC and ASC guidelines. If we treat AF ablation, then probably patient won't be symptomatic after that because causes are present only after spontaneous AF termination. So it depends on patient to patient, basically. But yes, if we are sure that the Brady episodes happens only after AF termination, then we can give a choice of AF ablation as well. So again, a similar patient, he was a 45 years old male patient with recurrent paroxysmal AF episodes, and he was on amiodarone and beta blockers, and obviously an anticoagulant. But despite that, he was having a frequent episodes of atrial fibrillation. So a patient of AF who was given amiodarone, who was given beta blocker, anticoagulant, but despite that, he was having atrial fibrillation episode. So what should be done next? So then here comes the therapy of catheter ablation, and guideline recommendation is class 1 with level of evidence A, both in ACC and EAC guidelines. So this is how we do catheter ablation. Basically, we do ablation in the left atrium. So these are the 4 pulmonary veins in the left atrium. So this is 3D map of the left atrium. And these are the 4 pulmonary veins. And these brown dots are the radio frequency ablation points. And we have done isolation. We have just isolated the pulmonary veins from the left atrium. So this is how we treat atrial fibrillation. Either we treat it by radio frequency ablation or cryoablation. The basic motive is pulmonary vein isolation. So that is what is the guideline recommend, that pulmonary vein isolation is now widely accepted as the cornerstone of AF ablation procedure, and electrical isolation of all the pulmonary veins is recommended during all AF ablation procedure because more than 90% of AF triggers are found near the pulmonary veins. So yeah. So there are, apart from the ablation guidelines, I think someone was mentioning about the non-ablation strategies. Like Dr. Milind was mentioning that apart from these, the comorbidities should be taken care of, like loss of weight loss. If patients obese, we have to consult for weight loss. All contains a very, very good recommendation. So if patients having obstructive sleep apnea, then patient should be given, CPAP or home monitor. I mean, home CPAP therapy should be given to the patient. And so obesity and this sleep apnea should be taken care of. Similar guidelines in the ESC, which was published very, very recently. And just one thing, that it has given class 1 recommendation to reverse LV dysfunction in AF patients when tachycardia-induced cardiomyopathy is highly probable, independent of the symptom status. So basically, if patients come with LV dysfunction, and we are pretty sure that this LV dysfunction is because of tachycardia-induced cardiomyopathy, then it contains a class 1 recommendation for atrial fibrillation ablation. And again, pulmonary vein isolation is the hallmark for AF ablation. Just I try to be brief.
Push, tell me one thing.
Yes, sir.
That you got a patient with heart failure, low ejection fraction, and atrial fibrillation. So how do you decide is it tachycardiomyopathy or AF is secondary to LV?
Sir, it's very difficult. Probably it's
so how do you approach for the benefit of physician? Yeah. How will you approach this patient?
So a lot of patients are there. So if a patient has a history of, if patient has a history of atrial fibrillation, and sir, it's very difficult to diagnose basically.
There are few things which you can do is, if you see the records of the patient, if the patient was in LV dysfunction, that time the rhythm was sinus. You have multiple. See all the ECGs, all the holters of this patient. You have to spend a lot of time on these patients. But if you see 2, 3, 4 holters, for example, every holter shows fast ventricular response. That's one patient where you should consider tachycardiomyopathy. And secondly, you rigorously control the heart rate with medication. And if it's a tachycardiomyopathy, they improve very fast. You know, just give a trial of 1 month or 1.5 months, control the heart rate, tachycardiomyopathy patient will improve very fast.
Okay, then we can go for catheter
Then you
ablation.
can consider, yeah, catheter.
Point taken.
I think we have Dr. Gautam also for some discussion, so we can combine him as well. So Dr. Suresh Gupta, our director, head of department neurology is here. I thought it will be very useful to have a neurologist amongst us. Sir, in the previous sessions, we were discussing about using Holter or external loop recorder monitoring to diagnose AF in stroke patient. So there was an interesting point came out that whether every stroke patient should undergo screening for atrial fibrillation, or there are any methods to see that whether it is cardioembolic, or if you are sure that cardioembolic, then only go for AF screening. How do you approach these patients?
हाँ वो क्वेश्चन हाँ अभी थोड़ी देर में करता हूँ मैं किसी के साथ बैठा हुआ हूँ मैं कौन है
for screening, long-term monitoring and smartwatch and new devices, which I am not very well versed, but in these patients of stroke of undetermined etiology, at least 20% patients will have underlying atrial fibrillation. So I think all these patients should be screened for atrial fibrillation.
Are there any methods to differentiate between a cardioembolic stroke or stroke happened otherwise due to atherosclerosis, brain atherosclerosis?
So there was a discussion going on regarding the radiologic findings, sir. How can we differentiate radiologically whether it's a cardioembolic stroke or non-cardioembolic stroke?
So there's on CT scan or MRI scan, if you see in PAC, there are areas spared in between. Infarcted area, normal area, infarcted area. This gives the impression of embolic stroke. But I'm not really very sure how to differentiate.
Okay. I think perhaps there is no way to differentiate cardioembolic versus atheroembolic from the carotid vessel. But the strokes from the heart, because of atrial fibrillation, they are likely more recurrent. What he said is very correct. If you have multiple areas of, but same thing can happen in atherosclerosis. I think whenever there is a stroke without a reason, we must look for AF. I think there's no doubt, but there's no guideline how long we should look for 24-hour Holter, 48, ELR, and blah blah. Because if you put the patient on ILR, the positivity rate of AF increases much more fold as compared to just 24-hour Holter. I think 30% of so-called strokes without any apparent reason are because of AF if you follow them long enough. It's just a question of follow-up, how long you follow these patients. Now the question which I want to ask Dr. Sneh is that what is your latest thinking on young stroke, the role of a patent foramen? In a young stroke, 20 or 30 years boy or a girl, he comes with stroke, heart is normal, but how much is the contribution of the patent foramen?
Yes, the patent foramen ovale is one of the important causes of stroke in young, though the incidence is less, but all the patients should be screened for patent foramen ovale if the cause is not very obvious.
So how many patients you have found so far in your career who were because of PF and you ordered them to closure of the PF?
Before closure of PF?
Yeah, we can close the PF very simply. But how many patients you referred for closure of the PF?
Very few.
Thank you.
Thank you, sir. Yes. Sir.
Is there any difference in the treatment, what we are discussing, a cardiac embolic stroke or a stroke which is from atherosclerosis? I feel sometimes as a cardioembolic stroke, they respond very well to the treatment better than the atherosclerotic stroke.
Talking about the treatment part, the embolic stroke, obviously they have a better prognosis as compared to thrombotic stroke. But as sir said that if there are multiple strokes, different territories are involved, then they are probably of cardiac origin, but the same territory again and again stroke is occurring. This is probably because of arterial disease, carotid artery most probably.
Sir, is what when we diagnose it that it is in cardioembolic stroke, should we start with the DAPT, what we usually do in stroke, or we go for triple therapy along with anticoagulation with the DAPT for the treatment part? Dual antiplatelet along with the anticoagulation. If we diagnose it to be an cardioembolic stroke.
As far as the dual antiplatelet therapy and anticoagulation is concerned, there are no studies that we should combine aspirin and anticoagulation. There is no definite study. But I think in an embolic stroke, the best way to treat them is use of anticoagulation.
So then you combine anticoagulation?
Rather than going for antiplatelet.
Sir, what you do with the young patient with this cardio diagnosed to have a cardioembolic stroke? There was LV dysfunction, need cardiac clot in that, and that is embolized. So what you usually give? You give with the ecospin clopidogrel or only the anticoagulation? How you treat that?
Preferably only anticoagulation.
Only anticoagulation.
Yeah.
Dr. Gautam is there with us. Gautam, can you hear us?
Hello.
I think he's here.
Yeah, Gautam, can we see you or you are in Bermuda?
So I'm not in Bermuda, but I'm not really in the best shape, as you know.
Yeah, I know you were not well today, and still you joined. Thank you so much. Thanks.
No. It's always a pleasure. Can you see?
Yeah, we can see you.
So I listened with great interest to a couple of talks, and Dr. Shomu Bora's talk about the role of atrial fibrillation, ablation. In context, the Indian context was very nice, and I don't know if the audience had any questions pertaining to heart failure in AF. So I would be very happy to answer that.
Yeah, so there was a discussion going on with Dr. Claire here. Yeah, you're listening?
Sorry, now I lost you there.
Yeah, so there was a discussion going on here before some time with Dr. Claire that it will be a very good idea in AF and heart failure to do AV node ablation and CS pacing, conduction system pacing. So any experience you have had so far and any comments on that?
So there was this, early on, there was this PABA CHF trial wherein they looked at AV node and ablation and pacing, and some of the patients received CRT. I don't remember the exact percentage, but that was compared to ablation. And what they found was that ablation was superior. But large randomized controlled trials are lacking, especially because now ablation itself has proven to be of, the Castle AF study, the camera MRI study, you name it. There have been so many studies now. And now this RAFT AF study, especially for LV systolic dysfunction, that is heart failure with reduced ejection fraction. Ablation has not only improved ejection fraction, but also improved outcomes, especially now we have proof of mortality benefit. So I think that question is a little, probably that could be reserved for patients who cannot go ablation, like the patients with advanced heart failure, patients with comorbidity.
As a rate control strategy only, not as a rhythm control, but as a rate control strategy only. If we
rate control, that question has been more or less addressed. So that question has been more or less addressed. I think there is little doubt that when you can ensure rhythm control, it is far superior.
So you are convinced now that AF with heart failure is some situation where there is no doubt that rhythm control is better than rate control. At least here we can conclude in AF with heart failure.
Yes, but with a corollary that the heart failure should not be that advanced. there is a Castle AF2 trial coming up, wherein they're looking at the LV scar. LV, we often forget about the left ventricle when you're talking about atrial fibrillation, but it's very important to look at the scar because it's one disease, and they're going to assess whether the scar load determines the outcomes. So advanced heart failure did not prove to be that good. The therapy did not prove to be that good even in Castle AF1 study. So and they clearly showed that ejection fraction of less than 25% did worse with ablation. So if the disease is advanced and they are very elderly, comorbidities, then probably you should be a little hesitant. But you have no option. For example, Shomu was talking about hypertrophic cardiomyopathy. And I think Professor Claire would agree, and Vivek is also there. And these are the patients who really need that atrial kick, because of their diastolic dysfunction. And once AF sets in these patients, it's catastrophic. So we did, knowing very well that the results are going to be not that good. We've had some experience with hypertrophic cardiomyopathy in AF ablation, and surprisingly, the patients did well. Not as bad as what we would have expected. So we can still attempt trying to help these patients, but as per the clinical need.
Gautam, this is clear.
Sir,
see,
sir, good evening.
What I feel personally that in atrial fibrillation, I think our strategy should be reversed now. It should be from, first of all, we try to prevent atrial fibrillation. When we say prevention, for example, we go on delaying the mitral valve surgery in patients with severe MR and disorders like that. By the time when they develop AF, then they become chronic AF. If we operate them early, I think the AF can be avoided in those patients. Similarly, AF should be treated or ablated early rather than delaying, rather than thinking about failure of therapies. Because earlier you treat the AF, the better it is. Similarly, hypertrophic cardiomyopathy, for example, Shoma showed that the results are not as good. But I feel that if we ablate early in those patients, then you can have a better result long term. So I think the solution is the pendulum is changing in the Western civilization that earlier part of the AF ablation, if you ablate AF, it begets AF. So earlier and as far as early treatment is concerned, that is better strategy. This is what I feel.
Absolutely right, sir. I agree with you 100%. And you have the results of the East AF NET trial, which have shown that, if you adopt a rhythm control strategy early on, you have benefits. And there is this ATTEST trial by Karl-Heinz Cook, as you would know, sir, where they've again shown that the natural progression of atrial fibrillation is halted if you intervene early. So, and it makes sense because the substrate is more amenable to ablation. If you wait, as you very rightly pointed out, the substrate would be so far gone, then no matter what you do, the atrial myopathy would not reverse. There wouldn't be any reverse remodeling, and the patient would not benefit. So I think it's very pertinent, very right, sir, that we need to intervene. The earlier we do, the better it is. But of course, it has to be with the patient's consent, and it has to be at centers with adequate experience, because there is a complication rate associated with this procedure, which is not negligible, even though the large centers have now shown it to be less than 1%. But for India, that also needs to be kept in context. But yes, earlier the better.
So I just wanted to make a point here. As a routine in all CHF patients, I especially almost all of them are persistent. Paroxysmal is hardly there. At least in India, I've never seen. Invariably, I will at least try once at least to bring them into sinus rhythm. So I've done ablations in these people, but by the time they come in India, especially HCM, their LAs are more than 6. Ablation, I've gone inside LA and it's all scarred. It's unlikely that definitely cardioversion. And surprisingly, they may require more than one cardioversion in a year, but I think it is still worthwhile to keep them on a small dose of amiodarone, and they may slip back into AF. You again cardiovert them, but I think because there is, except transplant, there is nothing else left for these people. If their tick is gone, their heart is already, almost all of them go into end stage systolic dysfunction. So cardioversion is a very powerful tool which is very underutilized in India.
So Vivek, you're very right. And I must tell you that for persistent atrial fibrillation, long-standing persistent atrial fibrillation in patients with heart failure, that is the strategy that I'm adopting more and more. I give them a trial of cardioversion, especially if the LA is big. Cardioversion with low-dose amiodarone, as you said very rightly. And that's a test for me to see whether these patients would remain in sinus rhythm with this cardioversion and a couple of months of amiodarone, maybe a couple of cardioversions as well. So if they do, then obviously, as you know, there'll be reverse remodeling and the left atrium would also regress slightly, and that'll encourage me to think about catheter ablation. But that is a strategy that I adopt and we adopt at AIMS for advanced heart failure. But for early heart failure, that means there's no gross structural dilatation or structural damage. Ablation as a first strategy, early strategy, would probably be better. So you have to choose. So for persistent, long-standing AFib, advanced heart failure, maybe cardioversion, low-dose amiodarone, see how they go. If they remain in sinus rhythm, you're encouraged to think about ablation. If not, then probably rate control with the other possibilities that we were talking about. And for early heart failure, as Dr. Claire said very rightly, if you catch them early, this is the time when you can make a difference.
Gautam, last question I would like to ask you, that we know that we are talking about heart failure and AF ablation or keeping them in normal rhythm in a reduced ejection fraction. But is there any thinking or a trial going on ablation in patients with the heart failure with the normal ejection?
So that's again a very interesting question, sir, and that was addressed in this Anthony Tang's RAFT AF study recently presented at the ACC, and there they showed that. So they took patients with ejection fraction of less than 45% and more than 45%. So which is like reduced ejection fraction and preserved LV function. So when they dichotomized the results, they saw that there was a benefit in patients with reduced ejection fraction when you ablate the AF, but there was no benefit in terms of mortality for these patients with preserved LV systolic function. So with preserved function, there is, as of now, no data to say that ablation is better.
I think we should end this session.
Thank you once again, Dr. Gautam. Thanks for joining.
Sorry, I couldn't come in person, but next time.
Next time, sure. Thank you.
Thank you so much.
Thank you so much.
One question, we have got different drugs, what about your experience with the flecainide and propafenone and pill in the pocket? Because flecainide, propafenone.
Dr. Sidana,
because we are just using amiodarone, beta blockers, calcium blockers.
No, I think for those who don't have structural heart disease, no heart failure, no coronary artery disease, no concentric LV hypertrophy, class 1C are undoubtedly the first line drug. Whether you go for any guideline or evidence, everything. Amiodarone is too much for this kind of situation. Only in heart failure patient with LV dysfunction, hypertrophic cardiomyopathy, concentric LVH, amiodarone should be used. Otherwise, class 1C drug, flecainide or propafenone should be only choice for rhythm control in India, I think, which are being seriously underused.
Well, that I know, but have you used these drugs?
Yeah, very frequently. Very frequently.
Flecainide and propafenone.
Yes, flecainide often I use, but they should be used with beta blockers.
Yeah.
At least small dose of beta blocker if you are afraid of bradycardia, not without beta blocker for the fear of prolongation of QT. And maybe when we start, we can ask them to have a frequent ECG in initial follow-up, but once they start getting it, and I have not personally seen any torsat with flecainide at any dose.
Absolutely right. Although the recommendation is that for pill in the pocket, the first time you take it, it should be in hospital because you are taking a higher dose of 200 to 300 mg. But otherwise, as Dr. It's a very good drug. And really a very good drug if given in suitable patients. Beta blocker is necessary because if the AF also convert into a flutter, it would conduct very rapidly. So that's why you need EV nodal blocking. It can be beta blocker, it can be digoxin, it can be calcium channel blocker, whatever. Propafenone is also used, but it is available very irregularly. Sometimes it's available, sometimes it's not. Yes, they are exactly almost otherwise, and then it is twice a day. Propafenone is twice a day. That's another.
So thank you so much, all respected chairpersons. So for the next session, I would like to invite the management of AF, non-pharmacological management. I would like to invite Dr. Arvind Sharma sir, Dr. D.K. Garg sir, Dr. Dipesh Agarwal, Dr. Lalit Garg, Dr. Rakesh Mehla, Dr. Sanjay Khandelwal, Dr. Sohan Sharma, Dr. Sunil Beniwal sir. Sir, I would like also like to invite Dr. C.B. Meena sir. So please come.
Dr. Madhok sir is also here. Thank you very much, sir. Sir, आप join करें please. Abhi sir, we need you here.
So the talk is non-pharmacological management of AF, cardioversion, RFA, LA appendage occluto. And this talk will be given by Dr. T.S. Clare sir.
Well, actually, I think it has been a great pleasure to be here. I must compliment Jatinder, Dr. Jatinder and Dr. Kush. You're not listening. I must compliment both of you for having organized this symposium. Not only that, you have developed one of the best TP department in India, and I'm really happy about that. Well, a lot has been said, and my friend Madhok is also here. I'm happy to have him here. So a lot has already been talked about it. So I will be, I think, try to be a little bit brief. I think we have talked all those things. There are new developments like high power, short duration, RF ablation, heliostar, RF balloon ablation, pulse field ablation, cryo ablation. Well, basically, I think this we have already discussed. Rate rhythm control, we have talked too much already. I will stop it. Now, the thing which I want to tell you that beta blockers, somehow or the other, they lose their benefit in heart failure of the AF. So this is a trial to show that beta blockers are very useful when the patient is aneurysm, but beta block didn't make any difference in the outcome when patient in AF. I really don't understand why, but that's the reality which should be remembered. Now, when we talk about the treatment of AF, one has to understand that atrial fibrillation is not one disease. It's a combination of so many kind of things. And I always say that in atrial fibrillation patients, there is only one thing common, that the ECG is common, that shows AF, irregular heartbeat. Nothing else is common. Somebody is a normal heart, somebody is rheumatic heart disease, somebody is ischemic heart disease, somebody has a valvular heart disease. So there's a lot of variety of these patients, and that is why there's not a one treatment for atrial fibrillation. You have to modify your treatment according to the clinical scenario of the patient. So let's say we have a failure of these drugs like dronodrone, flecainide, and propafenone. Then patient choice is considered. We can have amiodarone, we can try another antiarrhythmic drug. But thirdly, if the patient is agreeable, catheter ablation, I think in the initial stages is rather very useful thing. If your amiodarone fails or you develop toxicity, Then again, patient choice, catheter ablation or some kind of hybrid therapy. If patient has already gone catheter ablation and there is a failure of ablation, which is not uncommon, actually 30% of the patient will have recurrences of AF ablation after at least one episode of ablation. Then again, you go to the patient choice, whether you want to repeat the ablation or you want to try another antiarrhythmic drug. So patient choice informed by AF heart team is very important. What do you want to do these ablations? A lot of speakers have talked about Mace surgery here, but I'm disappointed to say that nobody does AF ablation, Mace surgery in this country. I know 1998 or so, Dr. Rehan did the Mace surgery. It was all over paper, but I think that was the first and the last case he did of Mace surgery. I really don't understand why we don't do. Not many centers have picked up. We have so much of rheumatic heart disease patient going for mitral valve surgery, but people don't do AF ablation. Now, when we, it is not that we ablate and forget. That situation doesn't arise. There are people who are talking, please, behind. Hello? People are talking behind, please. Can you stop that? People who are talking behind, these pharmacological people, I don't know what they are doing. Okay, so it's not ablate and forget. We are treating the patient for AF. It is just like a slow cancer. We have to treat again and again new recurrences and this and that kind of thing. So it's a lifelong treatment for these patients. So another thing is that it's not a non-binary situation. Concept of AF is changing. We are talking about AF burden. In fact, it's not that you have a qualitative AF, but the more important is how much the burden of AF. So this is a new kind of concept. We want to decrease the AF burden. We may not be able to eliminate the AF. So when we talk about qualitative AF, paroxysmal hope, persistent, long persistent, but we want to know the longest duration of one episode, number of episodes in the monitoring period, percentage of time spent in AF, it becomes important. So treatment should be to reduce the AF burden as much as possible without increasing any risk to the patient. So this is a Castle trial, which I have already told that in heart failure, we have no doubt heart failure with decreased ejection fraction. Try to maintain these patients in normal rhythm as much as possible. Whether you do that with medication, amiodarone, or some other drug, or ablate them, the ablation threshold should be low in patients who have heart failure and atrial fibrillation. And this trial showed mortality benefit, of course. Then you have a trial, which is the Gavana trial in 2018, that also showed that it decreases mortality in new onset and undertreated patients by AF ablation. That's another trial to show that if we do ablation in earlier stages, it decreases mortality also. Now, why want to ablate AF? Patient get a lot of symptomatic improvement. Recurrent hospitalization are stopped. Prevention of heart failure, hospitalization and mortality prevention, prevention of tachycardia-induced cardiomyopathy, and we want to reduce the AF. Mind you, stroke prevention is not a reason for RF ablation, though if a patient after AF ablation remains in normal rhythm for 6 months or 1 year, and you are reasonably certain that you have cured the patient, anticoagulation can also be stopped. Now, treatment strategy is basically, I think Dr. Kush told you that primarily AF starts in the pulmonary veins. It's a left atrial disease. So because the atrial muscle sleeves extend into the pulmonary vein, so AF starts in the pulmonary vein. So we want to isolate the pulmonary vein from the rest of the atrium by ablation, so that even if there is AF in the pulmonary vein, it doesn't enter the main atrial chamber. But then there are additional, that forms the 90% of the patients, we just do pulmonary vein isolation. But some patients, they require additional ablation, like between the roof line, mitral isthmus, tricuspid isthmus line, and there are superior and inferior pulmonary veins. Sometimes we have to make additional line here, and posterior inferior line for the electrical isolation of the posterior left atrium and circle lesion on the superior vena cava sometimes. And there is something called cafe ablation. Cafe means that you go into the left atrium and the fractionated ECGs, areas of fractionated ECG need ablation, that also improves the results of atrial fibrillation. So it's a stepwise approach, mainly pulmonary vein isolation. Then you look for cafe in the main body of the left atrium. Then you isolate the left atrial appendage by a line there. Then there is a linear ablation and with the mitral line. So this is how it goes. AF ablation, first step is pulmonary vein isolation. Then add on ablation of cafes in the LA. If that doesn't help, then linear ablation in the LA like roof line or mitral isthmus line. If that doesn't help, go to the ablation of cafes in the right atrium. And sometimes you isolate the sphere pulmonary, as we see also in these patients. There are new techniques. This is called high power short duration AF ablation. I will not spend too much of time in this because many of the doctors here are physicians. There is called ablation index. Heliostar ablation is a new thinking. 12-speed ablation is going to come, which is called electroporation and cryoablation, and some of the centers have already in India. High power means that you have a high power 45 to 50 watt. It's given for few short duration. It's always you monitor the contact force with the catheter. It is a faster thing. Less RFA are needed on an average 20 minutes to 30 minutes for RFA as compared to 40 to 50 minutes with the previous technology. It is safer, more advanced, and technically more demanding. I think this is how it is. This is standard technique. This is high power short duration technique. We did 26 cases with this technology. 15 were paroxysmal, long persistent was 6 patients, atypical LA flutter was 4 patients, and pulmonary vein isolation alone 24 cases, lateral mitral isthmus additional 4, anterior mitral line 2 patients, roof line 6 patients, posterior wall. So tricuspid isthmus ablation 4 patients, and we had 23 no complication. One patient has a esophageal hematoma. Surprisingly, it didn't bleed into the esophagus. There was no communication, but there was the intramyocardial hematoma into the esophagus, and it settled down on follow-up. And we did endoscopy at 4 weeks, and there was a pericardial effusion in 2 patients. In these patients, overall, our this technology 80 to 90% success rate so far we have observed. There is something called Pentarray. Pentarray is a multi-electrode catheter. It's much faster to substrate, map the substrate. What happened, my dear? Just a minute. So I think these pictures have been shown to you, and I think for the shortage of time, I really think we can avoid these. And we, basically what you do is when you do the pulmonary vein isolation, you have to prove that there is no connection, electrical connection between the pulmonary vein and the left atrium by doing some mapping in these areas. We do some adenosine test in these patients. And this is how it looks like on the CARTO system. Let me go a little faster. We did a 6 months follow-up. These patients, most of the patients are asymptomatic in these patients. So high density, short duration is safe and effective in atrial fibrillation. Considerable shortening of the RF time. Procedure time is shortened. Esophageal temperature monitoring is very, very important in these patients. Different workflow is needed with different ablation parameters set up. Importance of sticking to time limits is to be stressed. Heliostar is another technology which is going to come. This is a multi-polar catheter, and there is simultaneous RF ablation from the individually controllable and programmable 10 bipole. There are 10 bipole, which is still not available in India. And this is a Heliostar balloon shown here. You enter the pulmonary vein and ablate between these 10 bipole. Again, shorten the duration of your ablation. And this is the cryo. This is the standard technique. Radiofrequency ablation. You go with the lasso catheter into the vein, and idea is to ablate just outside the ostium of the vein. You have a cryoablation. It is a short, you enter the vein and it decreases the duration of the ablation procedure, but it will ablate in a circumferential manner. The FIRE and the IC trial, they were done in paroxysmal AF to compare the efficacy of standard ablation versus the cryoablation. And this trial was a non-inferiority trial. That means cryoablation was non-inferior to the standard technique. The people who used both the technologies, many of times we have to do cryoablation and then, again do some lesion with the standard technology if there are some gaps between the pulmonary vein and the left atrium. Pulse field ablation is upcoming modality. It is supposed to be much safer. No collateral damage to the nerves and the blood vessels. Now, let me tell you, I think this is more important for physicians. Who is the ideal patient for AF ablation? Paroxysmal AF, especially in the initial stage of the disease, patients who have got almost normal heart with near normal LA value. That means the LA size up to 4.5, we think very encouraging to do the ablation. Patients who are highly symptomatic, some of the patients become terrible during AF ablation. Highly symptomatic, long persistent AF is also a good idea. Patients with atrial fibrillation and heart failure, we have already discussed, they are good candidates. Patients who don't want to take anticoagulation, ablation is a good idea to those patients. Maybe if they remain in normal rhythm, you can stop the anticoagulation patient. Now coming on the complication, no procedure is safe in the world. If you go to the meta-analysis of various trials, roughly 4.5% complications occur in these patients, though the serious complications less than 1%. What are those serious complications? Cardiac tamponade is one of the important things. Stroke, because you go to the left atrium, and if your heparin is not up to the mark, you keep the ACTs up to 350 or so, but sometimes you can have a clot formation on the catheter, and that can cause the thromboembolic episode. Pulmonary vein stenosis used to be much more common when we used to ablate in the pulmonary veins, but now we have come out of the pulmonary veins, so that's happening very little now. Phrenic nerve paralysis is one complication. One of the most serious complications is what is called atrioesophageal fistula. When you ablate when you give posterior line, the left atrium, the esophagus is very close. So if you over ablate, give more energy, you can produce a communication between the left atrium and the esophagus. And mind you, more than 50% mortality will occur if that thing happens. Acceptable risk of death, which is considered in the world, that if you do 1,000 procedures, one patient should die. That is maximum acceptable. If more die, then that means you are not doing something good. Now, the risk increases if the operator load is less than 25 cases. If you do 2 cases in a year or 6 months cases, your complication will be more. So operator load less than 25 cases and the hospital volume less than 50 cases, that means the risk complication will increase. So who should do AF ablation? AF ablation should be done only in centers who have committed EP center, committed EP department. It is not a one-man show. It is a teamwork. You have to have perhaps more than one EP guy. You have to have proper trained technicians, proper EP lab. Otherwise, I think you will harm patients rather than benefiting these patients. Now coming on to how successful is the AF ablation? We talk about the AF ablation. Now when we talk about success of AF ablation, we mean that patient is in normal rhythm after 3 months of ablation. The first 3 months are considered maturation time. So AF can occur in the first 3 months. That is not considered as a failure. But if you have AF after 3 months, then it's a failure. So either success is you get a total AF free, or you may have to use drugs, small amount of drugs, like for example, flecainide or propafenone or maybe 100 milligrams of amiodarone. Even if with these drugs, patient is in normal rhythm, it is called success of AF ablation. So meta-analysis of various trials have shown that there was a 63% reduction in the risk of recurrent AF as compared to drug therapy with the radiofrequency ablation. RF ablation success is roughly 65 to 70% in paroxysmal AF in first ablation. If you do one ablation, at least in good centers, and it could go up to 85% in the second procedure. But that also is the value in good centers, the people who are trained to do AF ablation. If the centers that don't have experience, I think their success rate will be less and complications will be more. So the things are changing. 1998, we used to say, don't get into the car with strangers. 2008, we said, don't meet people from the internet alone. There may be a danger. But 2018, we order Ola and Uber without knowing who the guy is, who the owner is, and who the driver is. We feel safe. So I think the things are that more and more patients will benefit from AF ablation in specialized, dedicated centers. That's what the way forward. I think thank you very much for your kind attention. Now, there are some other non-pharmacology therapies. I don't want to spend too much of time. One is cardioversion. I think we have all talked. This is not a permanent solution, but many patients benefit from cardioversion. And what Vivek told you that many patients be repeated cardioversion, 7, 10 times even. They are helpful, particularly in heart failure. Surgeon isolates the left atrium. It ligates the left atrium because the most of the clots in the atrial fibrillation, 95% actually, they are in the left atrial appendage. The clots in the main body of the left atrium only in 5% of the patients. So if you can isolate the left atrium, you can prevent 95% of the stroke. Whether you do surgically or you do with the catheter intervention like left atrial occluder, the patients who have a high risk of bleeding, for example, who cannot take anticoagulation, left atrial occlusion is a good device, and many centers in India are doing that. And lastly, I think, which is important as far as atrial fibrillation is concerned, I think we need to think about prevention of atrial fibrillation. And one of the most common cause in India today is hypertension, untreated hypertension, which we need to look at. Obstructive sleep apnea is really neglected a lot. I don't know how many patients who order sleep study. First of all, they don't agree. If they agree, they don't use the BiPAP. So this is another reason that atrial fibrillation can be prevented by these methodologies. Lifestyle modification, of course, now it has become class 1 indication as far as the ACC guidelines are concerned. So all these things, they do matter in the prevention and treatment of atrial fibrillation. Thank you.
Sir, we will take question at the end of session.
Okay. Okay.
Thank you so much, sir, for such a wonderful presentation. And so there are so many ways to treat AF. So earlier in my MD days, we used to study rate versus rhythm control. It's almost equal. But now you can see so many strategies are there just to treat atrial fibrillation, to convert it to normal sinus rhythm. So we have a lot of strategies to treat atrial fibrillation, as sir mentioned. And the latest technology which was launched in India is cryoablation, which was launched recently, 2 to 3 months back. As sir rightly said, that we need to treat AF, but the most important thing is to treat it at an earlier stage, because AF actually begets AF, and it's a progressive disease. And that is why earlier treatment is important. Because if we will treat AF at a later stage, then not only the chances of success rate of the procedure will be less, complication rates will be high, and most of the time patient will land up in heart failure, will have a lot of progression of AF is associated with adverse clinical outcome, including a higher risk of heart failure, stroke, mortality, and cardiovascular hospitalization. That is why it's important to treat AF at an early stage. No doubt, huge prevalence of AF across the world, and the number of times patient will have episodes of paroxysmal AF. So then the procedure becomes more and more difficult since the LA gets remodeled, cardiac remodeling happens. So just that I have already discussed So catheter ablation as a rhythm control strategy, already discussed the guidelines, class 1 recommendation with symptomatic paroxysmal AF who are already on medications, but despite medications have recurrent episode. Two modalities of treatment as of now, radiofrequency ablation and cryoablation. So we all know about the 3D mapping procedure. It's not a new technique. So this is how I just showed the slide in the previous presentation. This is how we basically treat atrial fibrillation by radiofrequency ablation by isolating the 4 pulmonary veins. So in RFA, basically we are giving burn to the tissue between the junction of the pulmonary vein and the left atrium. So it's a difficult, it's a time-taking procedure because we have to go step by step at each and every point by catheter, and then we have to give burns to the tissue. It's a bit lengthy procedure, and sometimes there are gaps between these brown dots. So what is basically cryoablation? So if we talk about the studies, so a lot of studies have already been done which have shown that cryoablation is a good technique for AF patients. And recently, US FDA has also given approval for persistent AF treatment, cryoablation as a treatment strategy for persistent AF by virtue of this top persistent AF clinical trial. So I will not go into detail of these trials, but already it has been proven that cryoballoon ablation as a first-line rhythm control strategy has been an acceptable safety profile. Fire and ice trial already sir has discussed. And no. So basically, what is cryoablation? The point is, what is cryoablation? So this is basically, it's not a new procedure. So it's been, it has launched in India recently, but the experience is more than 10 years with the cryoablation. And the procedure is being done in more than 80 countries. A lot of patients have already been treated with this technique. So this is basically the console. This is, we call it as cryo console. And this is the cryoablation catheter. This is again a sheath. This is the mapping catheter. So these 4 things are required for cryoablation. So how this cryoablation works? So basically, this is the pulmonary vein. So this is the left superior, left inferior, and there is right superior and right inferior. So what we do, basically, this is a cryo balloon, and so we give cryo energy. So we give safe cryo energy, and cryo balloon, it removes heat from the tissue for a more durable method of pulmonary vein isolation. So in this technique, basically, we don't have to give dot by dot lesions to isolate the pulmonary vein from the left atrium. We just have to insert the balloon. We have to give cryo energy and then just take out the balloon. And this vein is done. So it takes, I think, 4 or 5 minutes to isolate one vein. So I won't go in detail, but all the system, this is how it's connected to the machine. And this is the balloon, this is the catheter, mapping catheter, balloon, and this is the basically cryo console. So just a short video how things work. So this is the mapping catheter. This is the ostium of the pulmonary vein. We have inserted this catheter in the pulmonary vein. And as sir mentioned about the pulmonary vein potential, we can see the pulmonary vein potential. And then this is the balloon. This is the balloon just at the ostium of the pulmonary vein and the left atrium junction. We inflate the balloon and oppose it properly at the ostium and the left atrium, give cryo energy, and wait for few seconds, few minutes, 2 minutes, 120 seconds, 180 seconds, or 240 seconds, depending on case. And then this vein will be isolated from the left atrium. So this is the cryo energy which is being given. And after that, this vein is isolated. So this white dots are basically the isolation which is, by which the cryoablation works. So just a comparison between the radiofrequency ablation and the cryoablation. So AF treatment is not new. 3D mapping and radiofrequency ablation, we are doing it in so many years. But the problem is these two things are different. So in radiofrequency ablation, we are burning tissue with point by point radiofrequency burns. And in cryoablation, we are freezing the tissue by the cryo balloon, and it gets, and all the vein, one vein will be isolated just at a go. So here we have to reach each and every point, and then we have to isolate the pulmonary vein. So problem with radiofrequency ablation was that it was technically very challenging, and there was a lot of times it was difficult to maintain the catheter stability. It was time consuming, especially in a busy lab. Plus, there was definitely more risk of complications. And as far as safety is concerned, then definitely cryoablation has reduced risk of complications, shorter learning curve, easy to reach the target area within short time, fewer repeat ablation. That is, success rate is relatively high as compared to the radiofrequency ablation. And more importantly, in our setup, it enables time for additional intervention procedure, I would say. So one more thing, that it preserves the extracellular matrix. So this is the radiofrequency burn, and this is the cryo lesion at 1 week. So we can see a very well demarcation between the burn area and the normal segment. So this is how these things work. So just to summarize, so it's simple, safe, fast, effective cryoablation, predictable and short procedure duration, and ablation creates ideal lesions that are wide, extended, and circumferential as compared to the radiofrequency ablation. Accurate, safe, efficacy, then fewer repeat ablations, short learning curve, easy to adopt, and it is all proven in the various studies that this is effective therapy to treat atrial fibrillation. So in the last, as sir mentioned, earlier treatment with catheter ablation has been shown to reduce atrial arrhythmia recurrence. And patient can definitely now be referred to cryoablation without the need of drug therapy failure. Thank you so much. So we can go to the next presentation, sir. So we will have discussion at the end of the session, sir. So I would like to invite Dr. Chitresh Chahar to present the cases on cryoablation.
Good evening, respected chairpersons, faculty. I'll be presenting a couple of cases which we have done and which are in our follow-up right now. So the first case was of a 64-year-old female, BMI of 26, known case of hypertension, recently diagnosed with mitral valve collapse in this age, then she had moderate mitral regurgitation, recently diagnosed with AF at the time of the diagnosis of mitral valve collapse, less than 3 months back. Normal EF with a history of prior heart failure hospitalization within the past 3 months. She presents to us now with the breathlessness in NYHE class 3. Medications for past 3 months, she has been on Arni 50 milligrams, furosemide 10 milligrams, spironolactone 25, amiodarone 200, and metoprolol 25 milligram, along with, of course, apixaban. So echo showed mitral valve collapse, moderate MR, normal EF, borderline LV enlargement, and normal LV dimension. So we evaluated the case for the better evaluation of MR. We did a TE. So I've included a single cine from the TE, which shows mitral valve collapse in a 3-chamber view along with moderate MR. And the LA was borderline enlarged in TT with a dimension in plaques of 38-39 millimeters. So borderline LA enlargement. So we explained to the patient, she has already been on GDMT, the best we can provide. She has a clinical profile of that of HFpEF with AF complicating the moderate MR and increasing her the pulmonary symptoms. So the patient is definitely not in the valvular replacement stage as of now, and she's on the best of GDMT which we can provide to her. So we explained to the patient regarding the benefits we could provide her from the cryoablation, the technique, the AF ablation technique. And explaining the risks and benefit, she agreed to underwent the procedure after, of course, the initial stabilization in our hospital. So she was on apixaban, the 5 milligram twice daily, which we stopped 12 hours prior to our procedure. We checked the T for the clot, so there was no clot in LA appendage. For the pre-procedural evaluations, she underwent CT pulmonary angiogram. So in which we checked basically for the structural, we plan our procedure. We looked the structural aspects and the pulmonary vein diameters. So we started our procedure under general anesthesia with the patient being on mechanical ventilators so as to complete the case without any haste in a comfortable way. So we plan our procedure with a TE guided puncture because we aim to get a lower and anterior puncture so as to comfortably achieve the cannulation of all the 4 pulmonary veins. So in the first view, which is the bicaval view, we check for the cranial and caudal. So in this view, basically we pull the catheter down towards the IVC, and simultaneously in the X-plane we look in the plex view, the short axis view at the aortic valve, and we try to be as anterior as possible, which obviously cannot be done on fluorogram. So after the T-guided puncture, we exchange with the Mullen's setup. We exchange it for the dedicated flexible catheter provided with the cryo balloon. We exchange it over an LA wire, or we can use even an Amplard stiff wire. So this is the basic setup. So we use to carry out the procedure safely. We use a phrenic nerve pacing with a CS lodged in the superior part of the subclavian vein, along with a temperature probe in the esophagus. And we basically monitor the compound motor action potentials from the phrenic pacing with a setup which consists of a ECG electrode placed 5 centimeter above the xiphoid process and a 16 centimeter along the right lower rib cage. So by this we can see the compound motor action potential of the diaphragm. The other ways to check for it is by palpation, and other way is to look directly in the fluorogram. So basically this is the anatomical overview. The esophageal injury mainly occurs, the most dreaded complication, that is of atrioesophageal fistula, mostly has been reported during the ablation of the left inferior pulmonary vein and the phrenic nerve. So this is the right lateral view of the heart. So this is the SVC, and this is the RA, RSPV, and this is RIPV. So the phrenic nerve transverses on the lateral side of the SVC, and it is mostly this complication of the phrenic nerve paralysis happens mostly during the RSPV, and when we are giving lesions deep into the vein. So for these two dreaded complications, we had our setup earlier. And so this is the setup Dr. Kush has already discussed. So basically a few points which I would like to raise is that this is the FlexCath, the dedicated flexible catheter, over which, through which we get a cryo balloon, which is cannulated into the pulmonary veins over the circular mapping catheter. So the temperature, so basically this is the injection port in the later half of the balloon, which injects the liquid nitrous oxide at the 8 ports, and the temperature probe which monitors the temperature is actually towards the back part of the balloon. So it is not at the tip. It provides us the temperature of the gaseous nitrous oxide, which is returning back to the machine. So we started with our procedure after full anticoagulation with an ACT of over 300, and we started it with LSPV. So this is the cine. We cannulated the LSPV with the circular mapping catheter. All the manipulation is done with the flexible, the 12 French sheath. The balloon and the cannulation is done with the manipulation of that catheter only, the FlexCath sheath. And after confirming that the occlusion is proper of that pulmonary vein, we proceed with the initial inflation of balloon, which happens at the 2 to 4 atmosphere, and we look for whether we are not deeper into the pulmonary vein. And after the confirmation that there is no indentation over the balloon, we go to the full. We get the freeze on, during which the pressure increases up to the 18 atmosphere of the pressure. So on starting the freeze at 1:31 minutes at 37 seconds. So these are the pulmonary venous potential, which we can see on the circular mapping catheter. And after at around less than 60 seconds, we see that the pulmonary venous potentials have abolished. So we have the time to, the isolation of the pulmonary vein was less than 60 seconds. So this is the first endpoint we try to achieve. And this is the cryo console report, which shows that the temperature reduced to -49 within 40 to 60 seconds of the initiation of the cryo procedure. And we maintain it for a fixed dose of 3 minutes or 180 seconds, after which the cryo, as we can see, the nadir temperature is also -49, after which we release the balloon. So a few things to keep in mind is that when the balloon temperature goes below 15 degrees centigrade, the balloon catheter sticks itself to the LA wall, the antral side of the pulmonary vein, and care is to be taken not to manipulate the catheter after that. And after 3 minutes or 180 seconds, we deflate the catheter, and the time taken to thaw, this is the time taken to thaw. After 15 degrees centigrade, the balloon removes itself from the wall, and at 20 degrees centigrade, the balloon deflates automatically. So this is the freeze time, 3 minutes, and this is the time to thaw. So these are the secondary endpoints. When the lower the nadir temperature, the better the pulmonary vein isolation. The more the time to thaw, the better the pulmonary vein isolation, and the quicker the temperature achieved to the nadir temperature, the better the pulmonary vein isolation in the follow-up. So then we proceeded with the left inferior pulmonary vein. So this was our obstruction of that, confirmation of the pulmonary vein ostium obstruction with the dye. And after this, we initiated the freeze. So this is basically the hockey stick maneuver in which we try to cannulate the left inferior pulmonary vein inferior branch in the LAO view, and we push the catheter, push the sheath so as to achieve a hockey stick-like appearance. So then we initiated the freeze at 1:46:50 seconds, and the time to isolation. So these are the pulmonary vein. The pulmonary vein potentials are not as good seen in the lower pulmonary veins, both the left and the right. So, but we were able to manage to see the pulmonary venous potential. So the isolation was achieved at less than 60 seconds, so which was our primary endpoint, which was met. So this is the cryo console, what the cryo console showed. So quick time to reach the nadir temperature. Then the nadir temperature is close to 40, which is our good endpoint. And lastly, the time to thaw, which is also very slow, taking more than 30 seconds, 30 to 40 seconds. So then we proceeded with the right superior pulmonary vein. So this is the RO view in which we have cannulated the left. We are quite deep inside the pulmonary vein. So what happens is at the initial inflation of 2 to 4 atmosphere, we look for the indentation. And if there is indentation, we slightly pull back our catheter and recheck with the dye, the radiopaque dye. So we initiated the freeze at 2 p.m., 4 minutes and 21 seconds. And the isolation, as you can see, that the isolation was achieved by less than 60 seconds. During the right inferior pulmonary vein, as the right superior and the right inferior pulmonary vein, we have to check for the compound motor action potential, which is achieved by the use of the phrenic nerve, the stimulation with the help of the decapolar catheter inserted in the superior vena cava. So basically, we initiate the phrenic nerve pacing when we achieve a temperature of -10 degrees centigrade. So you can see that by the time -10 degrees centigrade was achieved, at that time we started the phrenic nerve pacing. At that time, the pulmonary venous potentials were already isolated. The pulmonary veins was already isolated. So these are, we check for the compound motor action potentials. So this is a CMAP, this is a QRS, this is a CMAP, again QRS. So it is paced at a rate of 60 per minute. So this is, again, the time to reach the nadir is very fast. And then we keep it for 180 seconds. Then time to thaw is again very slow. So at the time so we check the CMAP at the start of the procedure until the 180 seconds. If the amplitude reduces by 30%, then we have to immediately stop the cryo balloon. So then we proceeded with the right inferior pulmonary vein, which is the toughest vein to cannulate and to properly give a circumferential lesion. However, we were not able to see the pulmonary venous potentials. So we basically relied on the temperature endpoint. So the nadir temperature -40 reached very fast, less than 60 seconds. Time to thaw also very slow, taking more than 30 to 40 seconds. Other strategy which we can use was to check for the exit, the block, while pacing from the achieved catheter, the central circular lumen mapping catheter. We could use that. So this is our timeline. We started the LSPV freeze from 1 p.m. 26 minutes, and we finished our procedure at 2 minutes, 2 p.m. 24. So close to one hour in all the 4 pulmonary vein isolation, and in and out time of around 1 hour and 45 minutes. So our patient, although she did not revert with all the 4 pulmonary vein isolation, so the patient was sedated, already on ventilator, and we cardioverted her with 100 joule of energy, and she fortunately reverted to the sinus rhythm at the end of the procedure. And she has been now in follow-up of around more than 1 month, and I'm happy to report that she is still in sinus rhythm and with quite improvement in her heart failure symptoms. So this was our first case. I don't think the time permits. I have another case. Should I go ahead?
Thank you very much. Thank you so much, Nitesh, for such a wonderful presentation. So I think it's open for discussion. Any question?
Dr. Clear, my first question is to you. Would you take age into consideration? Say it again. Age into consideration.
Yeah.
You say patient is 75 years old, is not interested, you cannot give anticoagulation. Would you straightway recommend left atrial appendage occlusion?
Yeah, I think if the patient is not willing to take anticoagulation, that is one of the indication to give the left atrial occlusion. This guy, Governor of California, Arnold, he had AF and he said, no, guys, I don't want to take this drugs. So Dr. Sabalkar, he did the left atrial occlusion of that guy, and it was very encouraging, and I felt very proud that this guy had come at TCT meeting, and in front of doctors from almost 100 countries, he said, this Indian guy did my procedure. It was a very kind of encouraging thing to see. Yeah, you're right, that people who don't want to take anticoagulation, left atrial occlusion is a good option.
And your cutoff line for cryoablation would be atrial fibrillation under 1 year or even more than that?
No, I didn't understand the question again.
Cryoablation for recent onset atrial fibrillation or even for chronic atrial fibrillation?
Yeah, don't see, that doesn't, the duration of AF doesn't matter when you use the cryo technology. It's one of the technologies. See, few things I want to say that cryoablation has not been proven to be superior than the standard ablation. That's number one. Number two, people should not go with the idea that it's a very simple technology. It's not a simple thing. Nothing is simple in this. Getting into the left atrium, that big sheath, then going into the veins, and particularly the right-sided veins, they are difficult to cannulate, and the particular right inferior vein is very difficult. In fact, one of my students, Dr. Sanjay Dikshit, he is the director of electrophysiology at Philadelphia University. So he said, we have left balloon actually. We don't use anymore. So there has not been a universal adoption of balloon, but yes, it certainly decreases the time. And there are many centers now use cryoablation as one of the modality in AF ablation. But in India at this time, it is a little bit expensive, but maybe with time it will become cheaper. But again, I will advise that people who are committed EP centers should use these technologies, not everybody.
Can I comment on this?
Yes.
Your first question, sir, as far as, because we have bought cryo, so we have made our standard guidelines. So we touch paroxysmal AF and long-standing persistent AF with reasonable LA size, not very dilated LA. But yes, long-standing persistent AF, that means anything more than 1 year of persistent AF we can take if the heart is structurally not very abnormal and LA is of reasonable size and it is easy to reach to the pulmonary veins. Second, sir, we have done both RF ablation and now cryoablation. Technique is simpler, definitely simpler, and it takes much less time. In 45 minutes, you go and you can come out ablating all the 4 pulmonary veins. And our right inferior pulmonary vein will always remain Achilles heel of electrophysiologists, but fortunately in all our cases, we reach to RIPV in one shot. And actually I am encouraged to do more and more AF ablation only after this technique. Being a director of a busy cath lab, we actually could not perform RF ablation, which people need now. And that's why we opted, actually the ease of procedure and time. That is why we opted, not due to superiority to RF. Nobody claims that it is superior to RF. It is non-inferior to RF, that is enough. But technique is simpler and complications in RF ablation, maybe yes, we were not that much frequent. So we did few cardiac tamponades also. Here we have to take care of very meticulously two things. One is most common complication of cryoablation is a phrenic nerve paralysis. So what we do is we keep the phrenic nerve paced and we see a amplitude potential of that contraction. We feel manually also at the amplitude of contraction. If we feel that the phrenic nerve is going slow, the diaphragmatic contraction are getting slow, we immediately stop that. And there is an objective measurement also of the action potential of phrenic nerve. So we do that also, and we keep an esophageal temperature probe inside the esophagus. The cutoff value is 28, maximum 25. Below that, if temperature goes, then only LA esophageal fistula will be formed. So if these two things are taken care of, cryoablation is largely safe, because as an Indian operators, we are very comfortable with septal punctures. I have seen you, sir, doing septal puncture in 30 seconds, 40 seconds. So that way we are at ease. So that's why we adopted this procedure, because of ease of doing it, less complications. But yes, it is expensive. There are a lot of people with good insurance nowadays. So at least those selective patient, because government probably will never adopt these kind of technology in their own policies. But yes, selected paying patients and insured patients, we can use it a very logical way. If I can brief our two cases which we did, sir, for the audience also. The first case, Chitresh went into too much technical thing. I'll just brief my two cases. Our first was a very young lady. Yeah. So our first case was a very young lady, like 38 years old, and very frequent AF. She says कि मैं रात को जागती हूँ और धक 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 होता रहता है, सुबह 4 बजे 2 क्लोनोट्रिल खा के नींद आती है. So she was that symptomatic, and she already used amiodarone and flecainide, and then we did ablation. And when we took her on table, she was in atrial fibrillation. So we thought we are doing our first case, so we should map the potentials of pulmonary vein. So we should cardiovert, because in AF that clarity is not there, because we are beginning this thing. So what we did, we tried cardioversion thrice, and all 3 cardioversions failed. Then we thought of continuing the ablation in AF, and while we were doing RSPV, it slowed down, and then and only atrial ectopics were left. And when we did LIPV, left inferior pulmonary vein, then it terminated. And after that, she never had AF. She has some atrial ectopic. So our plan was that after AF, PVI, if we notice atrial ectopic, we'll do radiofrequency ablation for atrial ectopic. But that was not shown there. But now she's having ectopics, but no AF later. Second case is more interesting. Second lady was around 60 years, and she had moderate mitral regurgitation. She came to me to see me from Delhi 3 months back, and she was in sinus rhythm. Reasonable, I said, no need of mitral valve surgery, you can do well, but there was history of paroxysmal AF. Next time she came in persistent AF, it was continuing for last 15-20 days, and she was in failure. Now I thought what to do. I asked our valve specialist also, Dr. Amit Charosia, to see. He said mitral regurgitation ज़्यादा नहीं है. तो हमने कहा कि अगर mitral regurgitation ज़्यादा नहीं है, तो then heart failure का reason is atrial fibrillation. Then we tried to convince that guy, the husband of son of that lady, that we want to do this, and he agreed because he had insurance. And we did AF ablation. She was in sinus rhythm when we started, and she remained in sinus rhythm. But then after that, she's now no more AF, and she's very happy. So she's out of congestive heart failure. Now, this very recent follow-up, I can't say that she is free of atrial fibrillation, But these are the typical clinical scenarios where we can best use it. And like heart failure, probably the atrial kick was important for her because of mitral regurgitation. And first lady was very symptomatic, very frequent, already took a lot of medication. So these were two indications.
One more thing in that. Elderly person, atrial fibrillation, heart failure. Which are the guys whom you would consider dual chamber pacing with AV node ablation?
Yes, sir. So before you came, we had a lot of discussions on this. So
I'll ask you later.
No. But it's very important question, sir. And so basically we were discussing that this is part of a rate control regime. When we think that AF is not being controlled, rate is also not being controlled, or with rate control with drugs, patient is still in atrial fibrillation. So we would like to do AV node ablation. But if patient is, as you say, in heart failure, if I do AV node ablation, my strategy would be to do a conduction system pacing, left bundle pacing or his bundle pacing. Left bundle pacing in this case, because we are doing AV node ablation, his bundle pacing is not that reliable long term. So left bundle pacing, I would like to suggest. And Dr. Claire wants to do a trial with AV node ablation and conduction system pacing.
You will be wiser in your next conference.
Thank you. Just for the query, do you have any cath data for both these patients? Or they had moderate mitral regurgitation. So do you have any cath data for these patients? Catheterization data, like left heart steady.
For these patients?
For both these patients, yeah. They had significant moderate mitral regurgitation. Do you have any data for this? We have echo finding of moderate MR, but
cath we didn't do.
We don't know the LV pressure and LV EDP. That's what I was more interested in.
One patient had moderate MR. The other one didn't have moderate MR.
Yeah, only the second patient had moderate MR with mitral valve prolapse.
Sir, post cryoablation patient recurrence rate of AF in this patient, sir?
70 to 80% success rate, 20 to 30% recurrence. It is equal to like radiofrequency ablation in good hands, but in less skilled hands, probably cryoablation would do better because it is a circumferential ablation. And in one shot, we have seen in 1.5 minutes, the whole pulmonary vein goes silent as Chitresh showed the picture. So,
after cryoablation, sir, how many months you advise antiarrhythmic or anticoagulant therapy in this patient, sir?
Interesting question. Anticoagulants, antiarrhythmic first. So as Dr. Claire said that after any ablation, whether it is cryo or whether it is RF ablation, 3 months is maturation period. And 3 months, we don't consider it a recurrence. And 3 months, we continue with antiarrhythmic. Whatever he or she was taking earlier, amiodarone or flecainide, or preferably flecainide if structurally normal heart, and we send them back. After 3 months, we reduce the dose and then we take it off. Anticoagulation is a tough question. If CHAD-VASc score is high, I would suggest that any ablation we should continue. If we want to stop, we have to give LA appendix occluder. Why? Because symptomatic recurrence we know, asymptomatic recurrence we don't know. So, but if we want to stop because of some reason, we should do frequent monitoring, periodical monitoring, maybe once in a quarter a Holter or an ELR, once in a quarter to rule out silent AF. That is not enough. I would still afraid of withdrawing the anticoagulation. Sir, cryoablation is costing 7.5 lakhs at my center. But there is one more center in North India which is charging 12.5. So that way we are one. Because this balloon itself is very expensive. So actually we are not charging much for the hospital. It is mostly the cost of the hardware. Maybe my CEO is looking at me, but that's the fact that this is the cost of hardware only. We are not charging much to the patient. Yes, sir.
Well, I think no doubt the cryo is a new armamentarian in AF ablation. And I I think the cost, to my mind, is irrelevant. I tell you why. We are discussing science here. We are not discussing cost. The same cryoablation will cost 50 lakhs in the United States, at least 50 to 60 lakhs. I think we are doing much cheaper in this country with the same technology, same effort, same cath lab. The Indian, I think, population should understand that we treat them with the best Western medicine at throwaway price. They don't understand. The thing which I would like to comment is that in long persistent AF, you know, my worry is always the atrial health. Unfortunately, there is no technology to tell before ablation that how that atrium is going to behave, whether it is going to get mechanical contraction again or not, because the cardiac MRI is not good enough so far to tell what the atrial cardiomyocyte, atrial tissue health. So when we do these patients, if you have a lot of scarring, then those patients are not very good. They have more recurrence. So it depends on the scar tissue in the atria. Sometimes there's a lot of scar in these patients and say gone atrium. So those patients will have high recurrence.
Yeah, I agree. LA size is a very crude method to see the health of LA.
We don't usually don't do ablation if the LA size is more than 5 centimeters.
Yes.
Our is 5, sometimes 5.2 maximum, because if the LA is more than that and the AF is more than 1 year or 1.5 years, then 50% recurrence will be there.
Yes.
The problem in India is patient कहता है सर मैंने इतने पैसे लगा दिए दोबारा कैसे हो गया? That's something they want a guarantee. Nobody can give guarantee to these patients.
So what is the variation in the pulmonary vein anatomy? Does it matter in the ablation, especially?
Yes, sir, it matters. Pulmonary vein, if generally the standard balloon size is enough for all pulmonary veins, but problem is when there is a very small pulmonary vein, very big pulmonary vein, or common pulmonary vein ostium. So most common anomaly is common pulmonary vein ostium. So in the same ostium, we'll try to do, instead of single ablation, we'll try to do 2 or 3 ablation with different orientations of the balloon, and we are sure that we cannot occlude like he showed in the, we inject a contrast and show that there is no leak back. That is not possible in common vein ostium. So we'll do 2 or 3 ablations with different orientations of balloon.
But do you think it should be known beforehand? So there is a role of
yeah,
CT,
so
CT,
it is our
CTs.
protocol to get a CT scan done 1 day before, and there is no, we don't have merging of CT scan with this any fluoro system, but we keep a film available there. And because we are not combining 3D with cryo, because it increases the cost by 1.5 to 2 lakhs. So we are doing it.
Thank you.
So we move for next thing. So you
All
keep
the
sitting.
speakers, Dr. K, Dr. Balkar, excellent, wonderful.
Thank you, sir. Thank you. Be here, sir, for last session, sir. I'll invite Dr. Rajiv Gupta, sir, to come here. Dr. Claire, sir. Dr. Vivek, आप आइए ऊपर आइए. We need you here. And Suresh Gupta, sir. Dr. Suresh Gupta, sir, please come. Sanjeev Roy, sir, is he here? Dr. S.M. Sharma, sir. Dr. Chandwani, sir. Sanjeev, you missed that previous session. Please come. Yeah, one more chair. So basically, we'll go quickly through the next session, and it is all about few cases and few real-world scenarios of atrial fibrillation patient. So we discussed very hi-fi things about ablation and everything, but for our clinicians, colleagues, it will be more useful to listen to this talk, because I have kept some clinical scenarios, and then we'll discuss. I'll take the opinion of our expert panel. So I'll right away start with a case, sir. 52-year-old male had palpitation last night while at meeting. ECG at nearby center shows atrial fibrillation. Present ECG, NSR and normal. BP is 130/80. Heart rate is 90 now, normal sinus rhythm. No history of hypertension, diabetes, coronary artery disease. No past history of palpitation. So how would we approach this case? Anyone would like to? So basically, patient looks like that patient first time had this.
First of all, I want to know that he was seen last night. Was he drinking or?
While at a meeting, maybe.
Because you should know that the alcohol, at least binge of alcohol can produce atrial fibrillation.
Yeah, holiday heart syndrome.
Yeah, that's what it is.
Yeah. So basically, last night he had AF, and now he has come to show. So
yeah. There are certain points which need to be probed more in the history here.
Yes.
So two very important things in AF symptomatology and evolution. One is BMI and abdominal obesity. So that is something which needs to be probed, and history of sleep apnea, which is also a very potent marker for recurrence of next events. Once you have seen all these things, then amongst the basic tests, I think all of them should actually undergo one echocardiogram to look for structural heart disease and look for the left atrial size. And then, because certain other parameters also determine the evolution, progression, and treatment. So the creatinine clearance and thyroid status, as well as CBC, these are the ones which are essential for full risk stratification of these patients.
Yeah, right. Very beautiful points taken. And reversible cause, rule out reversible cause, as Dr. Clare said first, that whether he was drinking alcohol or not. So that is one of the reversible causes of atrial fibrillation. So we have to rule out that and rule out structural heart disease. And then this patient echo was done, showing normal study. Now, what kind of treatment would you like to give this guy? He is young and he had first diagnosed, what we can say according to ACCHA, first diagnosed AF. That is a separate entity. So would you like to cover this person with NOAC, or you would like to give any antiarrhythmic here?
First of all, first AF, the diagnosis, if you look at epidemiology, they are probably at as much risk for future events as any other group of AF. So the treatment for them strictly depends on their Jawahar score, which for this person is, I think, 0 only. He's got nothing. So he gets no anticoagulation. And with one single episode of AF, I'm not going to give him even metoprolol on a regular basis.
Yes.
Probably SOS basis.
Yes.
I think he also needs a Holter test to be done, because you cannot rule out any asymptomatic episodes of AF in this particular patient, although he's very young.
Yep.
And I think sleep apnea is one of the very important causes of it. So
yes.
BMI is missing in the whole thing.
Yes.
We need to
So comorbidities are to be explored, and no need of prophylactic drugs in this case. And just we need to tell him that report again. But doing a Holter is a good idea, because there may be a lot of silent episodes. But one episode which he noted was symptomatic episode. So yeah, anything, Sanjeev?
Rather than Holter, ELR is a better option.
ELR.
7 to 10 days, because these episodes are very infrequent.
Yes.
So better to do ELR, which is frequently available.
Of course, yes. ELR has more yield than Holter.
Yeah, but I think there are no kind of real guidelines that what should be done.
Yes.
But if you're talking about common sense, first of all, what Rajiv told was very good in a way that this was first symptomatic episode. He may have asymptomatic episodes also, but practically speaking, if the heart is normal, his BP is normal, I wouldn't go further, to be honest with you. I won't go too much further. I will just tell him if he has symptoms anytime, he should report an ECG.
Yes.
So whether you
But
do-
here, if Chatsworth's score was high,
Then
we would have used NOAC.
Right.
Even after one episode, we would have used NOAC. That is the message.
Yeah, the Jawahar is practically, I agree with Vivek that no anticoagulants.
Yes, yes, yes. So after 3 years, this.
Yeah, I think
Beautiful point.
It's a very relevant question. The smart watches are very useful, and I think they are going to come in a big way to, in rhythmology, all these devices are becoming more and more important. And ultimately, I think the Holter and shoulder this will go away. You will monitor, you can record the ECG on these devices. So it is important.
Yes, Apple Watch is very sensitive for atrial fibrillation.
It is approved nowadays.
Yes, it is approved by FDA for AF monitoring. And there was a discussion in the evening that what about asymptomatic episode? Because when patient will check his rhythm when he is symptomatic. But random checking, regular periodic checking also screens atrial fibrillation, silent asymptomatic AF episodes.
Such a patient, there's another thing is that the day he came to you, his BP was normal. But let's say on an echo, you should look very, very closely for any LV hypertrophy. Number one. Number two, this patient needs BP monitoring for some time at least.
Exactly.
Because he may have hypertension that day, you may miss it.
Yes, hypertension is probably the most common reason for non-valvular AF in India. And that's why this lone AF thing is going now, because most of them, they have some etiology like obstructive sleep apnea, like obesity, like even maybe diabetes, hypertension. These are the etiologies for atrial fibrillation. So no more this lone AF thing should be used. And
yes, the thing is the lone AF, why we call it lone AF? Because we still don't have a real technology to say that heart is totally normal.
Yes.
We have gone to the point of cardiac MRI. But maybe there are still more technology to come, like for example, atrium, we don't know whether it's normal or not. So normal is so-called normal, it's really not normal.
Yes.
I slightly disagree here for monitoring of AF in this patient. There are two reasons. One is younger patients with paroxysmal AF are mostly symptomatic. They don't have asymptomatic.
Okay.
Let us assume that suppose you did a Holter and you found a 3-minute or a 40-second asymptomatic episode in him. How would it change your Marriot?
Yeah, because Chadwick score is less, so it won't change your...
So there are no
exactly.
symptoms to treat.
Exactly.
The other point I want to make here is I would like to temper the enthusiasm for aggressive screening for AF for two reasons. Rather, two trials. So one trial which came out last year was called the SPEED, I think it was called Stop AF. SPEED Stop AF trial. And the other was Vital AF. So these were both randomized controlled trials, and both of them screened very aggressively for AF, which is good. But when they treated that AF, not much significant difference from the routine conventional treatment, symptom-guided AF detection was found. So screening is very good for high-risk patients, but as a routine screening measure, probably does not.
Society of European Heart Rhythm Society, they recommend some kind of screening after the age of 65 for every patient.
Yes.
And
So,
that screening has to be a little more vigorous after 70.
yeah, I think dealing with asymptomatic AF is all about preventing the stroke. So if risk of stroke is high, then this all is worth. If risk of stroke is low, then if it is there, we don't bother much. So that was a good point. So same patient after 3 years now, he is a non-case of hypertension. He is on medication, metoprolol and telmisartan. He had palpitation and breathlessness for last 2 hours. No past history of palpitations, and heart rate is 155, irregular, BP is also high, he's conscious oriented, AF with fast ventricular rate, ST depression in precordial leads, TROP-T marginally high, echo is still normal, and no valvular disease. So same patient after 3 years, now he's again, now we can say paroxysmal AF, and this is the scenario. So how to proceed and what to do.
I think this patient now, you have to terminate the acute episode.
Yeah.
With whatever, whether it is amiodarone or cardiovascular, but a good exercise test is needed to do a lot of coronary artery because it's hypertension. And now if he has developed the second episode, now I'll put him on metoprolol. I'll keep him beta blocker. Not go beyond that, just beta blocker. and I look for this patient needs some kind of monitoring, whether he has got asymptomatic episode of AF or not. Again, with the idea whether anticoagulation are needed.
Yeah, but is this the time to think of rhythm control strategy now? Because you were only saying that earlier the better. So now, once he has symptomatic repeated episode of AF, I'm not saying about ablation yet,
right,
but rhythm control strategy should be obtained now.
See, you converted him with the ammo or with the cardioversion, and this is the second episode. This is after 3 years. 3 years apart, this is second episode. Maybe I'll wait for one episode more.
Yes, that's why we were telling that it is an individualized care pathway. So actually,
it also depends on the patient's wish. What he wants.
Yeah, exactly.
You should offer him.
Exactly.
Offer him the ablation.
Yes.
But most of the Indian patients will not agree at this stage.
Yeah. So he's 55
I would actually make sure that he wasn't at another meeting again. So that would be the first one.
Yeah.
And one point here for the residents, if they are here, I would like to make is IV amiodarone initially works only on the AV node. So it is a AV nodal blocking agent when given intravenously as a bolus for treatment of AF. Surprisingly, if you look over 24 hours, the results of amiodarone cardioversion are not pretty much higher than even spontaneous cardioversion. So that is why all these drugs like ibutylide, vernaculant were given, because emergency care in Western countries is very expensive on an hourly basis. So if you look at time-wise, then amiodarone, if you're looking at a horizon of less than 24 hours, it's not a really...
So you would have preferred a cardioversion here?
So cardioversion has always been my first choice, especially because I know that it's 2 hours only. So, but it may not be of somebody else. I mean,
No, I think in he comes to the emergency, I will give him flecainide 300 milligrams.
Yeah,
right.
That I would again agree, because within 1 hour probably.
Yeah, but generally it's not a trend for doing chemical cardioversion with flecainide, because it's, yes, in emergency you can do that, and but still I think preference would be abutylide, electrical cardioversion, and then amiodarone.
So if you go back one slide, he's got ST depression or elevation, what was. So I think hypotension, angina, or ischemia, if you would say here, you don't know the coronaries at that point. These are all kind of indications for elective cardioversion.
Yes, I agree with you. This is a candidate for electrical cardioversion. Immediate relief should be given. Yes. And then now maintenance therapy. Oh, first talk about stroke. I mean, he's 55 now. He's hypertensive also. So
yes. So CHATS score of 1 calls for individualized treatment. And as I think Dr. Shomu or somebody else showed that slide, the CHATS score is not the only score available. There are multiple scores available besides CHATS, because if you are at a borderline state, then you need to refine the risk further. So biomarkers, OSA, things like those, they can be used to refine your stratification. And then it needs to be a mutual decision between you and the patient. With clean coronaries and probably if he hasn't got significant LVH, I would not anticoagulate him at present. But I would probably give him flecainide now, because either as a pill in the pocket or as a regular therapy, because this episode was kind of semi-emergency.
So I'll ask Dr. Suresh Gupta, sir, are you predicting a stroke in this particular guy having AF?
It depends on the Chadwick vascular score and Hess plate score. If the Chadwick vascular score is high, more than 1, then obviously one should start anticoagulation. Because each patient, they carry a high risk of getting stroke.
Okay. So he was sent back on amiodarone, beta blocker, ARB, and rivaroxaban 20 milligram. So he comes again with AF now. He's all. So he's now having again symptomatic, having breathlessness, chest bilateral cramps, taking all medication regularly. Added thyroxine recently for raised TSH. So now, I wanted to come to that point. Yes. So now it is a consensus that he needs ablation.
I would be worried right now as to why is he wearing breathlessness for a 55-year-old male. You know, this is HFpEF, really. So,
no, AF itself, you know.
During AF episode. During AF episode.
Correct. Sir, yes, but there are traps also. So this is HFpEF. This is what I'm saying.
This is HFpEF, yes,
ADHF.
yes.
So one has to see whether he has got OSA, whether he's got significant LVH because of hypertension.
Exactly.
So those things you need to protect.
So there is a clear message in this statement that any patient who would have concentric LV hypertrophy, then atrial kick becomes more important, and atrial fibrillation precipitates HFpEF and episode of acute LVF. So in many, this is a message for residents also, that if patient presents with pulmonary edema kind of symptoms and you refer them for echocardiography, he comes back with a normal echocardiography and concentric LVH. Don't rule out heart failure. It could be heart failure with preserved ejection fraction, and AF is one of the most common precipitating factors for HFpEF. Yeah.
So would you
this is
recommend a
exactly-
pro-BNP test?
Yes, yes. So pro-BNP test definitely you would like to do because if he is having HFpEF, then it will be maybe marginally high.
With raised PSH, would you consider stopping now amide?
Yes, so that is one indication that he is having side effects of the drugs and having AF again. Yeah. So either we change, now the options are either we change the drug and send him back on flecainide if he doesn't agree for ablation. But if he agrees for ablation, we'll do the ablation, and then I'll talk to him about what he wants. If he can afford, maybe a cryoablation.
The point for residents to remember is that after any kind of cardioversion, pharmacological or electrical, for 3 to 4 weeks, even if the CHATS score is 0, you still need to give anticoagulation.
Yes, yes. And if this patient now he tells that I'm having palpitation for last 2 hours, if the duration was long or the duration was not known, then what we would do? If he has taken the anticoagulation religiously in last few weeks at least, we can go for the cardioversion straight away. If he hasn't taken anticoagulation religiously, intermittently, drug adherence was not good, then we would like to do a transesophageal echocardiography in the emergency itself and then rule out LA clot and then do the cardioversion. Yeah. So duration is very important when we are deciding about. So electrical cardioversion done, advised RF ablation. He didn't go under RF ablation. He was sent back on flecainide this time, and NOACs were continued. And then 6 months later, again atrial fibrillation. अब तो करवा ही लेगा सर शायद. Okay. Yeah. So ECG again AF, and in ECG done 10 days before also shows AF. So what category it is from this table? Now what? Persistent AF. Yes, absolutely. So I think today's AF summit is successful. So this is persistent AF because more than 7 days now he is having atrial fibrillation. So echo is still normal. AF reports by cardioversion. Now this time transesophageal echocardio was done because of irregular history of NOACs intake, and then RF ablation was done. I think I have not written here. Okay. Yeah, so RF ablation was done here, and he is asymptomatic. Now amidron was stopped after 3 months after ablation. So now can we stop NOAC? Again the same question which I answered. So would you like to stop if you see no AF at 3 months?
Well, I won't stop after 3 months. I would monitor him maybe at least 1 year to really have the courage to stop them. But as I was talking, this is the ideal patient for ablation. Near normal heart, LA size near normal, little bit enlarged, and hopefully no CAD, only after normal. He had repeated progesterone AF. This patient will good result. And in a good ablation with the patience of mind, I think you can get 80% success rate in this kind with one ablation.
Thank you. So any other comment? And I had some more cases, but I think we'll finish because some very good singers are waiting for this stage. So, yeah. Now it is the meeting time.
So
Yes,
one
sir.
last question. One
Yes, sir.
question I want to ask you. As warfarin versus NOAX, so which will you prefer?
NOAX anyway.
I will prefer NOAX, but I think there are still a lot of people who
There's
prefer.
no doubt. I think NOAX are better than the vitamin K antagonists. And there are, now it's a European heart recommendation that NOAX should be preferred over.
I think only indication here in this case would be affordability. But then, measuring PTINR also costs.
It's a class 1A indication, and all these NOACs are now off patent and are very economical. Everyone can afford it.
Yes.
NOACs is the first choice.
Yeah.
It's particularly cheap in India.
Yes.
So,
Yes, not so.
so then, I mean, it's I think if you're taking PTINR, possible bleeds and all that, then I think rivaroxaban probably will make even for people who are on the borderline. Otherwise, so that कुछ भी नहीं है पैसे तो फिर तो warfarin पे जाएगा.
So, what is the status of NOAX in patients with atrial fibrillation with valvular disease and mechanical valves?
Patient with valvular heart disease. Valvular heart disease, one of the speakers gave a definition that moderate to severe mitral stenosis plus any artificial valve.
Mechanical, sir, mechanical.
Yeah, any
bioprosthetic.
Not mechanical. Any metallic valve, these patients have to be given vitamin K antagonist. No.
I think there are a couple of trials going on. One is the Invectus, which is doing on mitral rheumatic heart disease for moderate MS and atrial fibrillation. And I think you are part of that. Yeah. And the second one, there are a couple of trials also going on metallic valve prosthesis. The first trial, this was done in Canada, which failed, and there were lots of problems in that. That failed miserably. I agree with you. But I think there are still trials going on NOAX on mechanical prosthesis. We are still waiting for the results. Maybe in a couple of years, we'll have something there. But for now, I think it's all vitamin K antagonists in metallic valve prosthesis.
So final remark by my teacher and mentor, Dr. Madhok, and then we conclude.
One very important point was that such patients, they routinely come to all hospitals. In सबका ना उम्र वही रहती है. Their age never changes because it's always copied to the previous.
Yeah.
So the age never changes, and so you also forget. But their chat size will keep on changing. That is a very important point which people forget. People do it again and again.
I think Jayendra, thank everybody, all the speakers, and you have made a wonderful program. Your singers are waiting. We call it a day.
Thank you, sir. Thank you. So just to conclude, I'll invite Dr. Manju Sharma, madam, who is MD and co-chairperson of ESCC. It's about her vision for the new technologies. She's so passionate about bringing new things to ESCC directly from Mount Sinai that we are actually fortunate to work in this institute. So I'll invite.
Wow, good evening. It looks so good that our young coming stars are learning from masters how to deal cardiology. I know last so many years we see, diseases are going so high, and young patients actually, middle age or, senior citizens, I understand, they have so many comorbid conditions, they are symptomatic. But young people, most of the time, they are asymptomatic. And I think this is the time that we teach our young generation to go for their wellness checkup, which is very important. And then, of course, once there's a diagnosis, and then I think it's better to leave on master's hand and guide them. Yes, technology plays a very major role in this. And I know, so many years, if you see, there was a time when angioplasty was just a beginning. Now it has surpasses everything now. You can do any kind of, triple vessel, double vessel. It's just a kind of beginning processes, and everybody is getting expert. Then secondly, start as a structural heart. You people are doing TAVR. Now you see EP, they are also doing excellent job. And I'm very happy that Dr. Makar is always a good student. I think he's always very charming to learn new things, new technology for his growth and the growth of the society's well-being actually, and this, which is very important. And myself and Dr. Sharma, we always encourage our doctors to learn more and more and share the knowledge with the young generation, those who will be coming and sitting on the driving seat. And it's our duty to encourage them, teach them the beauty of care, healthcare, and humanity. But the last thing I'll always go with Dr. Claire said, cost. I know cost is always high in the beginning, but as volume increases, costs are always taken care. It's not a big issue, but the important is therapy available and how we can approach clinically and who's the right candidate. Are we picking up choice of the patient? Is it good? And what result we are going to see? And that is very important. Case selection is very important. If your patient is young, go for aggressive treatment. If patient is old, that is all what cardiologists think in their field. But yes, my job is to stand behind them for each and every new technology coming, no matter whatever is the cost. But yes, we will manage it slowly, and good luck, and keep up our young doctors. And I'll encourage Dr. Makar, keep on teaching these young stars. Good luck.
So soon we'll organize the annual Jaipur Heart Rhythm Summit. So we'll expose you to more arrhythmias other than atrial fibrillation also. Thank you, Manjuman, for your kind words. And this is the time to thank all these stalwarts who are sitting here to come all the way and bless this occasion. And it's time to thank Dr. Kush. Doesn't need any thank. He just need a big round of applause for all this organization, because now I leave on him. I hardly personally called anyone, and still we are having a good gathering here. So kudos to you. He is the upcoming hero. मैं बोलता हूँ मेरा आगे उत्तराधिकारी जिसको बोलते हैं ना, मेरा उत्तराधिकारी जो है वो ये है, and we'll be together always. So wonderful, and all these trade partners behind, thank you very much for every effort made by you and our beautiful event team. Thank you very much. Big round of applause for them. एक बार भी कहीं आवाज नहीं रुकी और कोई online and offline, everything went very smooth. And our marketing team, our management, and of course my wife, Dr. Manmeet, who bears with me every day till 11 or 12. Thank you very much, everyone, especially the audience, our senior physicians who left their practice and came here in the afternoon, and our young students, very happy to see you here. And some of them were discussing very good things with me, and we are always available. ESCC hospital is always available for anybody of you. After you finish your degree, you want to have some kind of exposure as a resident, whatever we can do for you. And these kind of academic activities definitely will continue with support of everyone. Thanks everyone. If I have left anybody or any group or any name, my marketing team is always there with me. And these guys work day and night very hard to make these occasions success. And we have done once more. Thank you very much, everyone. Thanks a lot. And I invite you for dinner, and trust me, we have very good artists today to perform here. So don't go anywhere, just pick up your glass and come back. Thank you so much.